Good morning, ladies and gentlemen. This is Ria. I work in operations department for AIG Hospitals. So I'll be the another host for the day. So I would like to invite Dr. Deepa Nair, Associate Professor in Head and Neck Surgery, TMH Mumbai, for surgical consideration of maxillectomy. So, ma'am, can you come on the stage and take over?
Good morning. Thank you, Dr. Sridhar, Dr. Varun, and the entire team at AIG for inviting me for this meeting. The topic I've been allotted is to talk about the surgical considerations in maxillectomy. So I'm going to try and keep it brief. We'll talk a bit about how maxilla is basically one of the most anatomic surgeries. It is not very frequently done, and that's the reason why it seems like a big challenge. Yes, it is not an easy surgery, and especially you cannot learn it by assisting alone. I think your skill set for maxillectomy improves the more you do it, because it's a surgery where only the operating surgeon actually knows what they are doing there, especially for the last steps. So this is how I plan to go about the meeting. So just a few points about the maxilla. All of us know about the anatomy of the maxilla. I'm not really going to talk about the basic things of the anatomy. Couple of points which we need to be very careful and cognizant about, not just during the surgery, but also while we are looking at the preoperative scans of the patient, is the involvement of these particular areas. We're looking at any disease which is creeping up along the ethmoids, because your plan of the cuts of the maxilla changes. You want to look at the involvement of the orbit very carefully. You need to look at this area that is behind the maxilla, the pterygomaxillary fissure and the pterygopalatine fossa, for any involvement of disease. Erosion of the pterygoid plates is something which you need to be very cognizant about, because that, especially for squamous carcinomas, will change your entire plan of treatment. It sometimes may even a higher involvement of the pterygoid base may make your surgery plan non-surgical in these cases. And another couple of points which you need to remember is the position of the floor of the anterior cranial fossa. This is not something which we look at as head neck surgeons very commonly. As an endoscopic surgeon, we look at it, but as a head neck surgeon, we don't pay attention to it. But it's important, especially for maxillectomies, because the level of the floor of the anterior cranial fossa is around here, and generally your cut or at the frontoethmoidal suture will be around in the same area. So if you have a very low, what we call a Kiros 3 classification endoscopically, you may end up injuring the cribriform plate when you're just putting your osteotomy out there. So this is something again which you need to look during the surgery. And of course, you have to be very cognizant at what is the level of your posterior ethmoidal artery, because you know that the posterior ethmoidal artery is going to lead closer to your optic nerve. So again, placement of the posterior cuts is going to be important at these places. The challenge for us for surgery is this space, the small space which is called the pterygopalatine fossa and the pterygomaxillary fissure. Now, why is it so important, and why do we keep harping about it? Because this small area contains a pterygopalatine ganglion, which you can see here. Now, this pterygopalatine ganglion gets innervation from the Vidian nerve, which again is a branch of which is formed by the sympathetic plexus around the carotid artery and the greater superficial petrosal nerve. There are twigs which come down from the maxillary nerve. So any disease in this area, especially squamous cell carcinoma, has a potential to spread along these areas. You may have disease spreading along the Vidian nerve to the petrous apex. You may have disease entering the orbit. You may have disease escaping into the infratemporal fossa. So it's very important to visualize these areas. And on scans, this is what you are going to look at specifically for all patients. You look at this black line which is there behind the posterior wall of maxilla in front of the pterygoid base. This is your pterygomaxillary fissure. Ideally, they should be on the same size on both sides. It should be filled black, that is filled with fat. Any soft tissue or enhancement in this area is something which you have to be worried about. This again is how you are going to look at it on a T2 weighted image on the MRI. You're going to see a fat filled, brightly enhancing area on the T2, and this is a sagittal view of the same. So these are a couple of things which you have to pay attention to during the anatomy. Now, Ongram's line, all of us have learned about Ongram's line, dividing the maxilla into a suprastructure and infrastructure. But rather than surgically using it, we mostly use it for prognostic factors. Everyone knows that any tumors which are above the Ongram's line involving the suprastructure of the maxilla will have poor prognosis. So surgically, I think all of us have started using Spiro's classification, and Spiro's classification called it as limited maxillectomy when only one wall of the maxillary antrum was removed, subtotal maxillectomy where at least two walls of the maxilla were removed, including the alveolar process, and all your infrastructure, orbital plate preserving maxillectomy, all of these come under a subtotal maxillectomy, and a total maxillectomy where there's complete resection of the maxilla. What are the preoperative considerations? We've talked about imaging. I would urge you all to, for such cases where you are going to plan a maxillectomy for these patients, whether it's an infrastructure, subtotal, or a total maxillectomy, to get a combination of a CT scan and an MRI in case all these cases. Yes, CT scan read by a good radiologist will have a fairly good sensitivity and specificity, but MRI just gives you that additional information, especially when you're looking at involvement of the orbital muscles, whether there's extraconal or intraconal involvement, whether there's perineural spread along the pterygopalpine fossa, along the Vidian nerve, along the foramen retrendum, which sometimes may be difficult to identify on the CT scan. You have to plan your reconstruction when you're planning your surgery. So this is something very important. This is not reconstruction of the maxilla cannot be a on the go that on table dekh lenge kya karna hai. You have to have a clear-cut plan for it, because you need all your colleagues along with you during this surgery. You need to plan and ideally always include your dental and prosthetic department as well as your reconstructive surgeons for this planning. You may, we'll talk about reconstruction later. You would also want a good dental preparation for these patients, and this is not just scaling of the teeth, but also taking good preoperative impressions of the dental dentition of the patient. Even if you're planning to do a fibular reconstruction, it may help in your prosthetic rehabilitation later on. And ophthalmologic evaluation, especially if you're going to do a subtotal or a total maxillectomy, is of paramount importance. There is a chance of injuring the orbit. You need to be sure that the patient's vision is normal, that they have no diplopia or any other issues before you start the treatment. Now, these are a couple of cases which I wanted to show you, again emphasizing the fact about looking and reading your preoperative scans. If you look on the face of it, the scan looks fairly okay, innocuous, but when you start looking at it very closely, you see a diffuse thickening compared to the opposite side. Again, talking about the fat-filled space, here there's a diffuse thickening here, and when you give a contrast, look at the brilliant enhancement. This is gross perineural spread in this patient. So always complete your scans with post-contrast. Don't accept anything less than a post-contrast CT and MRI. Now, there are many incisions which have been described to access the maxilla and ethmoids. As ENTs, most of us have done the lateral rhinotomy frequently. The Wegeber-Ferguson is the most common incision which is applied to access the maxilla when you're doing a total maxillectomy. But you can use a Lynch incision. The subciliary extension gives you good access to the zygoma. And of course, a facial degloving approach can be also applied. I have moved more and more to the transconjunctival approach for this lateral excision to avoid, and we'll talk about it in some time. Now, talking about incisions again, this is the most common incision which we were taught initially, is to just put it in the nasolabial groove, but these heal very poorly. The cosmetic outcomes are not so good. And that is because there's something called shadow areas of the face. When you look at a person, the first thing what you see is the dorsum of the nose and the nasal tip. The nasolabial groove is also a very prominent feature when you look at a person in light. However, lateral to the dorsal tip, these are the shadow area of the face. The perialar area is also in the shadow area of face. So if you use the concept of facial subunits, where these principles are used by aesthetic surgeons, and the face is divided into different subunits depending on the shadow areas, lines of tension, etc. So by placing your scars in these shadow areas and in using the principle of facial subunits, you can actually have very good hidden scars. For example, in a patient who requires a lateral rhinotomy, you can move the scar along rather than from the nasolabial groove, take it somewhere midline between the dorsum and the nasolabial groove in the shadow area, curve around the ala, go inside the nose, floor of the nose, so that that part of the scar is again hidden. If the patient has a very prominent philtrum, then you can take it along the philtrum. But for people who have flat philtrums, it's better to take a midline cut. I've talked about moving to a transconjunctival incision, and that's not just for cosmesis, it's also for function. When you take a transconjunctival incision, the whole orbicularis oculi is preserved without cutting it. More importantly, when you take even a subciliary incision, or if you place it in the most prominent crease under the eyelid and the patients are radiated, post-operative, the patients have a lot of edema in that area because of the altered lymphatic drainage, and patients do poorly. I have moved to doing transconjunctival incisions wherever possible, and we've had fairly good access and good cosmetic outcomes in these patients. But don't forget that you have to tailor the incision according to the involvement. If there's skin involvement, always account for that and modify your incision accordingly. Now, maxillectomy is a very anatomic surgery. There are 5 classic osteotomies described for it, and I would urge you all to read this paper by Johann Fagan. It's a very beautiful open access paper on the maxillectomy. All the steps of the surgery, the surgical anatomy is given very well in this. I borrowed these pictures from that paper. So the classical 5 osteotomies which are described are: 1, where you will have the zygomatic cut, which continues into the floor of the orbit. The frontonasal process of the maxilla is the second cut. The third cut will be along the anterior midline, or placing it according to the extent of the defect which you need to do. The palatal cut. And last but not the least is the pterygomaxillary disjunction, which is done with a curved osteotomy. So these are the 5 main osteotomies in any total maxillectomy. And if you are able to place these properly, your specimen comes out very well. This is a small video of a total maxillectomy with an ITF clearance done. This patient was a 19-year-old female who's had an osteosarcoma. On the initial biopsy, it was a sarcoma with osteochondrite differentiation. If you see here, the lesion was involving the whole maxillary sinus and with some involvement of the infratemporal fossa. We've talked about the osteotomies already planned. Now this is again the incision. This was incision taken in the skin crease as described, and we are just elevating it. Open up the pyriform aperture properly. If you have disease in the nasal cavity, you have to be careful that you take margins on this tissue near the inferior turbinate. You have to be cognizant of whether the septum is involved and resect that as well. Once you take the facial cuts, that opens up your field properly. Again, depending on whether the anterior wall of the maxilla is eroded or not, you need to continue your sublabial incision. You have to account for involvement of the gingivobuccal sulcus. This is a slightly older video. So this is how we used to place the incision previously in the most prominent skin crease of the patient. While raising this flap, the most common bleeder out here is the angular vein. It can be very troublesome. So please take special attention to cauterize it. When you're raising these flaps, be careful. Do a good hydrodissection and elevate it gently. The flaps can become very thin. You may buttonhole the flap in such cases, so be careful when you're elevating it. Keep adequate soft tissue on the anterior wall of maxilla, especially for squamous carcinomas or when there's anterior wall erosion. And raise the flap adequately laterally so that you can get full access to the lateral component or to the zygoma as necessary. In this case, we were going to take some part of the zygoma, and hence our flap has been opened up with a Diffenbach's extension. Here we are releasing the masseter. I always release the anterior fibers of the masseter for 2 reasons. One, it gives me good access to the coronoid process to do a coronoidectomy. And secondly, it gives me good access to the pterygomaxillary area to do my disjunction later on. So the release of the masseter, then now I'm releasing the temporalis in preparation for the coronoidectomy. This coronoidectomy is important because patients do develop post-op trismus, especially if you have done an ITF clearance. Releasing the temporalis muscle, which is the main retractor of the jaw, will reduce this incidence of post-operative trismus in patients. So once I've released this temporalis muscle properly and exposed the coronoid process, we remove the tip of the coronoid. Here I am using a piezoelectric saw. So you can see it is the piezoelectric is a slightly slow instrument, but it gives you very precise cuts. So my preference is for some cases of maxillectomy to use this saw, especially for the orbital cuts and finer cuts. For the bigger cuts like the palatal cut, you can use a regular reciprocating saw. Once the coronoidectomy is done, you get good access to the posterior part, posterior maxillary wall and the infratemporal fossa. At this point of time, you should make an attempt to identify by palpation or by visualization the maxillary artery and ligate it. That helps reduce and devascularize the tumor. Once the bone, soft tissue elevation is done, then the bony cut started. This is a cut, the osteotomy through the zygoma. When I take the floor of orbit cuts, I always attempt to start from posterior to anterior, and here I'm again using the piezoelectric saw and connecting this cut with the zygomatic cut. You have to have good elevation of the periorbita and be sure that you don't damage the orbital contents when you're doing these cuts. The next cut is the frontonasal suture line, which I've cut here. And here I'm also doing a simultaneous ethmoidal clearance, being careful that I do not cause any CSF leak when I'm clearing this. Then I place my palatal osteotomy. In this case, we had divided it in the midline because the lesion was not crossing the midline, but sometimes you may have to do it. And the last but not the least is your pterygoid disjunction. Since there was some amount of disease in the infratemporal fossa, we did a separate clearance. It was not a squamous carcinoma and it was just bulging into the infratemporal fossa. However, we cleared the whole tissue around the foramen ovale along the mandibular nerve to be sure that our soft tissue margins there were negative. This is the maxillary nerve in the foramen rotundum. And we drilled out the base of the pterygoids to have a good clearance in that area. Here you can see the Vidian canal with the Vidian nerve. That's the defect at the end of the surgery. So at the end of the surgery, if you're doing a maxillectomy like this, these are the things you expect to identify and see. This is the nasopharynx out here. Here you can see this is the Vidian canal, this is the foramen rotundum, this is the sphenoid sinus out here. That's the orbit which is retracted, and that's your infratemporal fossa. So all of this clearance should be done completely. There are things you have to be very careful about when you're doing this, surgery, specifically hemorrhage. Maxillectomy can be there can be torrential hemorrhage because generally your vasculature is posterior to the tumor. It is very difficult to identify and visualize it, but that's why you should try and preemptively devascularize the tumor by ligating the maxillary artery. You may have some bleed from the pterygoid plexus, especially if you do an infratemporal fossa clearance, and from the foramen ovale. CSF leak is a risk, and place your osteotomies very carefully and mindfully, especially when you're going superiorly. Avoid injury to the ICA, and this can happen especially when you're doing your pterygomaxillary disjunction. So one trick what I have changed my practice in these cases is, rather than the curved osteotome from inferior to superior, I try and place it superior to inferior after doing the cuts in the orbit, slightly taking the floor down, and then I do the disjunction by placing the curved osteotome beyond the orbital cuts, so that my trajectory of the cut goes from superior to inferior rather than inferior to superior, which can pass through the ICA and cause an injury to the ICA. Two important things which we should remember is that these patients, we are going to cut the nasolacrimal duct. So we should marsupialize the nasolacrimal sac. Otherwise, these patients have very terrible epiphora in the postoperative period, and open up the other sinuses, because once you do your reconstruction and radiate the patients, these patients will have very bad sphenoid sinus, mucoceles, or frontal mucoceles. So open and clear the sinuses out for good adequate drainage and aeration. Complications of the surgery are multifold. Luckily, they are not too common, but the most common complications are the bleeding and the epiphora, which is seen in these patients. If you've resected a large part of the soft palate, the patients may have velopharyngeal insufficiency and nasal regurgitation during swallowing. If the reconstruction is not proper, the patients may have enophthalmos or hypophthalmos. Contraindications obviously are extensive pterygoid bone involvement, intracranial extension, especially for squamous cell carcinomas, adenoid cystic carcinomas, some osteosarcomas, you may still go in with limited intracranial extension. Cavernous sinus extension generally is a contraindication, and gross perineural spread is a contraindication. So these are some examples of really extensive diseases. Again, here the disease does not seem very too much, but when you look at it, there's a lot of involvement of the infratemporal fossa, the pterygopalpine fissure, and this was a pterygomaxillary fissure. This was a squamous cell carcinoma, so again went for non-surgical management. Once you've resected, you obviously have to reconstruct, and Brown and Richard Shaw in 2010 had described this extension of the classification, the Brown's classification, where they added two more categories, the type 5 and the type 6. So they have 1 to 6 depending on the vertical component of the defect, and a type A to D depending on the horizontal component of the defect. This classification is useful to sort of standardize the defect in terms of what needs to be done at what particular defect. However, it's a bit cumbersome to remember and use in daily usage. Corderio and Santa Maria's classification is slightly easier to use in the daily thing, where they've called it type 1 limited maxillectomy, where you can reconstruct it with an obturator. Where type subtotal maxillectomy is type 2, type 3 is total maxillectomy, where they've divided it depending on the orbital exentration or not. What are our goals of reconstruction? When you want to reconstruct these areas, the main goals are to support the orbit, to separate the intracranial and extracranial contents, restore palatal function wherever possible, restore dentition wherever possible, restore the midfacial contour, and obtain a healed wound. So when you're reconstructing, you have to always think about the amount of tissue resected, whether there's any soft tissue or bony replacement required, and what needs to be protected, the eye, the dura, etc. Prosthetic rehabilitation is what we used to commonly do, and this is the surgical obturators which are given on table for the patients for a temporary time, so that the patients can be on oral feeds immediately after surgery. What is more commonly used is the interim or the transitional obturator, which is 10 to 15 days after surgery. This has a hollow which will help reduce the soft tissue going back and sticking together, and allows the patient to assume daily life till his radiation is complete. Once radiation is complete, 6 to 9 months down after the whole soft tissue has fixed, we can give them a definitive obturator with teeth, which has fairly good cosmetic outcomes, and these are good for lateralized defects without too much height and without too much crossing of midline. Even in dentalist patients, you can offer an obturator when you do implant-based obturators. Coming to microvascular reconstruction, again, there's a lot of factors which go to determining what sort of flap you would use. It depends on what is the extent of resection, what are the things which need to be reconstructed, what are the critical structures which need to be preserved. And the ideal flaps are generally vascularized bone flaps. Each has advantages and disadvantages. It's just beyond the scope of this talk to discuss all of that. There's a lot of talk about CAD-CAM and virtual planning for mandible, but this role is also coming up in maxilla. This is one of our cases done by reconstructive surgeons using CAD-CAM technology. So what is the literature available for this virtual planning? There's actually a prospective randomized control trial on this. Though it's a very small sample size, it's 22 patients, 11 patients who were randomized to freeze flap with CAD-CAM versus 11 patients who are not. free scapular flap without CAD-CAM. So this is what they saw, that of course there's better aesthetic outcomes when you use CAD-CAM planning for reconstructions, better patient satisfaction scores, and reduced operation time and ischemia time for these patients. However, when you have extensive soft tissue resection and reconstruction, you may not be able to do these virtual plannings. You may not be able to use bone flaps. And in this case, we've used ALT flap with a iliac crest bone to reconstruct the orbital support. Once you've resected and done even bone reconstructions, you can do implant-based rehabilitation with prosthesis for these patients. And these are some of results of our patients. How does these flaps, obturators versus flaps behave when you compare them with each other? This is a meta-analysis. And if you see there's not much difference between both groups, you have to choose your patients properly. So I'm going to conclude here saying that maxillectomy is a very anatomic surgery, but it requires careful planning and evaluation. A multidisciplinary team is paramount, and new technology may actually help improve your outcomes. Again, a reminder for the National Headache Meeting, FHNO, it's from 17th to 20th October in Western Mumbai. Tata Hospital is organizing it, and all of y'all are welcome there. Thank you.
Madam, how often are you using CAD-CAM for maxillectomy defects?
Not really, because one is you have to realize the CAD-CAM planning, we should have a very fixed plan. With maxillas, as you know, especially when you're dealing with squamous carcinoma, sometimes the soft tissue extension is going to be much more, and the jigs cannot be really made customized with soft tissue.
Yeah.
You are doing the jigs only for the bone, so your change in treatment planning will be due to the soft tissue.
On-table. So for mandible, we are quite sure that we can about the cuts.
About the maxilla, it becomes a bit of a problem.
And sometimes one of the jigs will be hindering your cuts.
The section, yes. So it's good for benign tumors, bony tumors of the maxilla, it's good. But generally for, in my opinion, for cancers, especially squamous carcinomas, still has to be evaluated because it's not so easy in them.
Any other questions from the audience out of eminent panelists? Yeah.
And are you using the same unipolar the cartridge that is being used, or routine it is having any other facility for the cartridge probe, ma'am, for dissection? For
the surgery?
Sir, yes,
routine Covidian cautery I use, nothing different.
Okay, ma'am.
Thank you.
Thank you so much, ma'am. Now I would like to invite Dr. Sarbani Ghosh Lashkar, Professor of Radiation Oncology, PMH Mumbai, to present role of radiation in PNS tumors. Ma'am.
Good afternoon, everybody, and I'd like to begin by thanking Kaushik and the entire team at AIG for this kind invitation. So we've heard from Deepa about the surgical steps of a maxillectomy. In the next 15 minutes, I'll try to attempt how we use radiation therapy for paranasal sinus tumors. But in the interest of time, we really will not be delving deep, or rather diving deep, because we cannot complete each of these histologies. So now it's important for us that we understand PNS tumors well before we embark on any treatment modality for these patients. PNS tumors are relatively rare as compared to the garden variety oral cavity cancers. What we see more commonly are the maxillary tumors, followed by the ethmoid, sphenoid, and frontal sinus tumors. Now, of course, these are very challenging tumors for radiation oncologists as well as for the surgeon, essentially because they're very near critical structures, or they involve these structures directly. And of course, radical treatments therefore pose a challenge to all of us treating physicians. Now, it is a heterogeneous group again, we need to remember that it involves various subsites and different histologies which have different natural histories again. Now again, we do not have real prospective randomized data because of the small numbers that we come across, and majority of them, despite all that we know, actually present in locally advanced stages, and treatment therefore is again another challenge. And most of the data or the evidence that we have in literature is actually out of retrospective series with heterogeneous data over long periods of time, which simply means that we have to really extrapolate knowledge from one site to another. There are different histologies and multiple subsites are sometimes involved. Now, to drive home the point, if you look at the WHO histologic classification of PNS tumors, you will realize the wide diversity that we come across. But what we need to understand is that the squamous cell carcinomas are most common, followed by the adenocarcinomas and then the adenoid cystic carcinomas. But what we also need to realize is that each histology that we have has a definite natural history. Squamous cell carcinomas, of course, have a higher incidence of regional metastasis. Adenocarcinomas are locally aggressive with some incidence of regional metastasis and rarely metastasize to distant sites. Adenoid cystic carcinomas again are locally aggressive tumors with low lymph node metastasis, but metastasis to other sites like the lung is more common. Whereas if you have histologies like SNUC or NET, then you have aggressive locoregional behavior with 17 to 20% in some series reporting regional failure, as well as distant metastasis is common. Now, this is actually simplifying the PNS tumors, but this is broad and what needs to be remembered most often. Now, if you look at sinonasal tumors, the pathologist as they see it today is very, very complex. We luckily at the Tata Memorial Hospital have a dedicated skull-based clinic. And of course, what we see today is a paradigm shift in classification, clinical profiles, histologic entities, and understanding of the molecular underpinnings. Now, why is this important? This is especially important because there's a lot of ongoing research to identify predictive biomarkers as well as targets for using different agents in patients, especially who present with advanced disease or unresectable disease. Now, just to drive home the point that histology plays a very important role in this particular set of tumors, I would request you all to read the MUSES paper, which is a multi-institutional collaborative study on endoscopically treated sinonasal tumors. And this is a study which actually has looked at outcomes, 900 plus patients, to which the Tata Memorial Hospital has also contributed. And if you look at it, statistically, there is a statistical significant difference in overall survival, disease-free survival, recurrence-free survival according to the histology group. And if you look at these graphs, it becomes very apparent that actually there is a definite impact on histology, on the outcomes in patients, even if they are treated endoscopically, and this is very important to keep in mind. The other aspect is, of course, even if you look at the MUSES paper, the total number of recurrences were about 32.9%, local recurrences 16.7%, distant recurrences 14%, and regional recurrences only 2.4%. Now, this is the recurrence-free survival in these patients, but there is a strong correlation again between the recurrence-free survival and the histologic types. Again, this is one of those graphs showing you the impact of histology on recurrence in these patients. Now, coming to imaging. Now, we've heard imaging in oral cavity. Again, it is very important to understand that Dr. Deepa also showed us about imaging in maxillary sinus tumors. It plays a crucial role in PNS tumors in general. Why is it important? The CT scan is the most commonly used tool. It is good for invasion of thin bones in the region or vital walls, cribriform plate. Then also, for CT scan, you need to know how about the extent of disease, but it may be difficult, especially when you have large soft tissue involvement, periorbital involvement, and of course, it may be difficult to distinguish between secretions and the extent of disease. But the MRI then becomes complementary because it tells us about the soft tissue extension, the differentiation between secretions and tumors, cranial nerve involvement, perineural invasion or spread, dural and intracranial involvement, post-surgery setting, especially this is very important for us radiation oncologists in the planning setting. And of course, we need to do multimodality image fusion when we are planning for these patients. So in short, CT scan and MRI are actually complementary. Now, pathways of spread. This is again something that is very important for us to understand when we are treating paranasal sinus tumors. Why? Because direct extension in common, for most, it destroys the adjacent bone and spreads to the adjacent spaces. In the maxilla, as we've already heard from Dr. Deepa, the infrastructure lesions essentially spread to the upper alveolus, palate, soft tissue of the cheek, whereas the suprastructure lesions actually spread to the nasal cavity, ethmoid air cells, pterygopalatine fossa, and base of skull. And we know that all these structures are important for us to understand the natural history as well as prognosticate these patients. So here again, we all have to understand where the tumor is actually located in relation to the Ongren's line. Then for the nasal vestibule, early spread occurs to the upper lip, the gingivolabial sulcus and the premaxillary region. In advanced cases, of course, the cartilage could be destroyed or there could be extension to the nasal cavity. In the upper nasal cavity and the ethmoid sinuses, again, it is important for us to understand the spread, read the spread on the imaging because there could be extension to the lamina papyracea through the orbit or the anterior cranial fossa, and of course, the involvement of the skin and subcutaneous tissues. Another important area, but a contentious area in the paranasal sinuses is the involvement of the lymph nodes. So sparse capillary lymphatic supply most often related to extension to areas which have relatively rich lymphatics. Now this is important to understand. So if you have just disease that's involving the ethmoid sinus, you may not need to treat the regional lymph nodes. But if there is extension into the upper alveolus or into the maxilla, you may have to consider, even if it is a histology that does not spread as often to the regional lymph nodes. Invasion of the anterior nose and cheek, involvement of the oral cavity, extension to the nasopharynx. Now, these are sites where even if you have paranasal sinus tumors, they may involve lymph nodes in the neck. Then maxilla about 10 to 20%, nasal cavity about 3 to 10%. Now, if you look at the histology again, the variety as well as the incidence of involvement of the lymph node is a function of the site as well as the histology that is involved in the paranasal sinus tumors. Now, the other important aspect is perineural extension, most commonly associated with minor salivary gland tumors, as well as adenoid cystic carcinomas. They are much lower in squamous cell cancers. Olfactory nerve through the cribriform plate to the anterior cranial fossa, infraorbital nerve and nerves that run through the superior orbital fissure into the cavernous sinus, or middle cranial fossa and maxillary nerve through the foramen rotundum. Hence, it is very important for us to have a good and thorough knowledge both of the foramina that are located as well as the patterns of spread in these patients. Now, how do we make any decision in the treatment of these tumors? Of course, it is based on the performance status, the extent of tumor, orbit involvement including visual acuity and visual field, cranial nerve status and histology of the tumor. So for T1 tumors, as for most other head neck sites, it would be a single modality treatment. But for T2 to T4 tumors, it is usually a combined modality treatment, with surgery usually being the mainstay of treatment, followed by radiation therapy and or chemotherapy. Now, treatment protocol, in short, for other different histologies, for SCCs, we usually use surgery. Where it is borderline resectable or unresectable, it could be induction chemotherapy followed by surgery and or post-op RT plus minus concurrent chemotherapy. Adenoid cystic carcinoma surgery is usually the standard of care. Undifferentiated carcinomas, esthesioneuroblastoma. Again, I'm using really simple terminologies for all these tumors because today you use a whole lot of molecular markers and immunohistochemistry to further sub-classify these particular histologies. And of course, you have neuroendocrine tumors. So all these tumors, this is a broad management guideline. So unimodality or multimodality, how do you decide? Again, you have evidence for this. And it is essentially based on the histology, the extent of disease and the stage of disease. And we do understand that actually for advanced stage tumors, you would require combined modality management, and that would usually be a combination in resectable tumors of surgery followed by adjuvant therapy with or without chemotherapy. Now coming to the main point, and that is the role of radiotherapy. It could be definitive adjuvant or palliative. I'd be talking mostly about adjuvant and definitive radiotherapy. Why do we use adjuvant radiotherapy in our patients? It can be used to treat microscopic disease in otherwise non-responsive radio-responsive histologies. Lower RT doses are required in the adjuvant setting. Preoperative radiation may obscure the initial extent of disease, and surgery may not remove the microscopic extensions of tumor, though maxilla is the only site in the head neck region which does have enough evidence to support the use of intra-arterial chemotherapy. Then preoperative radiation increases the risk of postoperative wound complications. Now, in the paranasal sinus tumors, we need to understand the concept of cross resection, which is with endoscopic surgery or open surgery with en-bloc resection. And here the indications for adjuvant radiotherapy would essentially be in advanced stage tumors, node positive tumors, margin positive tumors in the presence of PNI, and practically all adenoid cystic carcinomas. In unresectable tumors, again, there would be a role for radiotherapy, and essentially because of gross infiltration of the infratemporal fossa, pterygopalatine fissure involvement of the dura and intracranial extension or extension to the cavernous sinus, involvement of the sphenoid or bilateral or bical involvement. And of course, we also see in PNS tumors that there is an increasing role of induction chemotherapy followed by either surgery followed by adjuvant therapy or induction chemotherapy depending on the response, followed by concurrent chemoradiotherapy post-induction. Now, target delineation. Now, target delineation is essentially based on physical examination, pre-treatment imaging, intraoperative findings, and of course, the pathological findings that we see from the pathologist. And this is typically how we do it. Now, there are certain considerations that are very important. And of course, for CTV, these are the various dose levels that we use in the CTV when we are considering adjuvant radiation therapy. And this is classically what we do. And this is one site again in the head and neck where multimodality fusion is of utmost importance when we are doing radiotherapy planning. Now, there are special considerations that we have to keep in mind when we consider certain sites. And this is essentially for the maxilla, for the ethmoid, for the sphenoid. The thing is that this is of course being published in the Manual of Clinical Oncology, but what I'd like to draw your attention to is essentially the fact that most of the paranasal sinuses are incompletely ossified or incompletely divided. So we may end up having to actually include the entire paranasal sinus in our clinical target volumes. Now, this is an example of a maxillary sinus tumor we fused, and this is the clinical target volume. This is for the ethmoids, where we've included the entire range of ethmoid sinuses, though the tumor was only confined to the middle and anterior ethmoid sinuses. Now, there is importance. We have to pay attention to detail, and this, of course, including the base of skull in the CTV, especially with PNI, then extranodal, then extensive. Thing what you call, if you have ENI in squamous cell carcinoma or undifferentiated carcinoma, it is important, especially when we are contouring the nodal regions. And of course, we need to have better techniques for improved controls and decreased radiotherapy sequelae. The important prognostic factors, of course, are stage, involvement of the orbit, the cribriform plate, the brain invasion, and infratemporal fossa involvement. Now, what are the radiotherapy techniques? Right from conventional to the more common, to the more modern particle therapy or proton therapy. Today, we do not use conventional therapy techniques when we're treating PNS tumors. Now, this is an old series published in 2007 from the MSKCC, where they looked at only 85 patients and they treated with a median dose of about 63 gray. Again, the most common site was the maxillary sinus. And if you look at the outcomes, they were actually about failure-free survival was about 62%, overall survival about 67%. And of course, there were no grade 3-4 eye complications with more conformal techniques. The prognostic factors were squamous cell histology and cribriform plate involvement. They concluded by saying that complete surgical resection followed by adjuvant RT was the effective and safe approach. And this is a table just to show you what happens with evolving technology that we can use for our patients. And essentially, when you compare conventional to IMRT, there is a decrease in the rate of toxicities of various structures. And also, we need to understand the various prognostic factors, which include the pathologic finding, the histology, essentially, the age, the race, the lymph node involvement, whether the orbit was involved or not, and the cribriform plate. And this is again another chart to show you that with evolving technique, there is actually a reduction in the incidence of both acute as well as late toxicity. These are various other trials that have used or treated, treated paranasal sinuses with adjuvant radiotherapy. And with IMRT, there is a definite reduction in the radiotherapy related toxicities. Now, of course, again, coming back to patterns of failures, I've already shown you this. In the squamous carcinoma, it is essentially locoregional. In adenoid cystic carcinomas, it could be multiple local recurrences as well as distant failure. In adenocarcinomas, they are locally aggressive. Sinonasal undifferentiated carcinomas, it could be regional as well as distant. And of course, mucosal melanomas, it could be distant metastasis even at diagnosis. Now, these are some more papers which go on to show you that with the use of IMRT or more evolved and conformal techniques of radiotherapy, there is actually no difference in outcomes. But what happens is that this first part is actually to show you that we can achieve good local controls with the use of definitive as well as post-operative radiotherapy, but with no difference in late complications between the two techniques, provided we use the right technique, and that is usually IMRT in most cases. Of course, we also need to understand what is the pattern of recurrence when we use non-surgical modalities of treatment. This is again a multicentric trial from the UK, and you can realize that most of the recurrences are either local or loco-regional. This is again from the Dahanka group. Again, if you see that out of the 184 patients curatively treated with EBRT, majority of the failures were local. Now, even amongst the local failures, it is important to understand where did this failure occur. And again, if you see, about 74% were within the high-risk CTV and 26% outside the CTV. Now, this is where IMRT has a definite role to play. So that is, the contouring is important, the technique is important. Now, the other part of IMRT is actually in an attempt to try and reduce the sequelae of treatment. And all these trials that I'm showing you, the studies that I'm showing you from Indira Madani, the Kent University, then Peter Durixis, all of them actually show that with the use of IMRT, there is a definite decrease in the incidence of late toxicity without compromising the local or loco-regional controls. Now, in the interest of time, I'll just go quickly. So these are other trials that have used IMRT. Now, the other important concept is, of course, elective nodal irradiation. So these are the indications: maxilla, other PNS, vestibular cancers, and all SNUCs. And usually we do not do elective nodal irradiation unless the histology tells us to do so or the area that is involved. Now, I'll come to our particular paper. 214 patients, nasal cavity, all received IMRT. This actually paper again goes on to tell us the importance of histology in the treatment of our patient. This is all related to histology. And if you look at this again, most of the failures by histology are still local. And in some cases, if you see the adenoid cystic, adenocarcinomas and the necks, you will see that there could be a finite incidence of even distant metastasis. The prognostic factors are, of course, the T stage, non-surgical treatment, undifferentiated histology, and poorly differentiated carcinomas. Again, we did not find any grade 3 toxicities, which were less than 5%, and only 3 patients had grade 3-4 late ocular toxicities. So we realized that IMRT should be the standard of care. All cases should be discussed in a multidisciplinary clinic. Surgery wherever feasible. NACT can be used in certain histologies, and the use of RT alone may be limited to very early stage disease or in patients with advanced disease who are unsuitable for combined modality management. The other thing that we need to understand in sinonasal tumors is the importance of other modalities of radiation therapy, which includes carbon ions as well as protons. I won't be going into details. We also have used protons in our patients, about 5 patients so far in the last 1 year. This is a case in which the maxillary sinus was involved along with the ethmoids. Patient had undergone surgery outside, came to us, had residual disease. So we treated this patient with proton beam therapy. And of course, the advantage is that we could spare the eye somewhat better, and we could deliver the doses that were necessary. The patient has undergone proton therapy and 6 months later is doing well. Of course, what we need to understand that these are early dates and we need to be cautious as well as evaluate our patients carefully. There are various other trials that are going on, prospective trials which are evaluating this is a study from the Heidelberg Institute of protons, and of course this what it clearly showed that this could be used very carefully in our patients. And of course you could also use a combination of IMRT and carbon ion boost in these patients, and the acute mucositis and late toxicity could actually be restricted in these patients. So this is why it is important to consider doing carbon ions or particle therapy. There is also a role of using a combination of intensity modulated radiotherapy and particle therapy, especially in unresectable cases. And this is from the Italian group, which this is the SINTART-1 study, which showed that this could be safely done. They went on to do the SINTART-2, where they showed us that perhaps there is no difference whether you use protons and IMRT or use carbon ion therapy, but definitely it was a safe tool to evaluate. These are some of the late sequelae after radiotherapy, which we should keep in mind, and it is important for us to keep these things in mind when we are planning our patients. And of course, treatment delivery and patient care is equally important for these patients, and especially rehabilitation on treatment and post-treatment is equally important, especially the idea of doing nasal douching carefully, care of the eye, care of the oral cavity are very, very important issues when we treat our patients with paranasal sinus tumors. In conclusion, histology, site and disease extent dictate management. Imaging and histology play a crucial role. And of course, multimodality decision making is important for us to manage our patients well. Conformal and precision radiotherapy techniques like the nasopharynx. This is another site in the head and neck where you have to do conformal planning, and it would be best to use IMRT with IGRT. And of course, if you have AB ions, you could use it, especially for unresectable tumors. Rehabilitation is equally important. And of course, you don't please sit and look for level 1 evidence, because you're never going to get it considering the numbers and the unusual type of these tumors. Certain questions remain unanswered. The role of NACT definitely. R1 resection versus definitive CTRT. Role of concurrent chemotherapy is also in evolution, and role of newer modalities, especially immunotherapy, carbon ion therapy, etc. And again, I would like to end by inviting all of you to Mumbai. Thank you very much. Sorry for exceeding my time.
No, ma'am. I just want any role of electronodal irradiation in esthesioneuroblastoma. If yes, what nodal levels has to be included?
For esthesioneuroblastoma and SNUCs, we actually, if the node is involved, of course, definitely there's no question you're going to treat it. But otherwise, if it is not involved, we typically do the level 1B, retropharyngeal and 2 lymph nodes electively. Now, if it's a lateralized tumor, you may not want to treat both sides, but the retropharyngeal definitely bilateral. But if it is something in the midline or crossing the midline, then we treat both sides electively.
Thank you, ma'am.
Deep recurrent extension who are very unlikely to respond to systemic therapy. What is
It's very difficult to give you a short answer, but what we do typically is that we would do neoadjuvant chemotherapy. After neoadjuvant chemotherapy, we will reassess the tumor with an MRI as well as a PET-CT scan to look for operability. If the surgeon deems it inoperable, typically we have our skull-based clinic discussions on these matters. If they think it is inoperable, especially because there is parenchymal involvement of the brain, then what we do is we fuse the pre-NACT MRI with the post-NACT MRI. The one that has responded may get a slightly lower dose, but you have to treat the microscopic disease and then treat the rest of it to your 70 grade 35 fractions equivalent.
Madam, nice talk, madam. Thank you. There are some reports saying ORN incidences are more with proton beam therapy. What is your comment on it?
I know that the MSKCC has actually reported a very high incidence of ORN. Now, there are two aspects to it. One is the system that they've used for reporting the ORN. That means the classification system, whether they've used the Notani system or you have your, what you call the MARC system and all that. So depending on, so even low grade ORN have been reported as ORN. But in our experience of 21 patients that we've treated on proton so far, we have not found any overt incidents of ORN. Not only that, we've also treated re-radiotherapy and we've not found any incidents of ORN. But what we've learned is actually that all patients actually go for an in detail or thing, what you call dental evaluation before we select a patient for proton therapy. Thank you.
Thank you so much, ma'am. Moving forward, I would like to invite Dr. Sridhar Dasu, Director of Surgical Oncology, AIG Hospitals, to moderate a panel discussion on PNS tumors. And the list of panelists, I would like to invite Dr. Sarbani Kosh Lashkar, Professor of Radiation Oncology, TMH Hospitals, Mumbai, Dr. Jyoti Junadula, Consultant Radiation Oncologist, Renova Century, Hyderabad, Dr. G. Kranti Kumar, Consultant Head and Neck Surgeon, Continental Hospitals, Hyderabad, Dr. Shravan Kumar, Consultant Head and Neck Surgeon, Indo-American, Hyderabad, Dr. Rachna Chinamaneni, Assistant Professor, Medical Oncology, NIMS, Hyderabad, Dr. Srilekha Appasani, Consultant Pathology, AIG Hospitals, Hyderabad. So I would like to invite all of them on the stage for the panel discussion.
A very good morning to one and all, and I cordially invite all of you all to our inaugural session of Deep Dive in Head and Neck Cancer 2024. So I think in the interest of time, we'll directly go to the case at hand. So the first case is a 60-year-old gentleman who presents with a swelling over the left side of the face for 2 months duration, associated nasal stuffiness and epistaxis. He has been a former smoker of about a 15-pack year history, right now not smoking, and a businessman by profession. So in examination, you can see that there is some fullness over the left side of the cheek. The skin is free, the infraorbital sensations are preserved, the mental sensations are preserved, his ocular movements are normal. Intraoral examination reveals a bulge over the left side of the hard palate, but there is no tumor visible. Nasal examination reveals a fullness over the lateral wall, but there is no growth and no cervical or parotid adenopathy. So what next? So the first question, Dr. Shravan, based upon this history and physical examination, what do you think we are dealing with?
I think we are dealing with a maxillary malignancy, maxillary tumor.
Okay. And how would you like to evaluate the patient further?
We'll do a complete endoscopy examination of the nasal cavity and also the gingivobuccal sulcus, upper gingivobuccal sulcus, which we have yet to evaluate, and also the ear examination to see the nasopharyngeal extent, if any.
Okay, so basically we'll go for a complete clinical examination and NPL scopy. So NPL scopy has been done. This is the finding. Fleshy growth in the maxillary antrum with cystic and hemorrhagic components. No visible growth in the nasal cavity, nasopharynx is normal. So what next? So obviously a biopsy has been done. Dr. Srilekha, madam, when you see this history and physical examination and you have found that there's a growth in the maxillary antrum and you receive a biopsy specimen, what goes through your mind as to what could be the common differentials that you're going to be dealing with?
So typically, more often there's squamous cell carcinomas. So if it is not an obvious squamous differentiation, then we would like to look for differentiation. If it is squamous, then it is easy. If it is not squamous, then we would, and it is high grade and it has an undifferentiated look, then we have to look at the undifferentiated carcinomas and also differentiate from other poorly diff malignancies like a small round blue cell tumor or neuroendocrine carcinoma or a lymphoma. So it depends on how differentiated the tumor is.
Yeah, so basically you'll go in terms of what is most common and based on the differentiation you try to rule out in orders of frequency. So
and with the help of biopsy.
So this patient actually was evaluated outside at a hospital in the city, and the biopsy was reported by a pathologist outside. It came as a squamous cell carcinoma. So what next? Dr. Kranti, what would be your next investigative treatment line of investigation?
As very nicely elaborated by Dr. Deepa. So basically we would ask for an investigation in the form of an MRI, and also I would like to complement with a CT scan. if I would suspect it to be a T4A disease with something like that, then probably a metastatic Werpel.
Yeah, so okay, so this patient had a CT. So imaging definitely would go for a CT scan. These are the CT findings. Can you just have a look at it? So some arrows are there pointing out to some regions. You can give your opinion, sir. Sharon, you want to weigh in?
I guess on the sagittal section, we are seeing a oroantral fistula with dissection of the palate. And on the axials, in the axial section, posteriorly, it is involving the pterygoid muscles and pterygoid plates partially.
Yeah, I think we didn't have time to put the entire sequence going down. So basically, yes, madam, Sharbati madam.
You know, there is also involvement of whatever limited cuts we have of the pterygomaxillary fissure. The
Okay.
middle one shows that actually there's a lot of soft tissue involving there and going into the infratemporal at least.
Yes.
And also the pterygomaxillary fissure area, though it is not the only cut, I would like to look at slightly higher cuts. And here, of course, we don't see too much of a superior extension, but I would like to do MRI in this patient.
Okay. And what about the orbit? Anybody has any doubt about the orbit
No,
as per the
orbit.
cuts?
Or
Yeah, the orbit appears to be free. Definitely there's a growth in the maxillary sinus. There is a breach of the inferior wall as well as the posterior wall spread to the pterygopalatine fossa and the ITF. So you would go for an MRI definitely, madam, in this particular case. So what would you look for in an MRI? Dr.
Yeah,
Kranti, sure.
basically, definitely in the previous CT, what you have shown that infratemporal fossa soft tissue
Yeah.
extent is there. So
Yeah.
we would like to see the pterygopalatine area, infratemporal fossa, and how the disease is.
Yeah.
And even the MRI will delineate me perineural spread and all.
Yeah, but the biopsy has come as common cell carcinoma. Would it be really that? And there's this mental sensations, the mandibular division.
Basically, what you said is mental sensation is
Yeah.
as such preserved.
So clinical examination and the biopsy suggested SCC. Yeah, Dr. Shravan, anything you want to weigh in? Yeah. So okay, so MRI is meant for basically four things. Number one, orbital involvement, skull base involvement. Number two, perineural spread or cranial nerve involvement. But clinically as well as in terms of histology, we're not dealing with an adenocystic carcinoma. Third is yes, definitely it helps to differentiate between blocked sinuses from tumor. That is very important. And lastly, yes, ITF involvement, pterygopalatine fossa involvement. In this particular case, you can have a look at the retromaxillary pad of fat. So it seems to be preserved. So this is one of the indications that there is high ITF involvement. In this particular case, bilateral retroantral fat planes are preserved. So probably you're not dealing with a high ITF involvement. Probably you're dealing with something like an inframarch involvement, even if it is there. So yes, definitely it's a complementary investigation. The patient was evaluated outside. The MRI was done. We didn't have the images, but yeah. But madam would say it's essential. I would say to this particular case, yes, probably plus minus. Okay. So what after this? Would you go for a PET CT? Dr. Rachna?
So with the extensions which we are seeing in the local imaging, I would prefer to get a PET CT also.
Okay. So PET CT for distant metastasis. Anything else in the PET CT you want to look for, which is probably not being picked up? Only CT with contrast is good enough. No distant mets, no nodes. Basically, no nodal disease, no distant mets. So what stage are we dealing with? Anybody can weigh in. Dr. Jyoti?
It's a T4 disease
Okay. So why do you say T4, madam, not T3?
because there is involvement of pterygoid plates in this case.
So the pterygoid plates are actually not destroyed. The posterior wall of the maxilla is involved, but the pterygopalatine fossa is involved. Yeah, but yeah, you'd still go for a T4A because you're saying that the ITF is involved. ITF seems to be involved, so it's a T4A disease. Yeah. So what next? How many would go for surgery? How many would go for induction chemotherapy? How many would go for chemoradiation? This is all being covered by Dr. Sharbani madam already, but yeah, Dr. Shravan, you want to go for surgery upfront based upon the histology and the findings?
I guess surgery with ITF clearance can be possible.
Yeah. So you think that you can get a reasonable clearance? What about induction chemotherapy, Dr. Rachna? Do you think that the surgeon is wrong and he's too confident? And all surgeons say we can always go for clearance, but finally we'll end up with unclear disease, right?
So that would be a discussion with the surgeon and his confidence.
You're discussing right now, madam. He's next to you.
So if he's very confident that he can attain a negative margins,
Okay.
we can avoid. But
No.
looking at the involvement, we can even consider induction chemotherapy.
Okay. For squamous cell also, you would consider induction chemotherapy. Sure. And Dr. Kranti, you're also confident?
So basically, we need to understand whether we can contain the tumor itself in your resection margins.
Yeah.
So when you showed the picture and all, what are the critical areas and all, what is stopping me in taking the decision, those have been very clearly mentioned. So, orbit is clear.
Yeah, what would stop you? Yeah, number one would be orbit. Okay.
No intracranial extension.
Very good.
Pterygomaxillary fissure is as such looking free.
Okay.
So I can contain the tumor with the maxillectomy.
So you can't contain yourself, but the tumor will be contained. Fine. So no role for definitive chemoradiation. Dr. Jyoti, you want to just say no?
Can I intervene here?
Sure, ma'am.
I know all the surgeons seem very happy and they say they're going to give me negative margins.
Exactly, madam.
But I really don't. I don't believe that. I would actually err on the side of giving induction chemotherapy and then doing surgery and then sending the reassessing the patient and then sending for surgery. And my reasons being that though there is no intracranial extension, though there is no high ITF involvement, the orbit is clean, but there is a lot of soft tissue involvement.
Exactly.
And that's where the cut margins may not be negative, except I know we always in the joint clinic would decide with the surgeon whether it can be done or not, but I would err on the side of doing induction chemotherapy and then reassessing the patient for surgery. That would be my thing on it.
Sure. Dr. Jyoti, anything else from your side?
Definitely, I would not consider doing definitive chemoradiation upfront. So if it is operable and if we are sure that, the surgeon is sure that they can achieve adequate margins, negative margins, then surgery followed by radiation.
Okay, so you are with us. You are with us. Yeah, fine. Sure. Yes, madam.
In the process of bioselection, we should not waste the time. Again, it should not become inoperable.
Exactly. So you think that it could, there's a chance that it could progress and probably lose an operable chance. Yeah, that's what we always say. Yes, madam.
There are 2 points to this. One is that, of course, you have to evaluate properly. Soft tissue involvement in the retroantral fat and fuzzy planes with the pterygoid muscles as seen in the scans would need a better evaluation with an MRI.
MRI definitely, sure.
Yeah, so I would not jump to surgery based on the scans. I would want a better delineation on MRI. The second thing I want to bring your attention to is the MD Anderson paper by Ehab, Hanna and all.
Yeah, we'll get to the evidence down the line, madam.
Yeah,
okay, but sure.
Yeah, so not particularly for maxilla, but overall for PNS, sinus, they've looked at squamous carcinomas especially. They've looked at their series of squamous carcinomas and they've saw that for advanced paranasal sinus tumor squamous carcinomas, induction followed by surgery and then
is inferior to?
No, it's superior.
Okay. So I read that paper wrong, I guess. Fine. Okay. So the MDT discussion was again, they were pro-surgeon and the surgery team, which is me, we found that we could go ahead with a surgery with an ITF clearance. So what approach would you go for, Shravan? Would you go for an open approach, endoscopic approach?
Definitely an open approach.
Okay. Why not an endoscopic approach? Just for the benefit of me, probably.
ITF, if we are planning to clear the ITF, going endoscopically will be
difficult. Okay. Yeah. Okay. And what about reconstruction?
Limitations for you when you're planning for endoscopic, not in this case, but you need to understand anterior extent, lateral extent, and when your resection margin is crossing the mid-pupillary line, all these things are contraindications for your endoscopic surgery.
CFR is, in general. Okay, fine. So what about reconstruction? Would you go for an obturator or madam is also, Deepa madam has spoken regarding, would you go for a CAD-CAM virtual surgical planning?
CAD-CAM specifically we have not used for maxillary reconstruction.
Okay.
I guess we'll go with a microvascular flap or not.
Yeah, so you will not go for a delayed reconstruction, you'll go for an upfront reconstruction microvascular. Yeah, so this I'll not go into. Basically, these are the indications where we can use the obturator. Generally, these are for central palatine defects, but again, advanced obturators are available. So the surgery was a total maxillectomy with ITF clearance. You would address a neck, definitely?
Definitely, yes.
Yeah.
We are opening the neck for
okay. Yeah, so free fibula flap reconstruction, we used, luckily we had a CAD-CAM system here and our plastic surgeon also insisted it to be better for us. So among the cuts, Dr. Kranti, which cut do you feel is the most critical when you're doing a total maxillary? Madam has already enumerated the cuts.
Posterior cuts, the posterior pterygoid plates. When your axis of putting a chisel and mallet, if it is in a wrong direction, you can even injure the cavernous sinus.
What about the frontonasal cut, sir? I mean, you can bridge the lamina papracia. In this case, the ethmoids seem to be free.
At least you'll be having a control open thing. The posterior cut is little difficult for us.
Out of these 3 cuts shown, the frontal it might.
Yeah, I actually found, to me it felt that the frontonasal cut would be the most difficult because, but anyway, This is what we used. We used a jig, and this is intraoperative use of the jig. As madam said, we actually had to remove the jig because one of the cuts we had to extend. It was not as per the specifications of the jig. And this was used by our plastic surgeon for making his cuts. This is the intraoperative picture. Day 7 he had some seroma, and day 1 month postoperatively he seems to have settled completely. Finally, the HP comes as slight surprise. It comes as SNP, polydifferentiated carcinoma T3N0. So we sent this off tissues of the pterygopalatine fossa and the ITS separately, and Sri Lekha madam says that they are all free. Margins are negative, PNI is negative. So stage group 3. So what next? Dr. Rachna, madam, would you want to weigh in?
For a T3 and 0 margin negative, chemotherapy role is not.
So no role for adjuvant chemotherapy. Dr. Sharbani, madam?
I would definitely consider giving adjuvant radiotherapy.
Okay, radiation. Any role for chemoradiation, madam?
No.
Okay, why, madam? Because
See, there is no evidence for axillary for PNS tumors. What we usually do is extrapolate evidence from squamous cell carcinomas elsewhere in the head and neck for this particular site. And there is no cut margin positive, nodes are not positive with
so PNI is negative, margins are negative as. Yeah, madam, sure.
SNUC is really, if you see more and more now, tumors are not being categorized as with, I think Neha is left, but madam can also add on to it. With more and more pathological awareness and more sub-classification, we realize SNUC is not that basket case where you put everything there anymore. But if you look at prognosis wise, SNUC is one of the poorest prognostic tumors. The ideal treatment is always trimodality for SNUC. So even though that margins and all are clear, because it was an advanced case and it is a SNUC histology, I think we should err on the side of caution and give chemoradiation to this patient.
I agree with Deepa because I still am in that squamous carcinoma thing.
Exactly.
But
So
if
that's
it's
why I asked
not,
you, madam.
then it will be CTRT, definitely.
CTR,
Yes,
yeah.
definitely.
So this was, yeah.
And
So
we would
probably in hindsight, if we knew it was a SNUC, we would have gone for a neoadjuvant, followed by reassessment, surgery, followed
and
by
then CTRT. And in this, I would also treat the neck nodes.
Okay.
And
Yeah.
then here, because now it's a SNUC, the PET CT makes sense. Otherwise, if it was a squamous
Not
carcinoma,
required.
you could have just done an NCCT.
Sure, madam, sure. So this is general maxillary tumor guidelines, but again, for SNUC, we have already gone through it. Lot of papers, lot of data which says that yes, trimodality treatment is the way forward, and the patients who have got sinonasal carcinomas have got an intermediate prognosis as compared to esthesios and melanomas. Again, the new clinic experience also says the same. Trimodality treatment is the way forward. This is the evidence for NACT by Moran Amit. He classified patients into locally advanced tumors, NACT, and reassessment with chemoradiation. Those who responded well, concurrent chemoradiation. Those who did not respond well, you go for surgery and radiation. And they found that in his paper, the chemoradiation arm was probably doing better than the surgery and chemoradiation arm. And so definitive answer for chemo was supposed to be given by the ECOVACRIN trial, phase 2 randomized trial, but it was closed early due to diminished recruitment. So regarding proton, madam, would you go for proton?
The main use for proton in sinonasal tumors is trying to either treat unresectable disease or to treat resectable disease, where you want to reduce the chances of complications to your doses to your OARs. Now, if your OARs are more than 1 centimeter away from your tumor bed, there is a point in using what you call protons. But if you look at the meta-analysis done from the Shanghai group, actually there is no difference between protons and IMRT for sinonasal tumors in particular. But if you look at carbon ions, there is a definite difference, because why? Carbon ions can actually help you to give much higher doses also biologically. The other thing that you have to remember is that there is a lot of problem when you're treating PNS tumors with any of these particle therapy, and that is actually filling of the sinus and emptying of the. So you need to actually have adaptive planning also that is ready. So keeping all this thing, yes, if my OARs are away, I may still consider protons, because that will give me the best kind of distribution and spare the adjacent structures.
Sure, madam. So you would go for IMRT?
Either IMRT or protons, depending on what I have, but there's not too much of a difference.
Yeah, so the patient here actually received chemoradiation with cisplatin etoposide and is doing well at first fall. So take home is a rare tumors and definitely biotrimodality of treatment is required. Surgery is still the mainstay, but yes, neoadjuvant chemo should have been probably given. Radiation definitely important role. Chemoradiation alone without giving any form of surgery is probably investigation. The next case is a 34-year-old male presented to the ER with complaints of giddiness and right-sided headache. He had some surgery for the left eye, probably thysis bulbi. Details are not available. Reasonably good performance status, and this is the CT findings of this particular patient. It was actually evaluated by the neurosurgical team. So in the interest of time, I'll go through the CT findings. You can see that there is a growth in the right nasal cavity, ethmoidal sinuses, and it is breaching the cribriform plate. An MRI was also done. It breaches the cribriform plate and goes into the anterior cranial fossa with significant amount of perilesional edema and midline shift. So what next? Dr. Kranti, what would you do now? What do you think you're dealing with? The 34-year-old male young patient.
It's a paranasal sinus tumor
Okay.
with an intracranial extension.
Okay.
What is the performance status? What is the echo? Obviously.
Patient is he's come walking, but complaining of giddiness and some amount of.
If feasible, we need to do investigations in the form of again biopsy and imaging.
Okay, so you would go initially for a biopsy, definitely. Who would go for an upfront surgery? Anybody for upfront surgical approach? Patient has got intracranial extension, mass effect. Nobody. Okay, so the neurosurgical team went ahead with upfront surgery, and as expected, they did a extended bifrontal craniotomy, excised the intracranial part, but on table they found there was brisk bleeding from the anterior cranial fossa. Gross excision was done. The intranasal part was abandoned because of the extensive bleeding. Patient was on vasopressor. So then after that, the history came, and the HPE came as olfactory neuroblastoma. Dr. Srilekha madam, what would be your take on this? Would you look for any differential diagnosis which would mimic olfactory neuroblastomas?
Surely, sir, we would like to rule out neuroendocrine carcinoma.
Okay.
Given it's a young male, we have the not midline not midline anymore,
Okay.
not carcinomas, because they also occur in a relatively young age.
Okay, this is the IHC panel that we have done at AIG. So based on this, you're sure of the diagnosis or anything else?
Yes, it is all good for neuro.
Yeah, all good for olfactory neuroblastoma. The differentials, as I said, is SNAC and SNAC, and based upon the IHC and the histology, we were able to make a good diagnosis. So then what next? So this patient has got an incomplete excision. Dr. Rachna, margin positive excision, the intranasal part has not been addressed. Gross total excision of the intracranial part. What else?
We have to discuss with the radiation oncologist if they can incorporate in the fields the residual tumor.
Not surgery, pre-surgery.
But I would like to give some chemotherapy if you have.
Okay, very good. So the resurgery is probably not an option. Patient has come after 1 month, and we will go for some form of any systemic treatment. Yeah.
Chemotherapy, this platinum based with etoposide is what.
Okay. And if this was not, say, an intracranial extension, Shravan, the anterior cranial fossa has free, you had a biopsy report prior that it's SCC neuroblastoma, it's gone up to the skull base, dura is free, cribriform plate is involved, not crossing the mid pupils. What would be your surgical approach?
I mean, upfront biopsy report of anesthesia neuroblastoma.
SCC neuroblastoma and HIAMS grade 4. High grade SCC neuroblastoma.
High grade, I think I'll incorporate NSCT before going to
Okay.
surgery.
Low grade?
Low grade, if I'm sure of getting clear margins, I'll venture for surgery.
Okay. And what surgery? Endoscopic? Would you go for endoscopic approach or?
I mean, if it doesn't breach the cribriform plate, I guess endoscopic approach should be.
Okay. So confined to the nasal cavity, you would go for an endoscopic, but breach of the cribriform plate, you'll not.
Combined.
You'll go for a combined approach. Okay. Fine. Would you do a staged approach? You'll do one sitting.
At the same.
Yeah, same sitting. Okay, fine. So the NDT discussion was we did staging PET CT and then plan for NACT and reassess for staged nasal surgery. Essentially, this is a Kaddish C. Bilgora 4, intracranial extension, HIAMS grade 4, no distal mets, no nodal mets. So what chemo? Dr. Rachna?
Cisplatin etoposide is the preferred
Okay.
for.
Fine. So this is cisplatin etoposide, 3 cycles given. Surgery was done. Later on, endonasal sinus excision. Again, came as olfactory neuroblastoma. So what adjuvant? Obviously, Dr. Sharbani madam, we have done adjuvant CTRT because margins are definitely okay. So we have given actually chemoradiation. Okay. What And you said already that you treat the nodes, madam? Would you treat the node electively? ENI? Okay.
ENI positive. Is it ENI positive, sir?
No, elective nodal irradiation, not ENE. ENI.
Okay.
Elective nodal irradiation.
Since it is node negative, we don't treat with elective nodal irradiations.
Okay, but for a Kaddish type C, high grade, is there any role?
There is no role of elective nodal. If it is node positive, then we go with elective nodal irradiation.
No, we have done only an intranasal excision and imaging does not show any nodes. Fine. Okay. So generally cervical node mets are less than 9%, upfront is 7% and delayed another 9%. The way forward probably is to go for Aztec would be any ENI to be given or not, madam?
I would consider giving ENI considering, because though this meta-analysis is saying there's no advantage, and that's the general perception about PNS tumors, considering this histology, a HIAMS 4 with a Kaddish C, I would actually do ENI also.
Yeah. Sure. Some role for proton, madam, aesthesio?
Can consider this, but then again, my only thing is, of course, Nagarjun is going to be speaking about it, and there are some more people with a little bit more of proton experience. But the moment you want to treat the neck, proton planning is not so easy anymore.
Okay. So now data for adjuvant system. Patient is on MRI, PET, CT, and SCOPy follow-up 3 monthly. Yeah. So the prognosis, this is Kaddish type C actually, and Gulgraf D. Local recurrences are the rule. 10 to 20% recurrence rate at 10 years. But does salvage improve survival? Probably not. Yeah. Take home is a rare tumors, and obviously the important thing is to get a pathological diagnosis before initiating treatment. Multidisciplinary treatment, surgery and adjuvant RT offers the best chance of cure. So the last case is probably more surgeon centric. This is an 84-year-old gentleman who presents with a non-healing ulcer over the right buccal mucosa. On examination, there is a growth in the RMT with both lower GB sulcus involvement and grade 2 trismus, level 1B node. It is an 84-year-old extremely frail patient. Biopsy has come as squamous cell carcinoma. This is the lesion. You can see a growth in the buccal mucosa with erosion of the alveolar process, mandible, with pterygoid muscle infiltration probably with a large node, level 1B or level 2. So what next? Shravan, this patient doesn't want surgery. What would you offer?
I'll send it to ma'am.
You will send it to ma'am. Okay, so surgery not willing. What about chemoradiation? Dr. Jyoti, you'd say that he's frail, but still I'll give chemoradiation, or?
He's 90-year-old.
He's 83, okay, 84.
84-year-old. If he's fit, we can consider chemo.
Okay, fine. So he's not fit that much, so I guess we just went for any role for induction chemo, madam? Rachna, madam? To make him fit.
If there is a scope of planning a surgery or CTRT at least after the induction chemotherapy, yes, we would like to give. But if they
I think he was not willing for surgery. So
not willing for surgery, not planning for chemo RT, then our intention would become palliative rather than induction.
Yeah.
I think it's important to do a comprehensive genomic assessment for such people. It's 84 years also, we can still find some fit enough patients who will be suitable for some form of systemic therapy. If the comprehensive assessment says that patient is unfit for anything, that's a different situation.
So you're saying comprehensive geriatric assessment. I thought CGS meant...
no, CGA.
CGA.
Comprehensive geriatric assessment, not NGS.
Not NGS. Okay, fine.
So I'd like to ask I would like to ask Rachna as well as Vamshi. Now, this is an 84-year-old male. The radiation oncologist has said they're not considering for CTRT. Is this a place where you may consider OMCT? Because the other thing that I'm considering is maybe do something like a quad shot in this patient, because it's an upper alveolus, it's not mandible. We can do palliative radiotherapy also, but it would be more like the quad shot regime, because he's an 84-year-old man. You don't want him coming every day. So, and of course, the role of OMCT in these patients.
Yes, ma'am. That's more important in this age group with the fitness which we are discussing about. OMCT has an important role to play, and with low-dose immunotherapy if feasible. But initially, we'll start with OMCT and then see the how the patient is doing.
So again, OMCT, that is oral triple metronomic therapy, combination of 3 oral drugs. It's safe, it's easily tolerated. Having said that, the triple metronomic erlotinib is not easy to tolerate in an 84-year-old. I use it once in 3 days. I actually don't even give it once an alternate day. I give it once in 3 days. So if I have to give, if the patient is fit enough after my CGA, I'm actually even okay to go for a standard dose immunotherapy because your data is better for immunotherapy standard dose rather than the low dose or a metronome. So if I have a choice, I will use my standard dose immuno. If I cannot use that, then yes, oral metronomic or anything else goes for a choice.
Okay, fine. So we'll go ahead. This patient basically got RT alone, high palliative dose of RT. In short, he's fine for 3 years. This is actually a true case. He's been fine. He got the radiation done in 2021. He's been absolutely fine till 2020, since 2024. So probably what we did was not wrong. Second thing is the pain and swelling. He's coming with complaints of pain and swelling in the right cheek since 2 weeks and swelling over the right eye since 1 week. So on examination, there is swelling, tenderness and erythema of the right cheek. Oral cavity shows some bony spicules over the right lower GB sulcus with foul smelling discharge. Grade 2 trismus. Dr. Kranti, what would you do next? What according to you are you facing with?
Always there is a chance of recurrence, so first we need to rule out it. If possible, we'll examine it, do a biopsy if possible.
Okay.
And the other possibility, what we are thinking is post-RT, so osteoradionecrosis is another possibility.
So
But
definitely
always
imaging,
possible
we'll go
to
for
do a
imaging,
biopsy,
yes.
do
Okay,
a
this is the
biopsy.
imaging findings. So I have marked out what the lesion you are looking at. Yeah, so if you have seen previously the pterygoid plates were actually free in the first scan, that is prior to radiation. Right now there is some destruction of the lateral pterygoid plate, and obviously the alveolar process of the mandible shows some amount of bony resorption and some bony spicules with some soft tissue component. Our radiologist has said it that there is nothing, there is no growth there. All the lesions are suggestive of only some soft tissue post-RT changes with secondary infection and inflammation, and this is probably a case of ORN. This is a 3D reconstructed image. Dr. Shravan, you want to comment on this?
The body of the mandible seems eroded along with the angle.
And is the erosion going to the inferior surface? It's stopping short.
No, it's not.
Yeah, it's stopped. So that is an important point. It's not going below. So what next? You are dealing with ORN, mandibular definitely, probably maxillary, right? So what would be your?
I still will go ahead and take a biopsy before jumping onto ORN.
Okay, so biopsy is negative. There's no evidence of malignancy. It's suggestive of an ORN.
Again, we need to go.
Correct. Any role for MRI? Any role for MRI? Dr. Kranti, Dr. Jyoti, madam, you want to do an MRI?
When there is clinical evidence of bone destruction.
Yeah, so gross bone destruction. Yeah, so what grade of ORN are we dealing with, Shravan? What are the gradings, or do you grade it or just?
Follow the Notani's classification.
Yeah.
Great.
Yeah, so probably we are dealing with some high grade because it's got some bony spicules. The skin also seems to be involved. There are some other consensus groups. I'll not go into the detail. What is the prognosis of this patient? Is he going to be manageable with conservative treatment? Assuming he's not 83, he's only say 50-year-old and he's quite fit now. What is the prognosis of this patient?
I mean,
more than 6 months post-RT.
3 years disease-free interval, and I mean, if it has to be definitive, it has to be resected and a soft tissue cover has to be given.
So basically, conservative
Front
treatment is
surgery
unlikely.
not fit. I don't think we'll proceed with that.
So conservative surgery is unlikely to be an option for this patient because he's got even maxillary ORN probably, because maxilla has got bilateral blood supply that is also got affected. It's unlikely to heal. So this is the general treatment algorithm that we use. Okay, fine. I think I'll stop. I wanted to talk about HBOT. How many in the audience would say that you'll use HBOT for these kind of cases?
I would actually start off with a more conservative management, and that would be, I think, antibiotics empirically with either pentoclo or pento only. So that would be used, and especially since he's an elderly man, if it is a maxillary ORN alone, I would actually only use conservative means because maxillary ORNs actually heal. It's the mandibular ORN that is likely not to heal or respond. So then in that case, surgery would be my treatment of choice rather than HBOT, because whatever evidence that we have on HBOT is actually equivocal. If you look at Anane's trial, it's a negative trial. So that's why we need to be very sure about what we're going to do for this 84-year-old man.
Yeah, so basically, sequestrectomy is debrided means marginal mandibulectomy. Could you go for Shravan if there is no maxillary involvement? Could you still go for a marginal mandibulectomy in a post-RT, definitive RT patient?
Not at all.
Not at all. There's no pathological fracture. Would you look for a pathological fracture as an absolute definitive contraindication for going for a
Post-RT setting, doing a marginal mandibulectomy is a relative contraindication.
And more than that, in the case of an ORM, leaving behind a...
And how do you assess intra-op?
I mean, as we cut through the bone based on the bleeding from
Yeah,
the cut.
bleeding from the cuttings is the definitive thing. Yeah. So would you go for microvascular surgery, early microvascular intervention, provided is 45, 50, not 80?
Yeah, empirically fit, I'll go for a soft tissue cover.
Soft tissue cover. Okay, excellent. So again, radiation dosing spaces, there's not been any evidence for any mitigating strategies. Again, dental prophylaxis, in general, we time dental prophylaxis at least to 7 to 14 days prior. HBOT cover, again, as madam said, is a negative trial. 4 large Cochrane meta-analysis have shown that there is no evidence for HBOT during dental implantation, no evidence for PRPs as well as fluoride pastes, and in general also wound basins rates are only marginally improved with HBOT but not statistically significant. You have to treat 4 cases to get 1 evidence, but this is also an imprecise estimation. So this is the common thing that we use, the Marks protocol, 20 prior and 10 after a particular intervention, but no level 1 randomized evidence for this particular. Pentoclo, madam, you said you use pentoclo regularly?
Because again, there is evidence between pento and pentoclo which have come. So you can also do pento, that is pentoxifylline plus what you call tocopherol without using the clodronate. And they've shown good results actually. But of course, when you have a fractured bone, then you have to think differently.
Sure. So no role for USG therapy and bone mesenchymal stem cells. So in essence, it's a difficult treatment option. No level 1 evidence for any form of treatment. I mean, surgery remains a gold standard if the patient is fit and you fail conservative treatment. Early identification of treatment is actually preferred over delay. Thank you all the panelists for your valuable time.
As a surgeon, when we are doing surgery, if you find any sort of a caries teeth, specifically if possible, just extract the teeth. How many of us will be sending back to the dental, then rehabilitation, then for radiation? All this cycle usually doesn't happen in routine practice. But when you're operating, if you feel there are any caries teeth,
so preoperative dental prophylaxis, intraoperative caries tooth excision, antibiotics. Yeah, sure. Thank you all for your time, and I thank the audience as well. Yeah, anybody else has got some doubt? Yeah. Thank you all for your time. Thank you so much.
Thank you so much everyone for the enlightening discussion. So moving forward, I would like to invite Dr. Nagarjuna Burela, Consultant Radiation Oncologist, Apollo Proton Cancer Center, Chennai, to discuss on topic summary of evidence and utility of proton in head and neck cancers. So, sir, over to you. Thank you.
Good afternoon, everyone, and thanks to Dr. Kaushik sir and the organizing team for having me today for this lecture. Today, briefly, I will tell you about this summary of evidence and utility of proton in head and neck cancers. Why proton therapy in head and neck cancers? We all know that treatment of head and neck cancer is not easy. It is morbid treatment which have acute and late toxicities associated with it. And there is increased incidence of HPV associated oropharyngeal cancers. And these HPV positive patients have done well, are doing and also doing well, and have live longer and cured. So we have to mitigate the late side effects that's happening in these patients, which is crucial in the treatment. So till now, IMRT represents the state of art of RT for head and neck carcinoma, but its exit doses to the photons increases the toxicity, that is acute toxicity and late toxicity, and also increased incidence of second cancers. So there is growing interest in the particle therapy, that is proton therapy, because of its natures of no exit doses and maximal dose release at tumor depth and sharp dose fall off and effective OR avoidance. So the physical advantage of proton therapy mostly lies in its physical property Bragg peak. Briefly, I simply in simpler terms I can tell this by simple picture that Bragg peak is similar to whatever skyrocket we use in our Diwali. So where when protons enter into the body, where there is less dose deposited while passing through the tissue, and before it tries to stop, all the energy is deposited. That is the Bragg peak. And now next, the mass of the proton is really 2000 times that of electron, means that heavier than the electron. So the more the heavier the particle, the more the staggered and clustered double strand DNA damage happens, and it helps in actually this biological property makes the heavier particle proton therapy better than photons. So with the photons, we can see that there is exit dose, and with proton therapy, no exit dose. So because what is the exit dose? There is no dose beyond the tumor. So that we can decrease the doses to the surrounding structures beyond the tumor, thus reducing the toxicity and improving the quality of life. Yes, everyone knows head and neck treatment is morbid because it is associated with side effects acute, most commonly this oral mucositis and xerostomia, that is dry mouth, dysphagia, and not only that, but also the weight loss and also malnutrition. And the chronic complications and toxicities like xerostomia and tube feeding dependence and also ORN. So already Quantec has defined that severe xerostomia can be avoided if single parotid receiving D mean of less than 20 gray and bilateral parotid receiving D mean of less than 25 gray. And Ibrook et al. Have said that with increasing doses in the pharyngeal constrictor and glottic and supraglottic larynx has shown that directly in relation with the increase in the aspiration and also associated with dysphagia. So if we see the benefits of proton in definitive settings, this study specifically compared the acute toxicities and also patient reported outcomes between IMPT and VMAT in HPV positive oropharyngeal cancers. This is the largest study actually done by Mayo Clinic and Anderson together, where they have compared the 46 IMPT and 259 VMAT patients, prospectively assessed patient reported outcomes with HNQL35 and provider associated toxicities with CTCAE4. So in results like you can see that the patients who have received IMPT have lower PEG placement with the odds ratio of 0.27 and less hospitalization that is within 60 days of post-RT with odds ratio of 0.21 and relative risk reduction of 22.3% for the end of narcotic use. If we subset analysis, if we see that these three things, the more strongest benefits is seen in patients who have definitive and concurrent chemoradiation. What about the late toxicities? And that is the xerostomia. This is the more compelling study that actually in patients who have used the proton therapy, the late toxicity xerostomia means like moderate to severe xerostomia is less in these patients. Where this is done by Anderson group, where they have evaluated 429 IMRT patients with 1 or 3 IMPT. The xerostomia specific questionnaire was given and then evaluated every 3 months. And if the score is more than 50, they will label it as moderate to severe, and less than 50 as no or mild. And if you see that till 18 months, there is no difference between the two arms. That means I mean the photon and the proton arm. And from 18 to 24 months and 24 to 26 months, actually we started seeing the difference between the two arms. And in patients who receive proton have this late xerostomia, that is moderate to severe xerostomia less. In particular, if you see this group, actually there is direct dosimetric correlate with the oral cavity doses. So the people who are receiving, means like in IMRT group, who have high dose per volume exposures to the oral cavity, that is volume receiving 25 to 70 gray, associated with high moderate to severe xerostomia. So yes, late toxicity, that is the osteoidonecrosis. This is by Stephen Frank group, where they have assessed 534 IMRT and 50 IMPT patients with a median follow of 33.8. In patients with proton arm, the mandibular doses are less, means the D mean is 25.6 versus 41.2. The maximum dose in both is same in the both groups. And we can see that in the IMPT, there is 2%, ORN rate is 2% in IMPT versus 7.7 in IMRT. And the significant osteoidonecrosis has started seeing only in patients where there is high mandibular percent volumes, that is volume of the mandible receiving the doses more than 35 to 70 gray. And to this counterpoint, there is one more study by Sloan Kettering, as Dr. Sharbani has said that, where in the proton arm, actually in that study from by the Sloan Kettering by Nancy Lee, they have said that the ORN is more with the proton. If you go in depth, as Madam said that they didn't pre-dental evaluation has not done properly, and also the doses they have given. So to summarize the toxicity benefits of proton therapy, Mendenhall et al. Has reviewed the studies which compared the IMPT and IMRT, and all these studies really show that with the proton there is reduction in the mucositis, analgesic requirements, PEG placements, even the hospitalization rate, and osteoidonecrosis, and reduced incidence of second cancers. So now coming to the benefit of proton in adjuvant setting. So where the Sharma et al. Has compared 64 patients in oropharyngeal cancer who underwent TORS, PBT and VMAT compared, and significant less xerostomia at 6 and 12 months in the proton arm. Anali also has reviewed the proton therapy in the management of nasopharyngeal cancers out of 9 studies. 4 studies were compared IMPT and IMRT, and 2 studies have shown lower feeding tube rates with IMPT, and 2 studies with lower grade 3 toxicities. And in this review, the proton arm, the grade 3 mucositis incidence is 7 to 11%, which is usual 29.4% in the RTOG 0225 treated with IMRT. And not only that, in unilateral, Romeser et al. Has showed that there is this benefit in reduction in the doses to the oral cavity, parotid, and submandibular and spinal cord, which directly correlated with the acute toxicities, that less dysgeusia, mucositis, and nausea. Okay, till now we have studied the dosimetric outcomes, but what about the dosimetric and acute toxicities? What about the outcomes in head and neck cancer? This is a Taiwan study from Chang et al., where 60,000 patients have analyzed, and after propensity matching, 92 patients were analyzed. A multi-center study, and which showed that the patients who have received the particle therapy, but not sorry, that proton therapy, have better overall survival, cancer-specific survival, and local regional recurrence. And then we should actually discuss this. This is the recent randomized control by Stephen Frank group from Anderson, actually delivered in the late 2024 ASCO annual meeting also, where they compared IMPT and MRT. This is the randomized control trial, where 220 patients in the each arm with median follow-up 3.14 years. And it is multi-center randomized, but phase 3 non-inferiority trial. With primary endpoint, you can see that this is the progression-free survival at 3 years. This is the primary endpoint. And second endpoint is OS and also gastrostomy dependence and treatment-related malnutrition. And if you see the results, the per protocol overall survival analysis suggests protective role of IMPT. Though we are seeing there is quite deviation in the curves, but there is not much significant till the whatever the study has told us. And IMPT decreases the risk of per protocol gastrostomy tube dependence in compared to IMRT. So this is the only one trial till now we have that randomized evidence. And what about this? Already in the previous speakers has discussed this, Patel et al. Regarding the charged particle therapy in PNS tumors. Yes, they have compared the patients who received charged particle therapy, either proton, carbon, or other heavy ion, with photon therapy. In these patients, it showed overall survival benefit and DFS benefit, not a local regional control. And in the subset analysis, when they compared with the proton and photon arm, there is improvement in the local regional control, not in overall survival and DFS. So, okay, with this evidence, there is growing interest in proton therapy, and the centers are getting available right now. So the next is how to select the patients. This is a Groningen from Netherlands. They have individualized that model-based approach for selection of proton therapy. So they have made 2 plans, and they have dose volume parameters of ORs. They found the relation with the certain adverse event and calculate the NTCP. And for the dysphagia, if the NTCP is more than 10% difference between the two modalities, and xerostomia more than 10%, and dysphagia and xerostomia combination more than 15%, and tube feeding dependence that is more than 5% have been qualified for proton. And there is also one study from Tambas et al. Where 22 European centers have been participated, and the electronic questionnaire has been given which adult cancer patients is required. They have mentioned it as 4 main group that really proton therapy has been advised in head and neck cancer. They are locally advanced head and neck carcinoma with primary close to the skull base, that is close to the skull base means close to the optic apparatus and also the brain, and tumors of nasopharynx and unilateral neck irradiation, and in patients where the dose to the brain has to be reduced. So coming to the utility, yes, it has its role in skull base and PNS cancers, salivary gland tumors, nasopharynx, oropharynx, and re-irradiation. So this is the, if you see the one of our patients, I want to show that the comparison plan of proton and photon with the nasopharynx. Simply, we can see the doses comparison, also the better, dosimetrically better with proton. But if you see, this is this isodose, pink isodose wash or line, isodose cloud. It is showing that the mucosa and the middle, inferior, and cricopharyngeus and larynx, we are able to spare, which are because these are the main structures that makes the treatment morbid. And similarly in the oropharynx, yes, we can reduce doses to the oral mucosa and inferior constrictor, cricopharyngeus, and larynx. And in the PNS, yes, here are the 2 plans. The top one is the proton and the bottom one is the photon. When we have done the target and we asked our physicists to plan with the both modalities, with the photon means we have helical tomotherapy plan, what we IMRT plan, what we do in our center. So we asked our physicists to keep the OIR doses constant same and have looked the coverage. the proton therapy arm has shown better coverage. Though we can see that 95% in proton is 99, sorry, D95 is 99 and photon D95 is 96. Though it is following the 96, 95, but if you see the slice based list, that is very much crucial for a radiation oncologist while analyzing the plan evaluation. You can see the structures that is close, target that is close to the optic apparatus has more underdose than in the proton plan. And not only that, if you see the low doses are like 18 gray is so much spilled onto the normal brain parenchyma and temporal lobes. Coming to the oral cavity, yes, we can see the reduction in the constrictors. And not only in the constrictors, the other structures like larynx, uvula, epiglottis, we have difference, mean difference that we have seen from 38 to 66%. Yes, in unilateral cancers, yes, in decrease in the oral mucosa dose, opposite buccal mucosa, constrictors and larynx. Larynx we are able to achieve less than 20 gray and oral mucosa less than 10 gray. So here one of our patient, this is one of our patient like re-radiation. Like nasal high-grade neuroendocrine carcinoma in 2010 diagnosed, treated NSCT with chemoradiation to a dose of 60 gray. He recurred in 2019, and when he came to us, NSCT endoscopy surgery, when he came to us, we have evaluated and we have calculated the remaining dose, what can be delivered. That it tells that the optic nerve right should receive 16 gray and optic nerve left should receive 24 gray. So when we asked our physicians about the plan that we have given primary importance to the target coverage and also the ORs here. This green is the 15 gray isodose color wash. You can beautifully see here that with the proton plan in the re-radiation setting, we able to curtail the doses to the optic nerves as prescribed. So we have published our own studies that where IMRT and photon comparison, we have seen 7% absolute benefit, NDCP benefit. And our physicists have developed the in-house script that is planning strategy to reduce the radiation dermatitis, which have been published in radiation oncology. And not only that, while planning, the important thing to keep by a radiation oncologist for the proton planning is the getting the composition of the dental material. So we will be in touch directly every time with our dentist whenever a patient comes, because we have to know whether the dental filling or the artificial tooth is made of GCAM, amalgam, acrylic, because their composition, and if it is post-op, either they keep titanium plate or what other material. Because this has to be accounted while planning, because they have to assign certain value, whatever required, because bone is like plus 1000 above, but these materials, the house units are different. This has to be accounted while the physics planning is done, because if you don't account this, there will be a lot of uncertainties. And make sure that our beams doesn't pass through these metals. And during treatment, the other important thing we have to is the QCT evaluation. What we QCT in our institution means, these are the check scans that we do during intermittently, like after every 7 to 10 fractions. Check for the weight loss, and is that weight loss perturbing the dose? Yes or no? Yes, in this patient, when there is a weight loss, if you see, you can see like it's like evaluation of the beam path changes. It is very much crucial while evaluating the plans and making that plan uniform during the whole treatment. So here with the weight loss, there is a reduction like 3 to 4 millimeters, but we can see because of that there is a hot spot on the periphery of the target, which increases the actual toxicities. And also the matching of the lower neck, the shoulder is the main challenging for the therapists also, and we should be careful. See here one of the patient where there is setup error, there is quite the dose perturbation in the lower neck nodal volumes. The other thing, yes, what the Sharbani ma'am told like that the monitoring of maxillary sinus and nasal filling and emptying is very much crucial, because this is the plan that was made when the on the day 1 scan, when the maxillary sinus is empty, and during treatment he may have cold or he may have the symptoms like there is increased thickening of the nasal mucosa, which making the underdose in the target, because this dose perturbation is there. So you have to criteria like either you should make that when to make the adaptive plan, and either it may be sinus filling or it may be sinus emptying. So we have our oral cavity oropharyngeal cancer patients that we have treated 61 patients so far, most of the stage 3 and 4, and with median follow-up of 14 months and with 2-year survival of overall survival 83% and local control of 79.4%. And skull-based adenoid cystic, if you take only skull-based adenoid cystic cancer of 13 in number, 2-year local control is 80. And all skull-based excluding chordomas, if you see our local control 2-year is 75%. So in conclusion, I can say that head and neck cancer, ideal indication for use of proton beam therapy, And curtailing doses to the parotid, constrictors, and oral mucosa to make treatment less morbid is truly essential. And it is important that if the tumor is in and close to the optic apparatus or brain parenchyma, where with the normal photon technique it could not be, where the dose constraints cannot be achieved, yes, proton therapy is indicated. And we have enough dosimetric studies and PROs to tell that proton better than photon. And evaluation of the changes in the beam path length is critical important. And we have to keep the regular attention low threshold for QSCT scans for any weight loss or beam path change or sinus filling or emptying. And adaptation is required. So with this, I conclude my study. And I thank all my seniors and everyone.
Any questions? The lesion is close to the optic nerve and
Yes.
the optic chiasm. Protons may be ideal. But I would like to disagree with you
As
because,
you said, that is correct. At least we need a gap of 5 to 7 mm.
yeah,
That
because
is sure. That is because if that is not there, it is even proton
it's
also very
impossible,
difficult.
you
Impossible,
know.
correct.
And another thing is, I know that you've shown that there is a difference between tomotherapy and protons, but at the same time, I think the improvement, or rather the good plan with photons, is also a function of your physicist.
Yes.
Because, you know, if you see with time, actually, physicists have actually gained a lot of control on the photon planning,
Yes.
which has not happened with protons. Now, you've got it for 6 years, almost 6.5
Yes, yes.
years, more than that. So that takes, there's a steep learning curve for protons, I've realized. It's not, because sometimes even I get so frustrated, I said, photon pe treatment karo. That's the thing, because, you know, sometimes we want essentially, but yes, what is very good about protons is that sharp cut.
Yes.
You know, on the opposite side, you don't see any
Yes, yes.
reactions. That's the best part of proton therapy.
This I can tell you, ma'am. In our initial learning curve, like first 2 years, we ask our physicists to do the photon and proton. So sometimes our physicist has got the better plan with the helical tomotherapy technique. So again, our proton physicists have went back and done that. Why can't we decrease than that? Really, that is absolutely sure, because we have rival challenging plans between our physicists only. That made us the learning curve. Yeah.
I have one more question. What is your take on flap sparing radiotherapy? Maybe Sarvani madam also can come in.
Flap sparing, but even post-op, it is the indication.
No, in
that flap
adjunct
has-
therapy, you know, we do keep bulky flaps like ALT, PMMC, fibula with implants. But our, radiation oncologists always find they are not happy about sparing the flap. But, you know, it's like a normal tissue where there is no tumor at all. So, what is your
But as a
thoughts?
radiation oncologist, I will be interested in including the flap, because it is the post-op bed that has been manipulated to be treated with the whole dose.
Yeah.
If you have the guidelines, if you look at the guidelines of covering the flap, one guideline is for sure, that is you would want to cover the tumor flap interface, because that is where they fail. Now what happens is the flap is usually not covered intentionally. The flap is not your tumor bed. You know what you need, that's why it's very important again here that you actually do a good fusion. But it depends again on the certainty of the fusion. And that's why what is important for us to ascertain as radiation oncologists is that we've covered the bed of the tumor, not the flap. The flap is not the bed. But what happens is that unintentionally it gets covered just to be safe, that we are not leaving behind. And we don't go to cover the flap. We are more interested in covering the tumor bed and the junction so that we don't miss out.
Intentionally spare the flap. You are sparing constrictor muscles, which is like such as, you know.
The flap is not
But
doing.
The problem is the flap, when it gets radiotherapy, all the function, the problems of the, you know, swallowing, speech, everything is affected. So can you take some intentional attempts to spare at least part of the flap?
No,
Just a thought.
No, so Indraneel wants to say something, but you know, we don't intentionally treat the flap is what I'm trying to impress upon you. We don't intentionally treat the flap. I don't want to treat the fibular strut. It is a problem for me also. But I will definitely treat the tumor bed and the junction. In that, whatever comes in, comes in. We don't want to treat it. Indraneel?
Yeah, I think that
very valid point that, you know, we should attempt to intentionally avoid. But there are 2 or 3 practical issues. One, that the junction between the flap and in the post-operative situation is sometimes open to interpret. It's not very clearly demarcated, and people will do different things. So I may contour differently, madam may contour differently. It may be quite difficult for you to assure quality treatment. So that's one challenge. The second challenge is a part of the flap, and you know, all the inside part of the flap will be in the target volume. And I'm not that sure that you will get a lot of function sparing. Having said that, cosmetically, definitely, I think that there is and there are now guidelines on how to contour based on flaps also. There's, you know, long-term evaluation of the results of that, which is point.
This is the last question. After that, lunch is ready for you. So, there have been proton skeptics in the past, and now, thanks to your team's work, that I think the number of proton skeptics are coming down, and routine proton topics are becoming part of a standard mainstream, you know, discussion. Is there a evidence of using proton for moderate hypofractionation that we use in head and neck so often, like SIBs, or that you have to do at 200 centigrade, or you can do 220 such?
Look at the MSKCC publication. There are 2 groups of patients. One is with routine fractionation, that is conventional fractionation, and the other one is a quad shot regime. The quad shot people didn't do as well, but it was safe to use. So that means you can definitely hypofractionate. What we as radiation oncologists need to decide is what is going to be our optimal target volume. Once we can decide that, there is evidence emerging about hypofractionation in protons. If you see the MSKCC paper, it is conventional fractionation versus quad shot. So that means you can definitely do hypofractionation.
Thank you.
Thank you so much, sir. Now, I request everyone to have lunch. We are having the lunch break of 1 hour. So, I request everyone to have their lunch and come back to this session. Yeah, thank you.
Sound too bit. 30% the bit.
Behind me is the roar of passionate fans. Over me is a spotlight following my every move. Ahead of me is the mountain I have to climb. So I stretch my limits. No sweat. Not a wrinkle of worry. I'm Raj Gaikwad, and I choose to rise.
Are you having any laugh? Are you getting any loving? If other people do, why can't you have a little fun?
Good afternoon, everyone. I hope everyone have had sumptuous lunch. Moving on, we have the next round of discussion regarding surgical management of ITF involvement in oral cancer by Dr. Krishna Kumar Thankappan, Professor, Department of Head and Neck Surgery, Amrita Institute of Medical Sciences. Thank you.
Good afternoon. So I was asked to talk surgical part of infratemporal fossa clearance in oral cancers. With the permission of the organizers, I have changed a little bit the title, but the substance will be almost the same. So we'd like to introduce this dual window approach for compartmental resection of maxillary bar gingivobuccal sulcus tumors with infratemporal fossa involvement. So this is a case in question. It is an upper JB sulcus tumor extending to the maxillary tuberosity. And you can see there is, in the CT scan, you can see there is infratemporal fossa involvement. The conventional approach for such type of tumor is an upper cheek flap with an infrastructure maxillectomy and soft tissue clearance, and the smaller tumors may be even taken out through a peroral approach. And such approach is an anterior to posterior approach with a high chance of positive margins, bleeding, and fear of injuring the unknown. And this is what happens usually. Most of them fail. They can fail at the RMT, they can fail at the infratemporal fossa, or they can fail at the skull base. But how does this happen? We have to understand two things about this: the anatomy and the pattern of spread. Anatomy, we all know, this is the area with the maxillary tuberosity, inferior alveolus, pterygoid plates, pterygopalatine fossa, pterygomaxillary fissure, and the inferior orbital fissure and the skull base. Infratemporal fossa is a non-fascia lined space, which includes a masticator space except the the masseter muscle, and it also includes part of the parapharyngeal space. Note the lateral boundaries of this infratemporal fossa, that is the coronoid process here, as well as the zygomatic process. Okay, note these 2 points. I'll be talking about that a little bit later. So pertinent maxillary nerve branches in this area are the posterior superior alveolar nerves and the greater and lesser palatine nerves. So this is a branch of maxillary artery coming out of foramen rotundum. You heard Dr. Deepa talking about it, with the pterygopalatine fossa, and supplying these nerves to the particular tumor area, the posterior superior alveolar nerve, and the palatal nerves, the lesser and greater palatine nerves. So the tumor can spread along these nerves to the pterygopalatine fossa. Also important is pterygomandibular raphe, with its attachment to the pterygoid hamulus above and mylohyoid line below, connecting the buccinator anteriorly and the superior constrictor posteriorly. And superior spread of the tumors can happen to masticator space and pterygopalatine fossa through this pterygomandibular raphe. And once the tumor reaches the pterygopalatine fossa, it can go anywhere. Like it can go to the infratemporal fossa, to pterygomaxillary fissure, orbit, nasal cavities, middle cranial fossa, palate, foramen lesserum, vault of pharynx. It can go anywhere. That is pterygopalatine fossa communications. So what is compartmental resection? It is a resection involving the anatomical tissue beyond the definition of conventional margin for that area as a compartment, but preserving any uninvolved critical neurovascular structures to achieve better oncological control. It is a resection involving the anatomical tissue beyond the definition of conventional margins for that area. So this is the routine resection, and this is the compartmental resection. We remove the tumor along with the compartment. And it is a resection in the third dimension. It is a posterior to anterior resection. The deep margin is dealt with first. The vessels are ligated. The deep soft tissue structures are individually identified and resected. These are the pictures I have taken from Neeraf's textbook. So the compartmental resection in this area should encompass the posterior alveolus and the maxilla, pterygopalatine fossa and its contents up to the skull base, contents of the infratemporal fossa, masticator space except the masseter from its distal attachments, and maxillary artery ligation has to be done in the initial stages itself. So that is compartmental resection for maxillary and upper GP sulcus tumors. And the boundaries, as I said, we can see the lateral boundaries, the zygomatic process, the coronoid process, and it include all this infratemporal fossa as well as the part of the maxilla according to the tumor, maybe a total maxilla or a posterior maxilla. And what we used to do previously was a mandibulotomy approach. And the surgical steps would be a mandibulotomy, detaching the pterygoid muscles from the mandible and the skull base, vascular control, that is ligating the maxillary artery, detaching the pterygoid plates from the skull base, preserving the contents of the foramen ovale, that is a posterior limit, and then appropriate reconstruction. This is what we used to do with a mandibulotomy approach. We had published this, and this is how we could get the specimen as a compartment. It was well and good, but we were finding some difficulties. What were the difficulties? We were finding difficulty in getting the superior most exposure at the skull base. We were finding it get difficult. and of course the complications of mandibulotomy like osteoradionecrosis, plate-related infections, malocclusions, and trismus. And that's when we came up with this particular approach of dual window approach, and that is an approach to the infratemporal fossa by opening the two lateral boundaries, namely the zygomatic process and the coronoid process of the ramus of the mandible. So this is the access which you get when you remove the coronoid process and the zygomatic process. Okay, you can see the posterior surface of the maxilla, the pterygopalatine fossa, the pterygoid plates. So this is a diagrammatic representation. So we have the masseter first, which is detached from the zygomatic arch, and then we resect a part of zygomatic process. Okay, that is the first window, and then we remove the coronoid process separately along with the temporalis muscle, as far as possible, the temporalis. And then we get a direct exposure to the infratemporal fossa. You can see the pterygoid muscles, the superior orbital fissure, and then you detach all these muscles distally. I mean, for the lateral pterygoid muscle is detached from the coronoid process and the skull base. Medial pterygoid muscle is detached from the inner surface of the ramus of the mandible, and then you could see directly the pterygoid plate and the skull base, and under vision you can cut the pterygoid plates, and then rest of the maxillectomy cuts are completed and the specimen is brought out. So that is the concept of dual window approach, and I will show a video. So again, this is the incision as was told by Dr. Deepa. We usually prefer a subciliary approach, and then the cheek flap is raised. You can see the medial pterygoid muscle nicely. The masseter is detached. And then you mark the zygomatic window. That's a coronoid window. And then with the coronoid process, you cut the temporalis muscle as far as possible, and that will serve as a lateral margin. And removed. And then you are directly facing the infratemporal fossa. And then we can identify the maxillary artery between the pterygoid muscles. It has to be ligated, and then from laterally we will be able to see the skull base, and the pterygoid plate cutting is done, and then medial pterygoid is detached from the mandible inferiorly, and the lateral pterygoid has to be detached from the condyle as well as the skull base. Here we are not seeing it properly because the camera is from above, but actually from laterally it is a straight cut, straight visualization. And then you do the maxillectomy cuts as required, whether it is a lateral total maxillectomy or a infrastructure maxillectomy, whatever. Here it is a total maxillectomy. It's a different case. And the posterior cut at the skull base, that is a detachment of the pterygoid plates, might have already been, it is already done. And so the specimen comes together along with the maxilla, the contents of the pterygopalatine fossa, all the muscles in toto. So that's a maxillectomy. And the limits of the infratemporal fossa, superiorly the skull base, you can see the foramen rotundum and the foramen ovale. That's the bare skull base bone with the foramen rotundum and foramen skull base. And reconstruction was done with the fibula and wound was closed. So that is the approach which we are doing nowadays for such tumors. Some data about how many cases we have done. Till now we have done around 19 cases, age 33 to 71, males 15, females 14, and majority of our tumors were infratemporal, high infratemporal, meaning that the tumors which are going above the sigmoid sinus nodes and reaching even up to the foramen, but not involving it. If the tumor is involving the foramen, the foramen ovale or the foramen rotundum, we don't usually do it. But if not, even if it is reaching, we go for this approach. And the majority of the cases were squamous cell carcinoma. We could achieve clear margins in 12, involved in 7, and most of the cases were obviously adenoid cystic carcinomas and other tumors. We had recurrences about 5 out of this 19, but local recurrences was only 2. But mind you, the follow-up was only 12 months, and 13 out of 19 patients are alive and disease-free without any Christmas or plate-related problems. One problem which we faced was that little bit of facial deformity because of the removal of the zygomatic process. But here again, we are thinking about pre-plating the zygomatic area before it is cut, and detaching it along with the masseter, bringing it down and later putting it back so that we can do it without this deformity. To conclude, a compartmental resection is a concept proposed to remove any tumor along with its anatomical compartment, including tissues beyond the conventional concept of margins. We describe a new approach to the infratemporal fossa for maxillary or upper GB sulcus tumors with the infratemporal fossa extension. It gives excellent exposure with vascular control, and oncological and functional outcomes are good in this early subset of 19 patients. Thank you. We have some time, maybe some questions.
So I just wanted to ask, is this approach good for medial infratemporal fossa extensions like we get on upper sulcus tumors creeping along the maxilla, or maxillary tumors with retromaxillary extension? Or do you think the lateral exposure in the ITF is a bit limited and shielded by the preserved mandible?
No, it can be used in all of these tumors, but only then if the maxillectomy cuts has to be designed accordingly. Even it is good for the mandibular tumors. Mandibular tumors going to the infratemporal tumors where we may have to clear everything. The approach, the infratemporal fossa approach, is open in front of you.
So if you have, say, an RMT lesion which is involving the upper GB sulcus going into the ITF,
yeah,
and you're anyway going to commit for a hemimandibulectomy,
yes,
retaining only the condylar process.
Correct.
So then anyway you give a mandibulectomy, mandibulotomy, and you would be splitting open the mandible.
Yeah.
And in this case, for example, the orbit is free and there is in breach of the
Yeah, I understand your question. If you are doing a mandibulectomy along with it, then you may not need to, full expose the.
But the zygomatic cut, but with a window, with the second window, what you're saying, is it really used or because anyway your exposure will be.
If you have a high ITF involvement,
Okay.
even with the mandibular, it may be rare, but if you want to clear the high ITF,
Okay.
that is when that window helps you.
Okay. Any other questions from the audience? Madam? Yeah.
If you need to clear this, one approach would be to do a lower midline split rather than a maxillary split, and you can.
That is a mandibulotomy, typical mandibulotomy approach.
No, you don't need to do a mandibulotomy. If you can do the same exposure by doing a coronoidectomy and clearing it with, but not doing a upper split.
Yeah,
so you
that
get
is-
a better access from below.
No, you will be limited at that skull base. That's what. This gives a little more better exposure if you do that. Making that skull base pterygoid and superior orbital fissure, cleaning all the, the greater wing of sphenoid, all those superior most infratemporal fossa and pterygomaxillary fissure area. This will add to your. Of course, you can do it. We were doing it with mandibulotomies.
One last question. So first you would do the zygomatic cut, sir.
Yes.
Then you would do the coronoid. If you are retaining the mandible, you will do the coronoid cut.
Correct.
Then you will clear the ITF, and then last you will do the palatine cut and the. If you are going for a
correct.
subtotal maxillary.
Everything. That's what posterior to anterior.
Posterior to anterior. Zygomatic cut, then coronoid, then pterygoid plates.
Pterygoid plate cutting, detaching all the muscles
of the pterygoid.
Maxillary artery ligation. It's all in front of you.
Yeah, and then last you do the palatal cut and the front. Sure, sir. Thank you, sir. Because we have a case tomorrow on Monday with a similar thing, RMT going on to the upper GBS and low ITF involvement with maxillary sinus involvement.
Yeah,
so
try
we
this.
are planning, so I will
Try this
definitely
and-
try this. Thank you.
Thank you.
Any more questions from the floor? Thank you so much, Dr. Krishna Kumar. Our next topic of discussion would be current management of N0 neck and oral cancer by Dr. Deepak Sareen, Vice Chairman, Head and Neck Services, Head and Neck Surgeon, Vedanta Hospitals, Gurugram.
Good afternoon. Good afternoon, and thank you very much for the invitation for this talk in this beautiful center. My talk is a bit more basic than what we've heard throughout the day, addressing a very basic concern that we have to deal with when dealing with how to address the N0 neck. And the talk basically I put it in 4 parts. One is how do we stage an N0 neck? What's the current standard of care for the N0 neck? We'll touch upon certain nuances and controversies when addressing the N0 neck. And finally, the last part on some trends and future directions which we need to look at when addressing the N0 neck. So N0 neck by definition is a neck that doesn't have disease either clinically or radiologically. And when we treat this, we are treating this electively on the presumption that it harbors microscopic or subclinical disease. Which imaging is best to stage the neck? If you look at Lauer's meta-analysis, where he compared the 4 commonly used imaging techniques, really if you see there is really not much difference between any of the techniques. The sensitivity of all of these lies between 50 to 70%, and the specificity is between 80 to 90. So really practically when we are looking to stage the neck, we often choose the imaging based on the primary, and whatever we think is best for the primary is generally appropriate for the neck as well. We assess the risk of metastases based on certain factors on the primary. These are just a few of them, not all. And traditionally, by consensus opinion, it was felt that if the risk of micrometastases is more than 50 to 20%, then the neck should be electively treated. But this is again a consensus decision, and the threshold may vary a lot between centers. based on what we think the presumed benefit versus the side effects of addressing the neck are. I think to understand where we've reached, it's a little bit worthwhile to step back a bit in history and see how we've evolved. So the radical neck dissection has been with us for over a century, described by Kreil, but really championed by Hayes Martin in the 50s. And this operation, which include all the 5 levels of the neck as well as the non-lymphatic structures, became the standard of care, both for the clinically involved neck as well as the clinically negative neck. But as was apparent, because there are significant morbidity associated with it, it was apparent that in cases of N0 neck, often it's an overtreatment, but not offering any neck surgery often resulted in failures. I think a bit of evolution came with the work of Osvaldo, Suarez, Boca, and Pignataro, when they showed that the non-lymphatic structures are preferentially not involved by neck metastases, and that led to the evolution of the modified radical neck dissection, where some of the non-lymphatic structures could be spared. And while the MND did acquire popularity in treating the neck, I think further efforts to reduce the extent of surgery in the neck, especially in the N0 or N plus neck, were somewhat thwarted by the fact of understanding certain factors lead to increased recurrence. For example, the role of extracapsular spread. This got recognized as a significantly poor prognostic factor and was often seen in nodes actually that were sometimes small, less than 2 centimeters in size. So at one hand, you wanted to reduce the extent of neck surgery, but on the other hand, you had factors coming in that said that patients with these ECS, for example, did really poorly. So that thwarted the attempts for any further conservation. The foundations of the selective neck dissection really were laid down by studies that looked at clinical as well as pathologically mapping what are the lymph node basins that are preferentially drained by different subsites in the head neck. And once we understood which site drains where, we were now able to at least conceptualize an operation that said if we can preferentially just remove the lymph nodes that are the first echelon of drainage, we should get a really good, accurate staging of the neck. It should reliably tell us what the status of the neck is. And that was the selective neck dissection. For the oral cavity, the stations were stations 1, 2, 3, and it was very rare for disease to miss these stations in an N0 neck. And therefore, this procedure that was initially, I guess, theoretically advocated as a staging procedure, where if you did find a positive neck, you could theoretically consider completion surgery, etc. It was soon clear that the procedure also has a clear therapeutic benefit. When you look at pathological N positive, which were clinical N0 and were treated by a selective neck, there was still excellent control rates in the neck. So what initially was a staging or a diagnostic operation soon showed it has therapeutic value as well in the N0 neck. And quickly then, this became the standard of care when the N0 neck had to be addressed selectively. And that's where we probably are with the most, I think, universally practiced surgical approach to addressing the N0 neck is with a selective neck dissection. There were, however, some differences in how it was addressed in early stage cancer, because it was always the indication to address the neck was always based on the probability of neck disease. For early stage cancers, many centers continued to use the policy of observation, saying the risk of metastases is low, doesn't warrant upfront selective neck dissection, and if patients recur, we can probably salvage them effectively. But this to a large degree was negated, this approach of wait and watch, by the excellent paper that's come from India with a couple of authors actually in the audience as well, which was a randomized controlled trial looking at whether upfront elective neck dissection compares with a wait and watch policy with salvage only in cases that recur. And it was pretty clear that even with early oral cavity cancers, if an upfront neck dissection was offered, the recurrences were reduced by 25% and the mortality reduced by 12.5%. I think with a very well constructed randomized control trial, that pretty much laid the basis for offering elective neck dissections in all oral cavity cancer cases that are staged N0. There is one small caveat though. I think with tumors that are very thin, you have a very, very low percentage of neck metastases. And this can be less than 5% in tumors that are under 3 mm. So if you look at it, it stands to logic. When you have a probability of neck disease 30-40% in T1, T2 tumors, an elective neck dissection clearly offers benefit. But when the probability of disease is exceedingly low, the thought is an elective neck dissection might be overkill. And that's why this is one area where there still exists controversy and difference in patterns of practice. Is for very, very thin oral cavity cancers, observation is still offered as a choice in certain institutions and with certain practice personal preferences. The question, of course, practically is how do you know a tumor is very thin? When you take somebody up for surgery, you often don't know that. That's a microscopic diagnosis known post facto. But there can be situations where this is available to you and the decision now has to be made now whether the neck is to be addressed or not. And this could be used as an alternate as well. I'll touch upon some nuances and controversies, and because there are nuances and controversies, there will be little difference in how all of us approach these. And I do appreciate that there will be differences in opinions on these portions. I think one of the issues that came up a while back was skip metastases to level 4 in oral tongue cases. And on Bob Byers' paper, which showed a very high incidence in level 4, it was said that the minimum neck dissection for every tongue cancer should include level 4 because of the high incidence of level 4 mets. But looking at that paper, it wasn't isolated level 4. It often combined 3 and 4, and numerous other publications that have followed that have shown that isolated mets to level 4, the absence of involvement of other levels, is actually exceedingly rare. And therefore, no longer is it absolutely necessary to dissect level 4 in oral tongue cases. The other controversy exists whether we should address level 2B in a standard selective neck dissection being done for oral cavity cancer. Again, if we look at multiple trials that have looked at the involvement of level 2B, it's basically very low. It's under 5%. And that's why some people do advocate that you do not need to clear level 2B in all cases. However, if you look at these papers, level 2B involvement was correlated with disease in level 2A. In other words, if you had disease in level 2A, level 2B was not infrequently involved. And that's very difficult to assess with certainty intraoperatively. Certainly not by inspection or palpation. And unless you want to freeze every node in level 2A and use that as a judgment call, which also again may not be accurate because we know frozen section intraoperatively also misses metastases. It kind of becomes very difficult to be sure whether 2A is involved or not. So at least in my practice, I continue to dissect level 2B in all selective neck dissections for oral cavity cancer. I'm also biased by a few other things. And when you look at really close analysis using PCR, the incidence may not be as low as we think. And when we look at sentinel node biopsy studies, often level 2B is one of the first echelon drainage nodes for posteriorly located oral cavity cancers. So at least in my practice, I do it, but certainly there's a school of thought that says it may not be necessary, and not doing it may help preserve better accessory nerve function. This is one aspect that we've looked at, and this is from our publication, which is how important are the perifacial nodes in a selective neck dissection when done for N0 necks in oral cavity. So the perifacial nodes are a pad of fat that lies between the submandibular gland and the inferior border of the mandible. And to dissect this area well often requires us to remove, elevate, and preserve the marginal mandibular nerve, both the superficial branches that run on the capsule of the submandibular gland and the deeper branch that runs right on top of the facial artery. And that's a tedious dissection, often adds a lot more time to the operation. Traditionally, perifacial nodes were associated with buccal cancer, and it was felt to be an important first echelon of drainage, and not so much with other sites. But we found when we analyzed 250 patients of N0 necks as to what the incidence of perifacial node metastases isolated as the only site of disease in the neck, it was 8% of all patients. That's a pretty high percentage of N0 necks harboring disease in the perifacial nodes. And we actually found no difference in whether the primary was either in the oral tongue or in the buccal mucosa. So at least we advocate perifacial nodes should be specifically addressed carefully in all oral cavity malignancies. And lastly, this is a practical dilemma, is when to address the contralateral neck when the necks are being addressed electively, N0. I think location of the primary when it approaches the midline, particularly if it crosses the midline, is unequivocal. Almost everybody would address the contralateral neck when the tumor reaches or crosses the midline. And if you look at Louis Kowalski's data, if you look at the relative risk of contralateral metastases, it starts increasing as the tumor reaches within 1 centimeter of the midline, but it's really high when the tumor has crossed the midline beyond a centimeter. So we often use this as a guide when to address the contralateral neck. What I think is not answered categorically, but there is emerging evidence, is what to do when you have a fully lateralized oral cavity cancer. Should you address the contralateral neck? And we know there are many factors that are associated with the risk of developing disease in the contralateral neck. Some are related to the primary site. If you look at that list, these are basically factors that portend a high risk of nodal metastases. That's what it is. So any tumor that has a high risk of nodal metastases logically has a higher risk of contralateral metastases. The one exception here is floor of mouth, which shows an unusually high preponderance towards contralateral metastases. And if you look at the nodal factors that portend contralateral metastases, it's basically high nodal burden in the ipsilateral neck. So if you're addressing an N-positive neck that has a high burden of disease, if the contralateral neck is N0, there is a fairly high chance, it's roughly about 20%, that the contralateral neck may harbor microscopic disease. I'm not sure if that's a clear indication we should address the contralateral neck. I think I'll wait for more data to emerge on this. But certainly if you're not addressing surgically, thought should be given to addressing this with postoperative radiation in these situations. And in the last few minutes, I'll touch upon two, trends, and they're not really future because they are kind of current. One is, what's the role for a selective neck in an N+ neck? This is from Dr. Shah's paper data. If you look at the table on the left, when they looked at their specimens that were clinically negative, the incidence of level 5 metastases is exceedingly low. That's the last column, the last row. And on the right is the table that shows the incidence of level 5 metastases when the necks were clinically involved and underwent a more comprehensive neck dissection. Again, it's fairly low, under 5%. So level 5 is a rare involvement by oral cavity cancer. And which is why many centers are now looking to advocate a selective neck dissection, even for N-positive necks. A systematic review published a couple of years ago showed again that the occult disease level 5 involvement is very low. But once again, we see that there is a trend that level 5 involvement is more common if the previous stations harbor disease, particularly levels 2, 3, and 4. If they are harboring disease, the incidence of level 5 involvement goes up. But certainly now, this is in institutional practice in many areas, is that you can offer a selective neck dissection for, let's say, N1 disease, where the disease is in level 1 or upper level 2. And lastly, a few words on sentinel node biopsy. Most of us would be familiar, but to quickly reiterate, basically sentinel node biopsy looks at injecting a dye around the primary site, seeing, as you can see on the 2D planar image, which nodes the dye drains to. These nodes are supposed to reflect the sentinel or guard nodes, which are the first echelon of drainage. These nodes are then mapped out using a handheld gamma probe in surgery. And only the nodes showing an uptake are then removed and subjected to a pathological analysis. This could be a frozen section, a permanent histology. And it's presumed, the logic being that if you can harbor only the sentinel nodes, and if you can analyze them, they should correctly give you a reflection of what's happening in the neck. Means if these are negative, the neck should be negative, and if these are involved, treat it as a N plus neck. So it's actually a staging operation for the neck. The SENT trial published in 2015 looked at what's the practical outcome of using sentinel node biopsy across multiple centers. What they did is they harvested sentinel nodes and then they sent them for a permanent section. The permanent section is very, very meticulous when you're doing a sentinel node biopsy. They sectioned it at 150 microns. They use standard H&E. They also use pancytokeratin and IHC if H&E was inconclusive. Basically, you're examining few nodes, but you're examining them very, very thoroughly. And they looked at the outcomes were sentinel node identification rate, the false negative rate, which is really the most important outcome parameter, which is how many times was the node negative, but the patient failed in the neck, indicating you missed neck metastases, and the disease-free survival. So sentinel node could be harvested almost always. The negative predictive value was very good at 95%. And the overall disease-specific survival was also very good at 94%. So this basically tells you that oncologically, it's an efficient option. It has a really good, ability to identify positive necks accurately and rarely misses positive necks. But see the pathology. In 16% of the positive necks, it was only isolated tumor cells. That's less than 0.2 millimeters. So it was a really close sectioning of a few nodes. Now you can't possibly do this in an entire neck dissection specimen. It's too labor intensive. So really, really small metastases were also being picked up. In this trial, everybody who had a positive neck underwent a staged neck dissection 3 weeks later. And we'll see why that's a challenge. So the thing with sentinel node is, oncologically it seems sound, but practically it doesn't get adopted a lot. And that's because of practical considerations. It does require some expertise. It can be labor intensive, both with more time in the operating room and more time for the pathologist. But I think the biggest drawback that I actually practically face with offering this is the possible need for second surgery. And that's because we know frozen section is not always reliable in picking up metastases as an intraoperative analysis. This was also shown in the SENTI MORL trial. That trial actually used frozen section intraoperatively to see if a full neck should be done or not. But out of 132 patients in the sentinel node biopsy arm, 12 patients with positive nodes were missed on frozen section. So that's almost 10%. So 10% of patients, even if you use frozen section, still needed a second stage neck dissection. And sometimes I think offering that option to a patient in clinic can be a struggle. So for me, at least practically, that's the big reason why sentinel node may not have high adoption across all centers where we can be resource constrained and where patients may have hesitation to possibility of a second operation. Of course, practically, if you're doing a microvascular anastomosis, then these options are not really to be thought. But those are my thoughts on sentinel node, but definitely seems oncologically reasonably sound, but with practical considerations. So I think what we've seen that now for the N0 neck, we've gone from really morbid treatment to now relatively conservative treatment that's equally effective. But we are still treating a lot of necks unnecessarily. For all selective neck dissections done, assuming a rate of 30%, that's still 70% unnecessary neck dissections. And I think we need to look at evolving better imaging or better intraoperative techniques for finding those and minimizing the number of elective neck dissections that we do for what turn out to be eventually negative necks. Thank you very much for a patient listening.
It was a excellent presentation. I am a radiation oncologist, but yet I have to ask one question which is related to surgery. When we have a recurrence, I mean, after treatment, when you have a recurrence like post-surgery, post-RT, you have suppose isolated neck recurrence on one particular side. It is, let's take level 2 on the left side. In that case, if per primum, if the neck was not addressed on the right side, so do you address the neck if you if you get the opportunity to do surgery in a recurrent setting, would you go for the neck dissection of the opposite side?
Okay. So if I understand correctly, you're saying ipsilateral neck dissected, patient radiated, now comes with contralateral neck recurrence.
No, recurrence on the same side.
Oh, so it's an infield recurrence in the neck.
Infield recurrence in the neck, and it is surgically resectable. The reason why I'm asking, because Tata Memorial, I mean, where Dr. Deepa is also the author, along with Dr. Pankaj Chaturvedi group, they have advocated to do it. On the contrary, some other papers are saying no. And I have a panel discussion to moderate, and this happens to be one of the questions in that also.
I'm glad I'm not.
So I want to get a clarity.
I think very nuanced answer I can offer as a surgeon. I don't think there is generalization to be made here. The thing, when you're operating a dissected and radiated neck, if you're going in, you need to be fairly sure you're going to get negative margins. So I think your imaging and assessment is key. By and large, if a good high quality neck dissection has been done, I think reoperating that is very challenging for an infield recurrence. Often disease will be stuck on the remaining structures left, and extracapsular spread is very, very common in radiated necks when they recur infield. So it's a challenge. So I think a very sorry, you're saying contralateral neck recurrence. Okay. You're saying what to do with the contralateral neck. So that is tough. So we looked at this. I'll tell you what we did. We looked at what are the patterns of nodal spread when we fail. We didn't find a fixed pattern. We looked at infield nodal spread. We looked at level 5 ipsilateral if it hadn't been dissected, and we looked at contralateral neck. We didn't find any fixed pattern by which nodes tend to recur. So I think if you have an ipsilateral recurrence and this is the last ditch effort, I would dissect both sides. That's what I would do. But if you ask me a little differently, if the primary recurs on the same side and you have to address the neck, which stations to address, I don't think literature gives a clear answer. I don't think you have an easy pattern to know where this primary will drain now. So I think there's a lot of variation on how one would do it. But I think if I'm dissecting an infield recurrence, I would be very tempted to do the opposite neck. It seems like that's the last stitch for that patient. So you just give it everything.
Thank you so much, Dr. Deepak Sareen. Now may I request Dr. Kaushik Bhattacharya, Director HOD Radiation Oncology, AIG Hospitals, to discuss evolving indications of adjuvant radiation in oral cavity cancers.
Good afternoon. I have 38 slides, and 8 of the slides talk about what we know already, and 30 slides that talk about what we don't know. That is how it is. Adjuvant radiation has been in business for 20-25 years now, and I felt that what we don't know about adjuvant radiation as of today is actually more voluminous than what we know. And that is also because certain things have changed as we speak in the last 3, 4, 5, 6 years. And the groundwork for my presentation was actually laid down in the morning by Dr. Neha. And I'm sorry that she's not here. Actually, I wanted to ask many questions to her, but she's left now. But still, you understand where it's coming from. It's all about pathology. So, as I said, that what you already know. What you already know is that if you have a T3, T4, if you have a T3 and plus, you go for a surgery which should also cover the neck, either same side or both sides. If there are no adverse pathological features, then you consider radiotherapy. If there are adverse pathological features, then you have to go for addition of chemotherapy. Now, this much is pretty simple. And all of us know that for this, you don't have to really come to a meeting and attend the lecture. What we are still learning about is the change in the TNM last 4 years ago, which has incorporated the DOI, and that has changed the staging, and that has got implications. And what are other risk factors? Like, is there any additional reason as to why you want to give chemoradiation beyond the standard indications? What about the impact of nodal burden? All node positives are not the same node positives. There are node positives which are very lightly node positive. There There are node positives which are very heavily node positive. Do you have a difference in the way you manage them? And also the evolving pathological factors like the PNI, the LVSI, the worst pattern of invasion, tumor burden, and many of these actually do not have a concrete answer. So can you lump some of these indices together and try to find a comprehensive answer? So the most important thing is the AGCC 8, which as it incorporated the depth of invasion as a factor, the stages changed. So what was earlier a T1, because it was a 2 centimeter lesion, on the basis of a more than 5 millimeter involvement, the DOI became a T2. And then T2 similarly became T3 if it becomes more than 10 millimeter. And a T3 becomes more than 10 millimeter, becomes a T4A. Now this changes a lot of, the guidelines as we speak. Many of the trials that have been performed on the previous AGCCs now become meaningless and they have to reinterpret it. The same thing happens with the nodes. Nodes are relatively simple. They remain as they remain, except once they become ENE positive, external extension is there, they are all getting clumped as a N3B, both for a pathologically as well as for a clinically. If you have fixity of the node, it automatically becomes a N3B, irrespective of whatever the size be or the laterality be. Now, taking these factors into account, for many years, even before the AGCC 8 came into vogue, people have been voicing their opinion as to reinterpret and relook at the plain vanilla indications that we have for adjuvant treatment. And there are plenty of trials, including one trial that Dr. Sareen also mentioned just in his previous slide. Dr. Sarmani is author of one of the trials I mentioned here. Neha has left. The key challenge is that once you migrate from the old to the new, the stage changes. And this is one very interesting retrospective trial, which shows that once you move your definition and take into account the depth of the 133 from size alone, you went up to depth of the, how to go to the, one second. Yeah. So once you went from size to depth, the patients who were earlier staged as T2 became T3. Significant number of patients, from 10% of patients, they became 33% of patients who became T3. And obviously, by the old definition of that stage, those patients were undertreated. And that's exactly what happened. The patients who got upstaged, their outcomes in the subsequent post-hoc analysis were seen to be worse. And if you divert them into two groups, one, the patients who have received radiotherapy versus those who have not received it. The patient who received radiotherapy after being upstage also did as good as patients who did not upstage, but the ones which did not receive radiotherapy, they did worse. Now, this is a fundamental understanding that you cannot ignore depth of infiltration at all. This changes a lot of things. So, additional DOI causes upstaging, and not adding radiation to them would be detrimental. Now, this is the first thing that you have to keep in mind. This is practice change. Now, we know that adverse pathological features, as they have mentioned in the NCCN guidelines, beyond the ENE and the positive margins, which we have already factored into our practice, are close margins, T3, T4, N2, N3 disease, level 4 or 5 nodes, PNI, vascular, and lymphatic invasion. I will try to briefly see how each of them impact your practice as of today. This is the gold standard as we have known for many decades. The Bernier and the Cooper, on two sides of the Atlantic, performed similar trials with some differences between them, and they found the Europeans found that once you add chemotherapy to a high-risk group of patients, they have increased DFS, local regional control, overall survival, without any additional detriment to the toxicity. And in Americans, Cooper found that DFS improved, local regional control improved, there was no impact on the overall survival, but the toxicity went up. Why this difference? Because there was a difference in the way the patients were cohorted into the different trials. And common ground that overlap, the Venn diagram shows that margin positivity and external extension were the common factors between the two trials. Therefore, it became a common practice for many decades now to give chemotherapy concurrently with radiation to patients who have ENE positive or margin positive, and that impacts DFS, overall survival, as well as local control. Now, if we have known this for so many years, so good, why are we questioning this? And people have questioned this for a long time. People have tried to look beyond Bernier and Cooper, and as early as 10, 12 years ago, RTOG was designing trials wherein they decided that apart from EC and cut margin positivity, having more than 2 nodes is a high risk factor, and they should be given chemotherapy. It was not even a part of the trial question. It was assumed that both the arms had chemotherapy in this trial. Possibly the most pertinent question has been asked by Triphility, where they looked at the National Cancer Database and found 10,000 patients of all head and neck sites. Now, this is the drawback of this trial. I understand that I'm talking about adjuvant artery and oral cavity, and this was all head and neck sites, wherein level 3 and level 4B patients who had no ENE and no CM positivity, they were run through a propensity score analysis, and they found that chemotherapy and radiotherapy actually increased the overall survival. And this impact was directly proportional with the nodal burden. If you have 4 or 5 nodes, then the impact was maximum. So possibly it is safe to say that high nodal burden, even though not proven in a randomized trial, makes a strong case for addition of concurrent chemotherapy. Beyond Bernier Cooper, one more Chinese trial, where also they have found out the same thing. And they found that if the patient is actually having T3 or a T4, N2 or a N3, overall survival, distant metastasis-free survival, and locoregional failure-free survival all improved by addition of chemotherapy in patients, even if they did not have ENE or EC. Now, is this outcome linked to the number of nodes? As I said, that the Triphility paper shows that more than 4 or more than 5 is where the benefit lies. But is there a place where the benefit plateaus out? Yes. This is a combined analysis of multiple RTOG trials, and this is Dana Liu et al., where she found that the overall survival, DFS, and locoregional control, they plateau out when you have 5 nodes. More than 5 nodes, there is no additional detriment, whereas the distant metastasis continues to worsen as the number of nodes go up. Now, this trial actually had a median number of nodes dissected by 33. So they found once you have crossed 5 nodes positive, whether you have got 7, 8, 10, other factors remain same. But it is quite understandable that if you have 10 nodes, the possibility of distant metastasis is more, and that is exactly what we found. Question is in the opposite direction as well. Of course, large number of nodes, you add chemotherapy, proper, no question about it. What about adding any radiotherapy at all in a patient who has T1 or T2 and N0? Now, this is one international collaborative study where Dr. J.P. Agarwal was also one of the contributors. They found that if you have margins positive, then adjuvant radiation is going to improve outcome. Margin trumps everything else. So these are small diseases, T1, T2. Normally you would not consider them for radiation, but once you have margin positive, all bets are off. This is kind of intuitive to understand, but this is a proof of it. What about patients who have very small number of nodes? There is one small trial, but at the same time, it's a prospective trial that found that while there was no benefit in the overall survival, the progression-free survival was significantly better in patients who had received radiation only because there is one node only. Now, this should not be seen in isolation. This should be seen in combination with what is the risk at the primary as well. And I will come to that, which is the next trial. The next trial is a trial which, a retrospective trial, but had more numbers, 1,500 patients. They found that the overall survival benefit is only when you have a T1 or a T2 and N1. So possibly a T1 N1 trial patient, there is no need of adding radiation therapy, but if the patient is a T21 N1, then you have actually tilted the balance in favor of adding adjuvant radiation. Even though it is a retrospective trial, but it kind of possibly fits in with our current practice as well, that most of the time the T2 and N1s, we think that is a combination of 2 risk factors, and let us give it. But this is, I'm talking about only radiation, not chemotherapy. The elephant in the room is obviously DOI. Now, whenever you talk about DOI trials, Ibrahimi et al. Trial is a trial that comes up again and again and again, One of the reasons because it is an international collaborative study which has taken data from all over the places and including India. JP is one of the authors here. And they have looked at many data points. And I'm just trying to summarize some of the data points here. They found that only when you have DOI along with some other adverse features, then you have an advantage in disease-free survival. This is basically disease-free survival. But if you do not have any of the adverse features, there is no additional benefit. So DOI alone in this trial did not show any worsening of the situation unless you have also another, similar thing. But at the same time, without adverse factors, there is no additional benefit in terms of loco-regional control. Now, this is a very, it's a very thin line between this and that. It's the way the statistics are designed. But what is important to understand here is that only DOI is possibly not adequate for you to offer radiation. Now, this is all head and neck sites. To summarize the Abrahami trial, while it is now known that the difference between a 5 millimeter, 10 millimeter, and more than 10 millimeter depth will have a negative impact on the disease-specific mortality as well as loco-regional failure, one parameter alone, DOI alone, should not be taken as an indication for adding adjuvant radiotherapy. But if it is along with one more risk factor, for example, a nodal metastasis or a close margin or involved margin, then definitely there is a point in adding radiation, and that is beneficial. At this point of time, somebody, especially that person is sitting in my MDT, will oppose me and tell that no such thing for, you cannot really do that. And then somebody will say that, well, tongues are different. So I'm trying to look at it. I mean, this is my daily battle. I relate to this battle so well. What happens in tongue? In tongue T1, T2, and this is focused only on tongue, the Chinese retrospective data, which shows the same thing, that the overall survival and the loco-regional control is worse when you have more than one risk factor. But when you do a multivariate analysis of all the risk factors, you find that DOI alone is not significant. So the same argument carries over onto the tongue, because there is a perception that tongue is worse, tongue is worse, tongue is worse. Limited as it is, the retrospective data does not show that. Now, this is the problem everywhere when you talk about this. You don't have great amount of prospective, and you cannot have, because the DOI definition has changed only 4 years ago, and it will be some time before you actually can come up with prospective data on this. The next question is PNI. PNI, this is a multi-institutional analysis of 557 patients, very low risk patients, T1, N0. Adding radiation help in only PNI positive patients. So you might argue that is PNI an independent prognostic factor, because this trial showed in 500 patients. Well, it is not so easy. What is important is the size of the nerve involved, whether it's an intratumoral deposit or an extratumoral deposit. Extratumoral deposit is worse, if I'm not wrong, and the number of foci. The author was here. Where did she go? Left? She left. Well, so author was sitting in the front seat. Yeah. So this paper, which shows that that adding adjuvant radiation improves outcomes in PNI positive. Now, this is a very nice trial. They have 1,500 patients retrospectively. Having said that, that trial alone is not what is going to decide you, because there are other trials which did not show the benefit. And and a meta-analysis of 7 studies, they came up with the conclusion that high-level evidence of adding radiotherapy on the basis of PNI alone is lacking in literature. So, I mean, I thought she will counter me, but she has left the field already. Okay. So, what about LVSI? Now, LVSI, I came to know about false LVSI because of the surgeon's manipulation today, right? So, I don't know whether any trial has looked into that, but I just pulled out a couple of trials, and the conclusion is that the adverse nature of LVSI is well known, but at the same time, we do not really know whether it alone can act as an indication. It's a relative indication for adding adjuvant radiation, but not by itself. Tongue is always the elephant in the room. So I thought it is a good idea to discuss this more recent trial from China. Again, this is everywhere is Chinese trial. They looked at only T1, T2, M0 patients with post-op radiation for patients who had more than 5 millimeter of depth of infiltration. This is the standard discussion everywhere. They found that there is a beneficial impact on overall survival, disease-free survival, local relapse-free survival, regional relapse-free survival, loco-regional relapse-free survival, and distant metastasis-free survival. So before you start giving radiation simulation dates to all your tongue patients with more than 5 millimeter depth, hold your horses, look at the data closely. Now, when you do a propensity score match analysis and remove the univariate bias from that, you realize that the beneficial effect, both local, regional, and overall, is when you combine all the risks together. What is important is that poor and moderately differentiated histologists, they had a benefit of adding radiotherapy both in local, regional, and metastasis. The PNI, yeah, here she is. Yeah. The metastasis, the PNI along with LVI, when you are not differentiating PNI plus minus LVI together, then you have an additional benefit of adding radiotherapy. But when you take PNI alone, while it is beneficial in the univariate, once you run the PNI alone, the advantage is practically not there. There's mild tendency towards DFS improvement, but by and large, you can say that PNI alone is not going to tilt your decision. So the answer possibly will be, if you have to understand what you do from here, you have to take PNI and other things possibly, maybe DOI, at least more than one indication to tell that this patient qualifies for radiation, even the patient is an early stage patient. The next evolving parameters is, and this slide is obsolete, because in the morning I know that there is a modified WPOI. So you may close your eyes when I speak about this. This is Indian data. This obviously shows that when you have PNI 4 and 5, they're worse than people who have PNI 1 or 2. And there's one small meta-analysis that also shows the 7 trials, their meta-analysis, that also shows the same thing, that WPOI 4 and 5 are worse than others. How do you incorporate all these things that we have known till now? We have talked about WPOI, we have talked about PNI, DOI, we have talked about LBSI, we have talked about diseases where you have very less number of nodes, you have talked about diseases which are T1 or maybe just T2. How do you incorporate this? And all of them have shown some reason to believe that adding some additional treatment after surgery may be of benefit to them. But by themselves, they cannot. So how do you make sense of this into your day-to-day practice? One of the ways to do it is to put all of them together and create a composite index. And there are many indices are there. This is one index where they have shown that WPF5, PNI and LBI extra or intratumoral, satellite nodules, they can be combined into creating risk groups and making a sense as to whether this patient should be offered adjuvant radiation or not. Also, there is one more trial, and this is from India. 2 of the authors are supposed to be in the hall right now, but I can't see them. Yeah, they're there. Oh, yes. Thank you. So, this uses similar factors on a sliding scale to create a risk stratification of low risk, intermediate risk, and a high risk, and proposes the treatment of adjuvant therapy, addition of chemotherapy to the adjuvant therapy, and treatment intensification, because these small indices by which they individually cannot do anything, all put together through a mathematical validation of risk put into every bucket in a slider, you can possibly create a statistical, situation where you say, yes, this patient is going to benefit from such and such treatment. So, looking back and at the same time looking forward, what we know is that 54 gray to 60 gray for adjuvant. If there is a high risk, you may go up to 66 gray, 66 gray for margin positive and all that. T3 and plus disease should receive radiation. Primary and next should be covered. EC and CM positivity are indications for adding chemotherapy to the radiation. From that, we are possibly looking towards a time where the DOI and its impact on stage migration has to be taken into account. totally from the beginning itself into the management, not only for the radiation, possibly for the neck dissection as well, which was shown in the trial with the caveat that you showed the 3 millimeter you can't really make out. You can start looking at the role of adjuvant radiation at early stage if your nomogram suggests so. You will have some idea about how to deal with patients with high nodal burdens. Should you add chemotherapy for patients who have T3, T4 or N3? Taking into account PNI, WPI and other things, whether to add RD on them or not. These are all evolving criteria and they are possibly best put into a composite index and make a sense out of it. At this point of time, in the absence of a hard evidence to direct you in either direction, do not leave your clinical judgment behind, because chemotherapy and radiation, especially chemotherapy and radiation together, is not a free lunch, and therefore your clinical judgment should be the most paramount important thing that will guide you into this decision making. And I must thank all the people who have helped me in this presentation, including the people whose trials I have used. Thank you very much, and block your dates in the month of January. Any questions? I have told that 30 of my slides are unknown. So any question you ask me, I'm the person who don't know anything. Yes. Good? We good? Thank you.
Small announcement. Surgical workshop is starting in the 5th floor. If any surgeons who are interested, please, you can please carry on to the 5th floor.
Yeah, question, yes. I do. This is what I have faced all my life. Tell me. Uh-huh. Yeah. Huh. Uh-huh. Huh. Hmm. Hmm. Can I get the slide back? Yes. Yes. Mm-hmm. Yes. So they have taken 2 nodes plus. Mm-hmm. 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 Yes. Mm-hmm. That's not true. Yes. Sure. Worse. Because they have put everything in one group. Hmm. Hmm. Does radiation change it? Exactly. Yes. Yes. Absolutely. Exactly. So the points that I have made, some of them have already become obsolete because, as I told you, WPO has changed. Yes, you want to say something? Yeah, please.
The absence of a clinical trial, a prospective clinical trial making this analysis is very, very difficult. So what we can do is that if institutions which are doing X and institutions which are doing Y can pool their data together, then using modern methods, you can find out the relative benefit of adding a particular modality, whether it's adding radiotherapy in an T1, T2, N0 case, or adding chemotherapy for node 2 nodes or more positive situation. So if you have a big enough cohort of people who have been treated with chemotherapy and radiotherapy versus only radiotherapy, you can find out. We are trying to initiate such a process. I'll tell you more about it separately. But I think that that's the best thing that we can do in the absence of a
That is
trial.
perfectly agreed. One thing is that we do lack clinical trials. And one of the reasons that we are not able to answer this with the background of the present clinical trials is because the goalposts have shifted while you are asking this question. WPOI is shifting. DOI has changed the staging. So none of the old trials are valid to answer this question. And by the time you want to know this, you have to wait for the next. I think that's it. I should not be delaying.
Thank you, Dr. Kaushik. Now we have a panel discussion on oral cavity cancers, moderated by Dr. Nandita Sesikaran. And the panelists would be Dr. Suman Das, Senior Consultant Radiation Oncology, Apollo Cancer Hospitals, Vizag. Dr. Dilip Gudipudi, Senior Consultant Radiation Oncologist, Yashoda Hospitals, Hyderabad. Dr. Ramachandra Nagaraju, Consultant Surgical Oncologist, AOI Hospitals, Hyderabad. Dr. Srinivasulu Reddy, Consultant Maxillofacial Surgeon, AIG Hospitals, Hyderabad. Dr. Pratap Verma, Senior Consultant Surgical Oncologist, AOI Hospitals, Hyderabad. Dr. Rahul Bugaviti, Senior Consultant Head and Neck Surgeon, Apollo Hospitals, Hyderabad. And Dr. Santosh Chellapura, Consultant Medical Oncologist, Star Hospitals. Finally, Dr. Swapna S., Consultant Pathology, AIG Hospitals. May I request everybody to come on stage to carry on with the panel discussion? Thank you.
Good afternoon, everyone. I thank all the panelists for coming on stage. I think a couple of them are missing, but we have a representation from all the departments, I think. So we'll go straight ahead with the panel discussion. Slightly different from the previous panel that we had. I'm not going to focus too much on diagnostic. We'll just answer a few focused questions in management. Part of it would be a revision of the previous lectures we heard, and part of it will be indulging the medical oncologist because we haven't had medical oncology lectures. So this is our first case. This is a 64-year-old lady. She was a gutka chewer. She came with a 1.5 centimeter growth in the right lateral border of the tongue. She was clinically node negative, and the CT scan as well was done, which showed that she was node negative. So she was treated elsewhere, and she underwent a wide local excision and a selective neck dissection of level 1 to 3. And that's the histopathology that you can see there. So this is a 1.5 centimeter grade 2 squamous cell. Closest margin was 5 millimeter. No LVI. PNI was present. Depth 9 millimeter. WPOI 4. And nodes negative, 0 out of 15. So my first question we'll start with the surgeon, Dr. Rahul. In terms of management of neck, we heard the lecture by Dr. Sareen. So what in your experience would be the ideal way to manage this early tongue who's clinically node negative? Is observation an option at all?
Yeah. Morning we have seen about the Tata trial, and apart from that we had a SEN trial from the UK. So both of them clearly showed that doing elective neck dissection increases the disease-free survival. The Tata trial showed improvement in overall survival, but the SEN study showed only improvement in disease-free survival. So it is better to do a neck dissection
to
improve.
So agreed, this is a Tata trial and it did show that elective neck dissection was better than salvaging a neck once they relapsed. There were some criticisms of this trial, particularly about the follow-up. So there's an ongoing NRG-HN006 also looking at the similar pattern of study design. What about sentinel lymph node biopsy? Is that something that you do in your practice or is it something that you will adopt in future?
Sentinel lymph node, right now we don't do it. Basically, because if we just do a frozen section, micrometastasis and isolated tumor cells are not picked up. So we need to do a more detailed analysis and then you need to do IHC, which is cumbersome. So right now it is difficult to adopt it, maybe in the future.
Okay, so there are issues with sentinel lymph node biopsy. Quite a bit of data, up to 3 randomized trials do say that it has very high sensitivity, high negative predictive value, and very importantly, better quality of life if you can spare the patient from neck dissection. Like you said, there are some issues. Any other issues that you can think of? So Dr. Swapna, what is the ideal way of sampling a sentinel node when you receive it?
We receive the sentinel lymph node. If it is less than 2 mm, we can do all embed at a time. If it is between 2 to 4 mm, we will make into half. If it is more than that, we will dissect, like cross the lymph node into like 2 mm thickness. So we will take multiple sections, like up 2 mm thickness interval. After once we get the block, we will take for every block, we will take 2-3 serial sections. Then later we will proceed with the IHC.
So how feasible is it to do a frozen section and give a good result on sentinel lymph node?
Frozen section for the sentinel lymph node is like sometimes we can miss the isolated tumor cells. But it is time taking process also. If we have to take every 2 mm interval, then it is time taking also during the process.
Sure. So like Dr. Rahul mentioned, there are some issues. There's also something called shine through phenomenon for floor of mouth cancers where the primary and the draining nodes are in the similar location. And step sectioning, as Dr. Sareen mentioned, is ideally 150 micrometer sections are recommended. So you are going to take a very long time, and so frozen sections can definitely be an issue. And this is usually a 2-stage procedure. Dr. Pratap, what kind of neck dissection would you offer these patients? Is a supraomohyoid selective neck dissection okay, or would you clear the entire neck in extended dissection?
If it is T1 N0, then we will do a selective lymph node dissection. But if it is T2 and N0, then better, especially in tongue, we do extended neck dissection. We dissect from level 1 to 4.
How often do you think you find a level 4 node in a clinically negative neck? Is it quite often, or?
It's not, or maybe around 8%. 8%.
So again, looking at studies comparing selective versus modified radical or an extended neck dissection, no difference in OS or disease-free survival. And the risk of finding level 4 involvement is fairly low. Skip metastasis is only 1.9%, and involvement in a node negative neck is also very less. So basically, doing a selective neck dissection is fine for most cases. Coming to the radiation oncologist, Dr. Dilip. So just to remind you of the histopathology, any role of adjuvant radiotherapy in this patient?
Is the PNA the small nerves or the large nerves?
Small nerves. It's microscopic PNA.
Observation is an option. And if you look at the PNA studies, then probably you can go ahead to radiation.
So this patient is in your clinic now. What are you going to tell them?
Observation is the option.
Okay. Dr. Suman, any difference of opinion?
PNI positive, WPOI is 4. Well, margin is 5 millimeter. But mainly PNI and WPOI, these two definitely I would go for adjuvant radiation. One thing, yes, do we 5 millimeter, do we really call it close margin or?
We'll come to that.
Yeah.
Somebody else I think will answer your question. Okay, so you would offer adjuvant radiotherapy. What about the depth? Is that worrying or is that?
Depth, yeah, depth above 5 millimeter, the chance of the risk factor is more. In fact, there are certain trials on that. So, yes, once the depth is only, that is the point, we don't need to give any adjuvant. But depth and PNI, also WPOI. So I would consider.
So the combination of factors
Yes,
is making
yes.
you consider adjuvant radiotherapy. Okay. So like we heard in the previous lecture, this is Dr. Deepa's paper, which shows PNI is independent prognostic factor. Adjuvant radiotherapy patients had better outcomes, but there are other papers as well which show that in isolation, PNI addition of radiotherapy may not be of that much of benefit. Depth as well, we saw this international collaborative study where depth alone, they found that there wasn't a benefit of postoperative radiotherapy, but in combination with other adverse risk factors, it seemed to show some benefit. Now, hopefully all of our questions will be answered by this trial, the ongoing trial from Tata, the ARREST, where T2 cancers with a depth of more than 5 millimeter are being randomized to adjuvant radiotherapy versus not. So until now, if you have a combination of risk factors, you are probably not wrong in advising adjuvant radiotherapy. So coming back to...
See, most of the trials, you do the minor risk factors, at least 3 or more, at the benefit in combination if you're looking at. But 1 and 2 with the composite 4, I think, not benefit from the adjuvant radiation. You say they have LVI, PNI, depth is close
Again, for
to 9,
tongue,
that's what-
as discussed previously, depth itself is a major risk factor, and then having 3 risk factors, I think, will kind of be divided. I think about 50% would agree to give and a few agree to not give. So, Dr. Suman, since you said that you would give radiotherapy, what kind of target volumes are you going to include? Are you going to include only the primary, with or without neck, ipsilateral, bilateral neck?
No. In tongue, definitely elective nodal radiation will do. Yes, I can go for lower dose like maybe 50 or 54 grade to the neck node and 60 grade to the primary.
And would you be tracking the nerve here up to the skull base in the presence of PNI?
No.
So basically, we derive all our principles of post-op radiotherapy from a few landmark papers, Meredith, the Dahanka, the Gotek trial for flaps in particular, and the Peters, which was a dose-finding trial. So as you said, you give a dose of about 54 to elective neck, 60 gray to the surgical bed, and 66 to areas of positive margin or extracapsular spread. And tracking of the cranial nerve, like Dilip specifically asked, is when you have macroscopic cranial nerve involvement, and you see on radiology, which is perineural spread rather than microscopic PNI. And this part of the Meredith paper also tells you when to include ipsilateral versus bilateral neck. What is a lateralized versus a non-lateralized cancer? So coming to the medical oncologist, Dr. Santosh. So early tongue cancer, and this is the pathology. Any role of adding adjuvant chemotherapy along with radiotherapy?
So one thing is when radiation oncologists are divided in whether to give radiation, that is the scenario I can tell no chemotherapy.
Okay, that's a good indicator.
So I see no indication for chemotherapy in this scenario.
Sure. And what in your practice are the indications for concurrent chemo in an early tongue cancer? Forget about this case.
Generally, any cut margin positive or extranodal extension.
Okay, so these are
the
your
two
hard factors.
Hard factors where these are the people would benefit from receiving of concurrent chemotherapy. Others, I do not. As we have seen in the previous talk by Dr. Kaushik sir, lot of things are emerging. Maybe 5 years down the line, we might treat or giving chemotherapy for other minor risk factors also. But we need to have strong data. As of now, extracapsular extension and margin positive.
Sure. So the Bernier and Cooper studies, absolutely right. These were the two hard factors which showed improvement of OS, DFS, and loco-regional control, and these are what we generally practice. The Trifility paper, again highly quoted, did show some benefit with multiple nodes as well, but like Dr. Sarvani just mentioned, there are issues with committing to that. When you do offer concurrent chemotherapy in your clinic, what is the regimen that you use, Dr. Santosh?
I use cisplatin 40 mg per meter square on a weekly schedule. That I feel is more tolerable, predictable toxicity and manageable. So I do not use the 100 mg 3 weekly one. I use 40 mg per meter square once a week schedule.
So there is evidence to what you've said. Although the standard of care is 3 weekly 100 milligram per meter square, there are two well-designed randomized trials. The Vanita Neurona trial, which compared it with weekly 30 milligram per meter square, which did show inferior locoregional control in the weekly. However, the Japanese trial, which used the 40 milligram per meter square that you use, did show non-inferior overall survival. So if you can, if the patient is fit, then do 3 weekly. But if you're a bit iffy about the toxicity, then a 40 milligram per meter square weekly is probably as good. What about patients who are cisplatin ineligible? Are there any alternative regimens that you can use apart from cisplatin?
Our own data from Tata shows in those patients where we are unable to give cisplatin, docetaxel is a reasonable option. So I would give it docetaxel when cisplatin is not feasible.
Okay. Dilip, is there anything else that a radiation oncologist can do if somebody cannot receive chemotherapy?
One thing is that, as I remember, in this 3 weekly was better tolerated than weekly.
So both of them had bad toxicity. So what they said was the toxicities were slightly less in the weekly in the Japanese trial.
Was better in the weekly part in the Tata, sir. The other trial, 40, also toxicity wise more or less same. Even AIMS has published a data of 40 mg per meter square, where it is little bit better compared to the 3 weekly in terms of toxicity and tolerance.
So toxicities are not significantly less, but yeah, slightly. I think the numbers were about 10% difference in the grade 3 toxicity between the two arms. Cisplatin ineligible, I was asking Dilip or Suman, is there anything you can do radiotherapy wise if you can't give chemo?
Cetuximab you can add.
Okay.
And there is a recent data from Tata also about using nimotuzumab.
Okay.
So cetuximab I commonly prefer in cisplatin ineligible.
Sure. So alternatives for patients? Yeah.
Yes. Yes.
So docetaxel.
So cisplatin ineligibility itself, the word, there's a lot more behind that. So we'll leave that decision to the medical oncologist. So yes, ma'am.
Mucositis. Seeing data wise, madam, cisplatin in head and neck is the best, but in cisplatin ineligible carboplatin, we do not have hard data, madam. So I would not give in that scenario where I have issue of this docetaxel, maybe nimotuzumab or cetuximab I would opt for, where the patient is frail, where I expect the tolerance to docetaxel is also poor, but carboplatin I do not believe, madam.
It shows that carboplatin is inferior. True.
Only thing is we have our own data with docetaxel, maybe toxicity we tolerate and more.
Yeah, so that was what I was trying to get from the radiation oncologist.
The peak of altered fractionation. You have the study by the McKinsey group only, but it's headed, I think, by Benjamin, either by Blanchard or by Pierre, what's his name? So, but that's a negative study. That's negative for accelerated radiotherapy. And in OCAT, we did see there was some kind of a benefit with the overall survival, but then those are all advanced things, and we did see 6 days a week was beneficial. But the meta-analysis is negative. It does not have our study in it, but it's negative.
So we'll continue with this unfortunate lady. So she did not receive radiotherapy, and a year later came with a whitish patch on her lower lip, is about 2.5 centimeters, with the central area of ulceration. So we'll come back to the surgeon, Dr. Pratap. What would you like to do with this lady?
So first of all, I would like to know if there is any history of contact irritation there which is causing this ulcer, or whether they have tried any medical treatment. If it is a persisting chronic ulcer, then I would like to go for a incisional biopsy.
Okay. So this lady does fall. So if you look at this as a leukoplakic patch or a pre-malignant sort of an appearance, she does have some high-risk features which warrant a biopsy. So a biopsy was done, and this turned out to be severe dysplasia. So we'll come back to Dr. Rahul. What would you do in this case? She has a patch which is a dysplastic patch with severe dysplasia.
Yeah, this only shows severe dysplasia. We'll do a wide excision. We generally don't take margins like a regular malignancy, around 2 to 3 millimeter of margin, and be comfortable.
Okay. And is there any role of laser ablation in these pre-malignant sort of lesions?
If it is superficial, then you can vaporize it with laser, but it's a deep ulcer. So,
You would
and I
prefer
need
wide
a
excision.
histopathology report also. So, I like to do an excision.
Sure.
Complete.
So when you do have severe dysplasia in your biopsy, the recommendation is generally to do a wide excision. You may or may not require a graft. So this was then the histopathology. It turned out to be a squamous cell cancer after all, grade 1, 7 millimeter invasive component, and there was a background of full thickness dysplasia. The depth was only 3 millimeters. The right lateral margin was less than 1 millimeter from severe dysplasia and 5 millimeter from the invasive component. So coming back to Dr. Pratap, how are you satisfied with these margins? What would you generally consider as an adequate margin?
Adequate margin, gross margin will be 1 centimeter, but the pathological margin, if it is more than 5 mm, it will be adequate. 2 to 5 mm will be intermediate, but less than 2 mm, it will be considered as positive.
So this lady has less than 1 mm from dysplasia.
Yeah.
So you would
I would prefer to revise the margin.
revise the margin. Okay. So most data, I mean the margins as well, the exact margin is a bit of a conflict. Generally about 5 millimeters or now even 3 to 5 millimeters considered adequate. A close margin is if it's within the range of 1 to 4 millimeters, and an involved margin if it's less than 1 millimeter. Dr. Dilip, if this patient does not have a re-excision, would you consider adding radiotherapy here?
Yeah, because it's a recurrence, then we have definitely she would require radiation.
It's a different site. The initial was a tongue, and this is now on the lip.
Okay.
And the margin is, well, it's a dysplastic margin. So you would consider it. Dr. Suman, would you offer radiotherapy in this case?
Definitely, now the margin is 1 millimeter, so radiation has to be offered, and
1 millimeter is for dysplasia.
So it's
Not
5
from the
mm
malignancy.
from invasive, less than 1 millimeter from dysplasia.
So if we count, it would be 6 mm.
yeah, then it will, yeah.
Okay, so this is a bit tricky. I don't think even I have the answer. So there's
I think
multiple.
if revised margin is done, then we can observe.
Which one? So it was right tongue, and this is kind of in the middle of the lip. So not exactly same. And she didn't have radiotherapy. Neck dissection was on the right side. The neck was negative. She didn't have a neck
Earlier
dissection.
negative.
It's now she hasn't had a neck dissection. So basically, I wanted to point out about the dysplastic margin. There isn't really any data to tell us what exactly to do. It is an involved margin. So like Dr. Pratap said, revision would be the best option. Because you do have some papers saying that there's inferior local control. There are other papers which say that does not affect survival. However, we do not know whether adjuvant radiotherapy provides benefit in a dysplastic margin. Yes, one has. Yeah. No, there wasn't.
Because the surgeon has gone in and revised the margin, the dysplasia. Now, the only issue, of course, is the surgeons can say, because
You may
if
not
this is
find
the
the
final
margin.
pathology report that they found severe dysplasia at the margin, revising the margin, whether it's going to be useful or not. But if they've
Correct.
gone in and revised on table, then that's a different thing. Then we don't need to give adjuvant radiotherapy, because otherwise there are no indications. Just the
There
fact
are.
that there is a second primary but doesn't have indications, we don't have to give adjuvant radiotherapy.
Agreed.
I don't think most of the surgeons may not revise the ipsilateral neck if an adequate neck dissection has been done on the ipsilateral side.
Also, it's a lip and it's a very superficial
yeah,
tumor.
exactly. And but I don't know whether you should call it lip because this looks like labial mucosa and not the definition of the lip as lip goes. It's not on the vermilion border, it's on the labial mucosa. So if at all you think that the margins are positive and you want to give adjuvant therapy, then it should be brachytherapy and not even external beam radiotherapy.
Agreed. Yeah. A year. Field cancerization. Correct.
Likely that she'll develop a third primary.
It's in general at her an indication
so,
of bad biology.
Leave if this is resectable, I would always image the neck. You not address the neck. If the depth of invasion was 3 millimeters, if the revised margin, which we are revising only for severe dysplasia, not for invasive carcinoma. If the neck is negative or sonography, I would revise and keep her under observation because she is most likely to develop a third primary.
Yeah, and that's exactly what happened. So a year later, this unfortunate lady came back with a swelling now on the left side of the neck. So this is contralateral to the previous dissection. But she had a primary on the right side. It was a right buccal mucosal primary and she came with left neck swellings. So biopsy of the primary was a moderately differentiated squam. And the scan showed a 3.7 centimeter buccal mucosa primary extending to lower GB sulcus, lower gingiva, and involving the RMT. The right neck, so the same side of the primary, you had only 1 or 2 lymph nodes in level 2 and level 3, but on the opposite side, there was a left parotid node and quite large level 4 lymph nodes. And the IJV was encased, and there was some loss of fat plane with the sternomastoid and query fat plane with the scalene muscle as well. So Dr. Rahul, this fairly locally advanced case, what would be the way that you would manage her now? Would you offer surgery up front? Would you send her to the radiation oncologist or to...
Can you show the scans once again? Does she have any metastatic workup done?
Yeah, this is a PET. There's no disease beyond what is seen on the scan.
Yeah, I would not offer surgery for this patient. She will go for radiation, and if she tolerates chemo radiation.
Chemoradiation. Yeah. So you're considering this as an inoperable case and sending her for chemoradiation?
Not inoperable. It's aggressive disease.
Aggressive disease.
It's a third recurrence.
Okay.
And surgery would be more morbid.
Okay. Dr. Pratap, any other opinion?
I would agree with Dr. Rahul.
Send the patient for...
Yes, send her for chemoradiation first. Then based on the response, take a call on surgery.
Maybe salvage.
Maybe salvage after the response assessment.
So in your practice, Dr. Rahul, what are the criteria that you generally use to label a patient as inoperable? Now, this case, I think, doesn't fall into the conventional criteria. It's more bad biology. But what do you generally see when you label a oral cavity as inoperable?
So when the primary disease is extending into the ITF involving the skull base, involvement of the pterygoid plates, and in the neck nodes, it is encasing the carotid artery. And there is extensive involvement of the skin with the dermal mets. So these are...
So all these patients you would send for CTRT?
Some of them for palliative care, some for radiation, CTR.
Okay. Dr. Praveen, any other opinion? These?
Maybe I would agree with Dr. Rahul.
Agree with those factors. Okay. So again, different trials have different sort of criteria to call them as inoperable, and there's also this in-between kind of criteria called technically unresectable. I think the Tata surgeons will know a little more about this. So inoperable is with carotid encasement, prevertebral fascia involvement, skull base involvement. And technically unresectable are those with high ITF, peritumoral edema, supranotch, extension to hyoid vallecula, and extensive skin infiltration. So Dr. Santosh, now if there's a patient who has none of these features and is upfront resectable, would you in any case offer neoadjuvant chemotherapy? Is there any benefit at all?
So in an otherwise upfront resectable oral cavity, there is no role of neoadjuvant.
Okay.
So I would not offer any neoadjuvant, directly take on the surgery.
For surgery, okay.
So
and
it is very clear, no confusion.
And this technically unresectable,
Yes.
you have some Tata background,
So in a technically unresectable case, offering neoadjuvant chemotherapy I prefer giving a triplet. In that scenario, there is approximately around 40% conversion rate of these. If we do surgery, these have good overall survival long term. So I would tend to give a triplet if they tolerate, but yes, we have to give, that is the best chance. If they are converted to surgery, then it increases the survival drastically. There is wide separation of those patients after induction chemo. One who underwent surgery versus no surgery. There was all those who did not underwent surgery.
Perfect.
So
And
definitely, malab, in some centers, this
You would
rate
give
of
them a
surgical
chance.
conversion was also to 50% also.
what about those who are frankly inoperable, carotid encasement, etc.? Would you still give them neoadjuvant chemo and see how they turn out? or-
Induction chemo followed by CTRT is not so much I would prefer, but in a technically unresectable, yes, I would push and give this one.
So there are a couple of good randomized studies who have looked at neoadjuvant chemotherapy in patients who are upfront operable. And although they did not find improvement in overall survival, disease-free survival, there was possibly a chance of doing less morbid surgery. So using this concept, an Indian trial, again involving Tata, they've done a phase 2 study of patients with paramandibular extension who would normally require mandibular resection and randomized them to neoadjuvant chemo versus upfront surgery. And they found, interestingly, that in about half of these patients, they could undergo mandibular preservation. So this was a hypothesis generating study, and the phase 3 part of it is probably underway. So an interesting concept of where you could possibly benefit with neoadjuvant even in the operable setting. And like Dr. Santosh said, technically unresectable. Again, Dr. Vijay Patil's trial did show that you could definitely push some patients to resection. About 43% were amenable to resection after NACT, and they had significantly better outcomes. But in the inoperable patients, several trials, a Paradigm, Decide, Interceptor, all of them have said no benefit in adding neoadjuvant. You can just do upfront CTRT. So just to summarize the role of NACT in resectable, possibly in futures, you could think of some kind of organ preservation or mandibular preservation because of the improvement of quality of life. In technically unresectable, it does improve chances of resection. So it makes sense to give the patient a chance if they are fit for triplet. But in inoperable, there's no benefit compared to CTRT. So this patient received neoadjuvant chemotherapy and fortunately had very good response. The primary disappeared completely, the neck nodes shrank considerably and came down to almost millimeter size. Dr. Rahul, would you reconsider and subject this patient to some form of surgery at this point, or still send her for CTRT?
This patient has a good response, so I think sending for radiation.
Okay. So this patient, I think our surgeons are a little more aggressive. They're even operating while we're discussing about chemo, etc. So she did have a resection. She had a neck dissection bilaterally, a superficial parotidectomy, a composite resection, and a flap reconstruction. So Dr. Dilip, after all of this, she had a very good response. It was a YPT0, so the primaries completely responded, and only 3 nodes on the left side were involved, and even the perinodal extension had responded. So what kind of adjuvant therapy would you offer this lady? She hasn't had radiotherapy in the past.
We'll give up to 60 to 66 gray because this was neoadjuvant chemo followed by a good response. So only we'll push for a higher dose. Yeah, even then.
Okay, so
multiple
RT or
nodes on.
CTRT?
If she's tolerable, CTRT.
Okay. So generally, most of the trials have advocated CTRT because you are reducing your extent of resection. There's potential microscopic disease. So with that, I'd like to summarize. We've just looked at these pertinent questions. In early N0 neck, sentinel node is an emerging option. When you do a selective neck dissection, 1 to 3 is possibly enough. Adjuvant radiotherapy, depth plus adverse criteria you may offer. CTRT if extracapsular spread or margin positive, and NACT does have these benefits. And if you are doing surgery after NACT, then adjuvant CTRT is the way to go. So I'd like to thank my panelists, and if there's any comments from the audience, otherwise we'll move on to the tea break, I think, next. Thank you very much. Thank you so much, everyone. I would like to request everyone to have a tea. Our tea break is of 10 minutes, so I request everyone to have a tea and come back here only.
So, moving forward to the session, I would like to invite Dr. Deepak Balasubramanian, Professor, Department of Head and Neck Surgery, Amrita Institute of Medical Sciences, for the topic Filling the Gaps, Reconstructive Ladder in Head and Neck Cancer Defects. So, over to you, sir. Just take.
Yeah, that's fine. Do we wait for the others to come in or do we start? We can start, okay. So at the outset, I'd like to thank the organizers for inviting me and their hospitality. One of the most interesting developments in head and neck surgery is the continuously evolving field of head and neck reconstruction. I know there's a lot of data, I know there's a lot of trials. It's very interesting to listen to all of that, but as a surgeon, you need to know how to fill in the gaps. Mere resection without reconstruction is not considered complete these days. So the purpose of this presentation is to briefly look at regional flaps, why free flaps have become the gold standard, the role of free flaps in head neck and special circumstances in the head neck region. So reconstruction is a very critical aspect of neck surgery. It's essential for both form and function. We have moved from closing a hole to doing functional reconstruction. We also have to take into account the morbidity of reconstruction, and there's an eternal debate of whether free flaps are needed or pedicle flaps are sufficient. So when you look at the defects, there are several aspects to consider. First, whether it's a two-dimensional or a three-dimensional defect, whether it's cutaneous versus mucosal versus full thickness. You think about whether you want to recruit tissue from local sites or from distant sites. You look at the site of the defect, whether it's an intraoral defect or an extraoral defect. And whatever flap that we decide to do, we should avoid tension or torsion during closure, because that will lead to loss of flap. So there are different types of flaps. There are local, there are regional, and there are distant. The flaps can be muscle flaps, adiposofacial flaps, skin flaps, and mucosal flaps. So one of the commonest flaps that we use is the Limburg flap, which is a local skin flap. It's useful for its local skin recruitment, and the scar looks very aesthetic at the end of healing. Larger cheek defects, we do a VY advancement where we recruit tissue from inferior to the defect. So you convert a V defect into a Y defect and then suture the flap. Again, this is very useful for cheek mucosal or cheek cutaneous reconstruction. The other flap that used to be done previously is called the cervicofacial advancement, and now we do the deep plane cervicofacial advancements, which are again good for zone 1, zone 2 or zone 3 defects of the cheek. When it comes to lip defects, usually lip defects can be divided into a third, two-third or total lip defects, and again the defects can be divided into central, lateral or commissure defects, and these are some of the flaps that we commonly use from the local tissue sites. But seldom is it possible, because most of our cancers are full thickness lip defects, result in full thickness lip defects along with commissure defects, and in those patients a thin pliable free flap like the radial forearm with a palmaris longus tendon as the sling is useful. This retains the commissure function, and the patients are able to have a competent commissure. Now, if you look at the differences between a regional flap and a free flap, the advantages of the regional flap are that they are robust. There's no microvascular anastomosis. They have withstood the test of time. It's easy to harvest, minimal donor site morbidity, good for debilitated patients, good in the salvage setting, and good in vessel depleted necks. But the reach and arc of rotation of these flaps is quite poor. It's not possible to contour the flap. There's no readily available pedicle bone flap compared to free bone flaps, and distal vasculature is suspect if you take large pedicle flap. So the good scenarios for local or pedicle flaps are cheek defects, eyelid canthus defects, lip defects, nasal dorsal defects, buccal mucosal defects, tongue defects, and pharyngeal defects. So what are the reconstructive goals? So in the tongue, you need to give mobility, you need to give mucosal cover, you have to have orocervical separation, and you have to provide for bulk. In the buccal mucosa, it's mucosal cover again, and skin may be required if it's a through and through defect. Floor of mouth, again, mucosal cover, and you have to try and give a mobile tongue. For the lip, it's the volume, the sling, and the commissure competence. Palate is oronasal and orosinus separation, and mandible is bone continuity, form, or occlusion. So this is one of the tables I've taken from Gillies and Millard, which is the principles of plastic surgery. There is one line that is very important here, that is borrow from Peter to pay Paul only when Peter can afford it, meaning recruit tissue or to do your local flaps only if the local tissue is able to give you that much surface area. So don't overdo your local or pedicle flaps. So these are some of the characteristics of the 4 common pedicle flaps that we use. There is the pectoralis major, the deltopectoral, supraclavicular, and the latissimus dorsi. So the most common and the easiest one amongst this is the pectoralis major. Almost 50 years ago, it was described. Single stage reconstruction of multiple components of the head, neck, robust vascularity, and even in the area of microvascular flaps, there are still indications for this flap. So this is the large surface area of the pectoralis. You can see here, this is a through and through defect of the buccal mucosa and the oral and the skin of the cheek, and a single stage reconstruction is possible without the need for microvascular anastomosis. One of the important things to do in any reconstruction of the head neck is to do inverse planning. So you use a glove paper, you cut out the contour of the defect, you leave the pedicle intact as a bridge of paper, you flip it to see how it fits into the defect, flip it back onto the chest and mark out your flap, and you can see such large defects can be closed easily with a pectoralis major. The other important flap is the deltopectoral. It's based on the internal mammary perforators, usually in the second and third intercostal spaces. Unlike the pec major, you can see there is a bridge of tissue still connecting the intercostal internal mammary perforators to the skin. This can be divided later, usually 3 to 4 weeks later, and the skin would have taken its blood supply. The flap would have taken its blood supply from the surrounding skin. So this is called division of the pedicle, and this is usually done after 3 to 4 weeks. Again, the DP offers a lot of skin area. It's quite robust, but the distal vascularity, that is the third angiosome of the DP, can be suspect, and in those cases, you delay the flap. This is a forehead, a standard forehead, which we generally try not to use because the donor site is not very pleasing. But here you can see that you can use a large forehead flap to reconstruct much of the upper and lower lips. You can use a sling and attach it to the zygoma to give commissure competence. But this is a last ditch flap. We don't do it regularly as an upfront choice in our patients. Next is the nasolabial. The nasolabial is either an axial or it can be a random flap. It's good for lip defects. It's good for buccal mucosa defects and palatal defects. You can do an islanded nasolabial flap. I think I have the pictures for that. And that allows you to take it into the oral cavity in spite of having intact dentition. Now this is a supraclavicular flap. It's from the of the transverse cervical artery. You get quite long piece of skin, and you can take it up to the deltoid insertion, and then you can flip it to close cutaneous defects or mucosal defects. This is the submental flap again. Oncologically, I'm not a big fan of this flap. You have to be sure that the patient is clinically and radiologically N0. People have dissected the fat off level 1A when they've taken the skin. It's based on the submental artery, which supplies the, from the facial artery, which supplies the submental skin. And here you can see that this is a tongue defect, which has been reconstructed with a submental flap. This is an infrahyoid flap, again a local flap based on the perforators from the superior thyroid artery. The vein usually goes to the superior thyroid vein into the IJV. It's a good flap, thin, pliable tissue. You can use it for floor of mouth defects or for tongue defects, and the neck is usually closed with a Z-plasty. This is what I meant by an islanded nasolabial. You basically raise the nasolabial, dissect it out on its pedicle, bring it to the neck, take it back into the oral cavity through the floor of mouth, and use it to reconstruct the tongue defect. So it's basically like a free flap, but you isolate the entire flap based on its pedicle. This is the temporalis for the palate. Remember the dictum, if you have fixed mucosa that needs reconstruction, like the palate or gingival mucosa, you can use muscle for reconstruction. But if you have mobile, pliable mucosa like the buccal mucosa or tongue, you need a skin-lined flap. Otherwise, the flap will heal by secondary intention and it will cause scarring and restricted mobility. So for pharyngeal reconstruction, I'm not going to talk to you about jejunum or gastric pull-up, just the two common faciocutaneous flaps that we use. This is an example of a supraclavicular flap, which can be tubed. The advantage of the supraclavicular over the pectoralis major tubing is that supraclavicular is relatively hairless. So this is a patient who had a large supraclavicular that was tubed and used to reconstruct his pharynx. This is the picture of a pectoralis major being tubed. You can see it's quite bulky. You have to at least have 8 centimeters of width to be able to tube the pectoralis major, and the skin sometimes becomes difficult to cover. So in those cases, you would need to put a skin graft to close the neck. So like I said, the most important difference is the amount of hair that the pectoralis has. It is quite difficult for the patient, but it's more robust. The vascularity is much better, and it has muscle on top, which will help to promote healing. So that is about the common local and pedicle flaps that we use. The current recommendation or the current gold standard is to use free flaps. So there are wider options. You have options for bone reconstruction. You have larger flaps that can be harvested. It's not restricted by the pedicle. You can replace multiple components, 360 degrees of movements, and simultaneous harvest is possible. So you have different components, different flaps. So you can have faciocutaneous flaps, you can have faciocutaneous with muscle, or you can have osteocutaneous. And these are some examples of flaps that we use. These are some of the facio and faciocutaneous and a muscle only flap. So this is a radial forearm, this is an ALT, this is a thoracodorsal artery perforator, and this is a vastus lateralis muscle flap. And these are some of the bone flaps that we have. This is a fibula osteocutaneous bone flap. This is a lateral border scapular osteocutaneous bone flap, and this is a deep circumflex iliac artery bone flap. So radial forearm is still the workhorse for now for us. It is usually from the radial artery and the venae comitans. Thin, pliable skin, but it is hairy, and the problem is you have to close the donor site with a skin graft. It's ideal for lateralized tongue defects, buccal mucosa, and palate. So here you see a lateral tongue defect. This is the radial forearm raised along with its cephalic vein, and this is the inset of the flap. The only disadvantage in my book is the donor site. If the graft exposes, the tendons expose, you have to debride, there is stiffness of the fingers. So what I prefer to do for tongue defects is the lateral arm flap. So the lateral arm flap, as the name implies, is skin from the lateral aspect of the arm. So the scar is hidden and you can close the donor site primarily. This is a hemiglossectomy, and this is a lateral arm that has been harvested. The only issue with the lateral arm is that you have to be very careful when you dissect the radial nerve off the pedicle, and you have to be able to do microvascular on very small vessels because the vessel diameter is only 1 to 2 millimeters. This is a medial sural artery perforator flap from the calf. It is a very thin flap. The artery is from the popliteal artery. So we have harvested the flap here, and we have tunneling the pedicle to the neck to do the microvascular anastomosis. And this is how it looks like after the inset. The primary site, the donor site, can be closed primarily. It's hairless, it's thin, and it's concealed in the calf. The next common flap that we use is the anterolateral thigh flap. So it's large skin paddle. Virtually the entire skin of the lateral thigh can be taken. It's a concealed donor site, can be harvested with skin or muscle, and 2-team approach is possible, and it's good caliber vessel. So look at this massive glossectomy. This is a total glossectomy with dissection of the tonsillingual sulcus and the tonsil. So you can contour the flap to different parts to fit in different parts. This is through a mandibulotomy. This is how the flap is inset into the tonsil, floor of mouth, and to the gingiva and to the other side floor of mouth. So this is the principle for any total glossectomy or subtotal glossectomy. The flap should be bulky. There should be good palatal contact. It should eliminate the insensate gutters. It should be protuberant and aesthetically acceptable. This is another total glossectomy patient, and in this case we used a profunda artery perforator flap from the medial thigh. So it's called a PAP flap. It's usually described for breast, but we do it for tongue and buccal mucosa. Again, all of our goals have been met: protuberant flap, palatal contact, and all the insensate gutters are eliminated. So this is an isolated salivary gland tumor of the base of tongue. Again, for volume replenishment, we can use the ALT flap. And just to contrast that, if you need a thin flap to cover a marginal mandibulectomy defect, we can use a radial forearm. But if you have composite defects or large defects like posterior segmental mandibulectomies, intratemporal fossa clearance, using a large ALT is good because it will give good aesthetic results and good bulk for the patient. What do you do if you have multi-axial, multi-component, multi-subunit defects? So this is the way you raise an ALT. Two skin paddles, one vastus latalis bit here, one vastus latalis bit there. So it's very easy for us to use different components to reconstruct multiple defect sites. This is something which I like a lot. This is functional oral cavity reconstruction. This is using the tug flap, transverse upper gracilis. So this has the gracilis muscle along the floor of mouth. You take the obturator nerve and you anastomose it to the hypoglossal nerve so that it moves, and you have a protuberant skin paddle which makes contact with the palate. So this is more functional. After some time, the tongue starts to move, at least propel itself upwards to touch the palate. So these are some of the common bone flaps that I had shown you the picture earlier. A lot of people ask me, what about pedicle bone flaps that do not require microvascular anastomosis? So this is a picture of pectoralis major with rib. You can do that, but the rib attachments are flimsy. Or you can do a pectoralis major with sternum, and this is how it looks like on the patient. Again, the inset is quite difficult and plate exposures are common. So that is why we prefer the fibula, because you have multiple advantages of the fibula: the length, the ability to osteotomize, the shape, osseointegration. There are several benefits with the fibula. So this is a picture of a DCIA. I wanted to show you this before we start on the fibulas, because the DCIA gives you very good bone height. So you can easily place dental implants, whereas the fibula doesn't give you that much bone height. And the vascularity of the DCIA is far superior to the vascularity of the fibula. So this is a patient who had an ascending ramus resection along with a horizontal ramus. And you can see that you can osteotomize the fibula, meaning you can remove wedges of bone between the segments and bend the fibula to the defect. And this is the patient after the reconstruction. You can see the bone is healed well and it almost resembles the normal mandible. She got implants after that with a Paris bar, and this is how she looks after the osseointegration has been done. I know Deepak is going to speak about 3D planning. I just have few slides. This is a right horizontal ramus defect. We first make the cutting guides virtually to tell us where to resect the mandible. After we make the cutting guides, we figure out how many segments of fibula we need, and we also construct the reconstruction plate on the patient. Then we image the fibula and decide how many segments we need, how much of the osteotomy has to be done, and we prepare osteotomy guides. Finally, this is transferred to a printed 3D model of the mandible. So these are various steps that we do. This is the fibula that has been harvested. This is the plate and the fibula that has been placed inside. And you can see in 12 weeks, this is the reconstructed part of the mandible. It has the exact same height as that of the native mandible, and you cannot see any of the osteotomy sites. Everything has healed well. So when it comes to maxilla, you have to ascertain what your reconstructive goals are. whether you want to reconstruct the alveolus, nasal buttress, orbital floor, or the zygomatic buttress. And each of them, there is a different configuration of fibula that has to be harvested. So there are 6 to 8 different configurations of the fibula. These are some of the configurations. You can do it for the orbital floor, you can do it for the alveolus, you can do it for the nasal buttress, zygomatic buttress, you can have 2 skin paddles, you can have muscle. So fibula gives you a lot of options. But you have to know what configuration and what construct you want to use for your defect specifically. So this is a patient who has a right-sided maxillary tumor, and this was his planning and 3D model. So he needed an orbital mesh for orbital floor support, and he needed 3 segments of fibula, orbital floor, 1 for the zygomatic buttress, and 1 for the alveolus. So this is how it looked like after the flap had been placed, the bone segments had been placed. This is how he looks like now. We try to avoid facial incisions in most patients, and this is after his complete dental rehabilitation. The DCIA is good for maxilla also. So this is an upper alveolar tumor where the DCIA was taken with the internal oblique, and like I said, for fixed mucosal defects like the hard palate, the DCIA internal oblique works very well. So I worked with Jonathan for a year and a half when I was doing my fellowship in Australia. There's a flap called the angular scapular flap based on the angular artery. So you can place it, it's triangular in shape. So you can place it horizontally to match the curvature of the hard palate, or you can place it vertically to give support for the anterior wall of the maxilla. So this is the scapular angle flap. It's got a very long pedicle length because it comes from the thoracodorsal artery. So bone defects, maxilla versus mandible. If it's orbitomaxillary defects, these are the options that you have. If it's alveolar defects, these are the options that you have. If there is a mandible with single axis defect, a fibula or a DCIA would do. If you have multi-axial defects, you use fibula, scapula, or ALT with femur. I prefer the scapula because you can get lots of different components in the flap. So in conclusion, body habitus, nature of the defect, and surgeon comfort decide the type of flap that is going to be used. In today's reconstructive practice, if you know radial forearm, ALT, and fibula, more than 90% of your defects you can close. You have to pay particular attention to donor site morbidity. Patients should not come back to you with infected wounds or exposed tendons that need to be debrided. And if you're doing a free flap, you need to know flap monitoring. You have to be prepared to re-explore the patient, and you should have good microvascular skills to ensure that your flap success rates are acceptable. So I have a YouTube channel which has about 6 lakh views so far. All of the videos are there for flap harvest. All the different flaps that I mentioned, there are videos. Please feel free to have a look at these videos, and we will try to add more videos in the future. So thank you all for your kind attention, and if any questions are there, I'll be happy to take them.
While doing reconstruction,
yes,
you prefer to do after surgery or before surgery? Because sometimes the flaps would take long time for it to get healed, and by the time we start adjuvant RT and all, the recurrence would have already started in some cases.
Sorry, sir, you're saying that for advanced tumors, by the time you start radiation, there is tumor recurrence.
After reconstruction,
yes.
Most of the time it would be, if it is delayed for any reason.
The RT being delayed.
Yeah.
Yes.
No, the engrafting is delayed. We find it already recurrences happening.
Usually I don't skin graft any of the defects. If you look at the reconstructive ladder, it's one of the lowest options that we use. So we never skin graft any of the donors, recipient sites in the head neck. So I don't know your institute specific practice. We always put a skin line flap for whatever defect that we need to, if it's a soft tissue defect. So I don't think that occurs. We don't have that specific thing occurring in Amrita. We don't skin graft any of our defects like that. Unless it's a calvarial defect where there is intact periosteum, we generally don't skin graft any of our defects.
Thank you for the methodical presentation. One thing I wanted to ask is, it seems that you prefer to use fibula for the maxillary defect. And
fibula or DCI?
Yes.
Yeah.
So if we use fibula and
Yes.
the maxillary, that flaps will be skin flaps, native skin flaps will be very thin, and the fibula may be exposed after 2 to 3 years because of that atrophy of the skin. So how you deal with that problem?
I might have done close to 500 fibulas. I've never seen after 3 years the skin being exposed.
No, not fibula skin.
I mean the hardware and the bone being exposed.
Not exposed. They are visible outside. Like, have you put bone this fat graft or something?
No. No. In a radiated bed, dermafat or whatever fat grafts don't work because it won't take. It's an avascular bed, it won't take. So we've never experienced anything like that. The most important thing is that the closure should be supple, meaning that you have to allow for the skin graft to contract over time. So don't make it too tight a closure. One of my seniors, Naveen, always told me, never burn your bridges. Even if you feed in more flap initially, we can always correct it later. But if you just take a small skin paddle, saying that I'll tightly cover it or I'll make sure it doesn't stretch, those are the problems those are the reasons why you have problems later with contraction and exposure. So take a supple, thick or a very wide skin paddle and then try to close the defects. But never put dermafat or anything into a radiated bed. It doesn't work. Yeah, Deepak?
If it's okay, can I address
Yeah,
the question
please.
here? I think what he was asking was that if your skin flaps are really thin, and that could be when you resect an alveolus cancer, let's say with paramandibular spread.
That is more for mandible.
And that's when you get hardware exposure. And he was asking if on the maxilla is that an issue? I think it might be if you raise really thin skin
See,
flaps.
maxilla you use non-recon plates. For mandible you use recon plates. Even if you use low profile recon plates, if you elevate the cheek, from a lip split or something, what I would do is I would take extra skin, de-epithelize it, and then put it over the plate and then close the chin. But for the maxilla, it's not much of a problem because you use non-recon plates in the maxilla. So exposures are not that much of a
I was
problem.
going to add that comment that exposure normally happens when you have thin skin tightly on a plate where it's sort of bearing the weight of the skin. If the plate's deep, it's not going to happen. And de-ep skin folded over plates is a great way to prevent exclusion.
Yes. Okay. Okay. We never do that. We do a lot of maxillas, but we generally don't do 2 flaps for that. Yeah. Okay. Thank you very much. Can you take my note?
Thank you so much, Dr. Deepak. Now, next, I would like to invite Dr. Deepak Sarin, that is Head and Neck Surgeon, Medanta Hospitals, Gurugram, for the 3D printing and CAD in head and neck cancers. So, over to you, sir.
Presentable. Yeah, this is fine. Thank you. Good evening. The previous speaker stole a bit of my thunder and ran away. But what I'll do in the next 20 minutes is introduce you to the concept of 3D planning, what's the basis behind it, and share with you some of our learnings and results that we've had over the past 7 years that we've been using this. So we know the mandible is really important. I mean, it provides structural support, functional support to the oral cavity, and that's why when we treat oral cavity cancer, either preserving the mandible or reconstructing are important goals. The classical commandos with the pectoralis major flap was a very effective way of treating oral cancer, but not a very efficient way because the patients often suffered numerous problems from the loss of the mandible. And a lot of that was reversed when we had microvascular free tissue transfer. We saw some excellent examples of how bone reconstruction can be achieved very well in the microvascular era. And the fibula is very quickly become the workhorse because you can get a long stock of bone, and extremely long and large defects of the mandible can be reconstructed. Now, what I'll talk about is how we've changed or evolved in the use of the fibula or how we plan it. You see, classically, when we use a fibula flap, we are doing what's called a defect-based reconstruction, which means you do your operation and then the reconstructive team sees the defect and tries to align the fibula to the defect, right? It's time consuming and it has a strong experience-based result. Now, you saw some excellent results in the previous speaker's presentation, but that's a lot of experience talking, and you won't always get a great result because you're basically trying to fill a defect with a construct that you have no idea what it originally looked like. You're just filling in a defect. Now, I'll show you some of the problems that we've seen, and everybody who's done a fibula would have seen them to a lesser or greater degree. Now, take for example this patient who's going to have a planned resection of the body and the ramus. This is the placement of the fibula intraoperatively. It looks fairly good. But when you see the caudal view, you can see that it's far from ideal. There is not enough projection of the body of the mandible, and there will be indipping of the cheek in this patient. When seen from the lateral view, you can see the angle is not in its natural position and is highly placed. This would lead to poor aesthetics. The challenge is bigger when you're dealing with the anterior arch, because once you've taken the anterior segment of the mandible out, there is very little to guide you how to build the arch of the patient. And you could either underbuild it, causing retrognathia, or you could place it incorrectly in height, not giving proper chin protrusion. There is also the issue that we see of condylar swing. So when we finish our resection, two things happen. The condyle, because of the unsupported pull of the pterygoid muscles, actually rotates inwards and upwards. And the remaining segment of the mandible also gets pulled in by the muscles to it. Now, these are not in their natural alignment anymore once the resection is completed. We can reposition the mandible back, especially if it's dentulous, by doing an IMF with the upper teeth, but it's very difficult to actually reposition the condyle back into how it naturally was present. And when you go ahead and attach a fibula now to a displaced condyle, you will have problems in the long run. Either you'll get trismus because the condyle will get pulled out of its socket, or the entire mandible construct will actually shift over time and you'll get malocclusion. So what CAD/CAM planning basically aims to do, it aims to overcome all these defects. How should I say? It aims to overcome some of the drawbacks that happen when you take a defect and you try to fit a fibula into it. And what CAD/CAM based planning is about is you move from defect based planning to resection based planning. What that means is that no longer are we looking at the defect that's being created. You're actually looking at the segment that's being removed. And what you want your fibula reconstruct to do is to actually mimic the resected segment. Mimic it in its contour, in its length, and very important in the cut edges, the angle of the cut edges, so they can approximate perfectly with the remnant of the mandible when it's put in place. And how we achieve that is by designing the fibular construct on the patient's nascent mandible virtually. So you can see on these three images, that's the fibular reconstruct being superimposed on the patient's mandible to align it to perfect shape, perfect size, perfect projection, good contours, an excellent angle of contact of the cut edge of the mandible with the fibula reconstruct. I'll shortly explain how this is done. Basically, that's what you want to do. Now, to achieve this, you'll do the designing on the software. and then you will print cutting guides, which you will carry to the operating room, which will help you replicate what you virtually designed on the software to physically on the patient in the operating room. And these are some of the steps that are there in 3D planning. We take very fine cut CT scan images, 0.6 to 0.75 millimeters. The entire facial and leg bones are reconstructed, and then you separate the jaw and the fibula from the rest of the bones and the soft tissue. At this point now we are ready to plan our resection. So the planned osteotomies on the mandible are done on the software. This is the planned resection of mandible. And then we'll place the fibular construct into this defect. The next video actually is the crux of CAD/CAM based planning. It's how when you place the fibular construct in the defect, the software will automatically transpose it onto the fibula, telling you where to make the osteotomies, of what length and at what angles, so that when you bring them together, these segments, you reconstruct the entire mandible's shape. And watch closely on the upper frame, on the lower frame. As I adjust the placement of the fibula on the mandible, you'll see the osteotomies on the fibula bone shift automatically to align it perfectly. So I'm going to pull it in because it seems a bit out. I'm going to pull the body in a little bit to bring it better in alignment. Watch the osteotomies on the fibula move automatically. And then we'll pull the angle in a little bit. This is really the crux of CAD/CAM based planning, is you can design the fibula in whatever shape you want in the defect, and it will automatically transpose it on the bone, telling you where to osteotomize and how to make the cuts to get that shape eventually. And finally, one would then export these as an STL file, take them to a 3D printer, who's going to print guides, both how to cut the mandible exactly where you wished, and as well as how to cut the fibula and osteotomize it at the places that you had planned on the software. So in the operating room, the cutting guide on the mandible is rigidly fixed, and then using a saw, cuts on the mandible are made at the pre-planned locations. Similarly, the cutting guide of the fibula is snap fit onto it, then secured, and in situ, while the bone is still in the leg, osteotomies are made. The length of the segments and the angle of the osteotomies has been pre-decided. And now when we bring these segments together, just joining the ends to ends, we'll create a bone of the desired shape that we wanted. The plates can be pre-bent on a 3D printed model, and that's the entire fibula reconstruct after having joined the osteotomized segments together. Now what you'll see in this reconstruct is we have perfect apposition bone to bone because no readjustment is required. It's the first alignment is the perfect alignment. So there's excellent union between the two cut ends of bone, which leads to rapid healing. And Deepak showed you that lovely OPG of 12 weeks of healing. That's what you get. You get very rapid and very quick healing because there's perfect bone union between the osteotomized segments. And this reconstruct now is a perfect replacement for the resected mandible. You slot it into the defect, you align it to the cut ends of the mandible, and you fix it into place. This will automatically put the remaining mandible segments into occlusion and give you great aesthetics and great occlusion. So we've done just over 300 patients till date using this technology in the last 7 years, and I'll pictorially show you some of the results to highlight the kind of results you can expect with this, and also some of the nuances and variations that you can use. So this is a straightforward, easy defect. We're looking at doing a segmental resection on the body of the mandible in this patient. That's the intraoperative photograph showing you the defect on the left slide, and that's post-operative, the OPG showing you the fibula placed in. What we did in this patient based on our CAD-CAM planning is give an extra osteotomy on the body just to give it better projection. Otherwise, the cheek always feels like it's sunken in. And these are the aesthetics when seen from the anterior-posterior view preoperatively and 6 months postoperatively. This is a complicated case, a very difficult case for reconstruction because essentially you're resecting a very, very large portion of the mandible from the angle on one side to the body on the other. And once you finish a resection, there is nothing to guide you how to build this mandible back. You could build it in any shape that you feel appropriate. But with CAD-CAM planning, you can pre-decide how you want to place the fibula. You could put it in alignment with the upper alveolus, and you can even plan for implants. And that's the post-operative orthopantogram showing the fibula in place. And these are the aesthetics 1 year post-operatively. It's also useful if you're planning dental implants. If we are planning dental implants, we plan in reverse. The mandible has two planes. There's an aesthetic plane, which is the inferior border, which gives us our jawline. This is in a different plane than the occlusal plane, which is more immediately located. The occlusal plane is in which our teeth are implanted. These two are not in alignment. So if you want to implant somebody, then you need to have a good occlusal plane, bone in the good occlusal plane. But you also want to simultaneously maintain good aesthetics. So what you do is you do reverse planning. You first virtually plan where you want to place the implants and how many implants you want to put. Now you will then place your bone in a manner that the implants can be securely placed into a good vertical height of bone. So that's the lower border being built, or the aesthetic plane being built. And in this case, because we needed more height, we've placed another half segment of fibula on top, and that's in the occlusal plane, so that can take the shaft of the implants. The planned positions of the implants are then incorporated into the 3D printed guide. So the implants are placed exactly in the bone in the correct direction that you had designed on the software. And using a no-touch technique, they can be placed primarily at the time of initial surgery. So this is a child with an ameloblastoma of the left body who needed a segmental resection, and that's the design contour. You saw the 1.5 height fibula being placed in a manner that will allow dental implants secondarily later in life. And that's the preoperative CT and OPG on the left, and the postoperative OPG and CT on the right. Aesthetics a year post-surgery. He's got good occlusion of the nascent mandible. Hopefully when he gets dental implants, he can have full dental restoration. So one of the other nuances of using this is sometimes patients who are having a marginal mandibulectomy also desire implants. But the height of the remaining marginal segment is too small to take the implants, and it's too far away. The implants would be highly cantilevered in it and relatively unstable. So you can build the height of a marginal mandibulectomy using CAD-CAM based planning. And this was a practicing doctor who was having a marginal mandibulectomy from the canine posteriorly, early stage disease, and he really desired dental implants. So these are intraoperative photographs showing the defect on the left of the marginal mandibulectomy, and then a fibula which was appropriately contoured in the occlusal plane being placed into the marginal effect simply to build the height of the mandible. These are his pre and post-op aesthetic images, and this is his intraoral view following complete dental rehabilitation a couple of months down the road. One of the concerns we did have is that these things look very good. Are the results durable over time? Especially in patients who get radiation, they do get a lot of scarring. They get a lot of asymmetric muscle pull. And the question was whether these good results will be replicated on long-term follow-up, particularly in patients who receive post-operative radiation. So this is a gentleman with a very large left alveolar cancer, as you can see. That's his resection and the fibula construct that is being used. And these are his aesthetic results 2 years following radiation, with fairly well-made contours in all views that we can see. So these were pictorial results which are highly subjective, and sometimes, as we all know, these are the better of the cases. We also wanted to objectivize the results and see, are these results that we think better Do they hold up to scrutiny by an independent third party? So we looked at objective outcomes, and there were two outcomes. We looked at aesthetics, and we published this a couple of years ago. We took our initial first 40 patients that we did with CAD-CAM based planning and compared them to 40 patients done prior to the era of CAD-CAM based planning who had fibulas, which was the conventional technique. And we had 3 plastic surgeons who were blinded to the technique used to score them on an aesthetic scale out of 5. And with CAD-CAM, we could see that the scoring even by independent viewers on an average was better than those who did not have CAD-CAM based planning. And this was statistically significant. But I think very important, aesthetics are one aspect. One of the very important reasons why we do bony reconstruction is actually to give them occlusion on the remnant mandible, because that's the side the patient is going to use to chew. And if you don't get great occlusion on the remnant mandible, it really negates one of the important benefits of bone reconstruction. So we looked at occlusion, the rates of malocclusion in those without CAD-CAM and with CAD-CAM, and those with CAD-CAM had fairly low rates of malocclusion at 2.5%. It's 1 patient out of 40, as compared to 15% in those who had conventional placement of the fibula. We also saw that using CAD-CAM actually saves you time. On an average, it was 1 hour and 40 minutes shaved off the operation. And that's because you don't need to take the fibula down, remodel it, place it back again and again. We also theorized that the fact that once you osteotomize and place the fibula construct in and you don't have to disassemble it again and again, there is less handling of the flap, less likely stripping of the periosteum, less shearing of the perforators, and theoretically you may have lesser failures. And we saw that in our results on the first 100 patients that we analyzed. These were in the first 2 years after using it, where we had a re-exploration rate of 4%, no total flap failures, and 2 partial flap failures, which was, I think, anecdotally better than what we used to get with conventional insets of fibulas. And we saw this reflect in the increased use of fibula, at least in our practice, with better results and lesser failures and lesser operative time. Our threshold to offer a free fibula, you could see increase. Really at 2017, and these are all figures from more than 5 years ago, we could see the percentage of patients being offered a free fibula flap in our center at least grew, and that percentage is probably much higher now. So I think this is the aim, really. When we are trying to bony reconstruct, you actually want to give the patient back an almost exact replica of what he was born with. It's difficult to achieve that, and this is just one of the ways to try and improve upon what we can manage. And I do want to acknowledge Dr. Khazanchi, Dr. Mahendru, who are leaders in the reconstructive team, and very importantly Rahul Jain. He's a maxillofacial surgeon on the team, and I didn't mention it earlier, but all the planning, everything is done in-house. And in India this is very important, because one of the questions you get asked is, how much does it cost? It costs our patient nothing, because the entire planning is done by us. It takes a few hours, but we can plan it on a software. The only cost the patient has to bear is that of professional 3D printing, which is around 20,000 per case for printing of the plates. But so even in a resource constrained setting, it's a viable option as long as we bring in the expertise of in-house planning. And Rahul holds a couple of courses every year to teach hands-on on software how to do it. He's held 2 till now, including at last year's FHNO. And if anyone's keen to attend the next course, just get in touch with me and I'll put you in touch with him. So if you want to start this off, he can keep you informed of whenever the next training course is. Thank you very much.
Thoroughly impressive. Regarding the implantation of the teeth, when do you do it? Do you do it in the same sitting or you do it in a different sitting?
So I'll preface that by saying we are very selective in offering who gets implants. Only a minority of patients actually getting bony reconstruction are offered implants, actually. you need a, because implants itself is a multi-step process in requiring visits to the operating room. You need to expose the implants, you need to thin down the flap, then they need to have multiple dental visits. You need a really well motivated patient. You need good mouth opening. That's kind of a prerequisite for a free fibula to start with. Ideally, and you can never be sure about this, but we should not anticipate the need for radiation. Ideally. If we have to implant, so in a patient who's carefully selected, if we have to implant, always primarily, it's better for malignant disease. Because if they need radiation, secondary implants have a much bigger problem after radiation. In fact, I would be very disinclined to reimplant anybody who has received post-operative radiation. We've done a few, there are a few successes, but there are a few failures as well. So our threshold for secondary implants is not great. So if we have to do it, and even if we anticipate the patient may need radiation, it would be primary implants at the time of surgery.
How accurate is the fibula osteotomy guides in your practice? Do you cross-check them before surgery?
No, you don't actually. So it's a very good question. I think there are many layers to it. How accurate is the fibula guide? It's excellent. Let me put it this way, it's virtually flawless because it's on the software, so it's computer generated. There can be flaws in execution though. That's a concern. So in other words, what you designed on the software is perfect. That can't be faulted. But the guides that you print and take to the operating room may have slots that are too wide, for example, and your saw moves in a different angle. So theoretically, you can have execution issues, but not designing issues. So we've learned a lot. So we've gone from a larger slot size now to a 0.7 mm slot size. So the saw can only move in one direction, can't angulate the wrong way. We've used different materials, so they don't have any play anymore. But if you get your osteotomy in the place where you are designed it on the software, the construct is perfect. It is nothing wrong. We did a analytical study seeing if what we design actually gets replicated in the patient, exactly to account for execution issues. So we used multiple points on the software that we had designed, and then we used the same points on a post-operative CT of a patient and saw how much had that points moved. And generally the movement was less than a millimeter or two at all those points. So it seems like the mandible that you wanted to make is what you'll end up making in general. So it's very, very accurate. One of the things that can happen and you have to account for in planning is what if your osteotomies change. Now this can be a challenge. So generally and that's generally a struggle in patients who don't have good mouth opening, which sometimes you can't see the posterior extent of the tumor or you can't see the lingual aspect of the extent of the tumor and you underestimate it. So at that point, we'll often design two guides. So if, for example, I see a patient who I think will need a cut at the mid-ramus, but I'm not very sure, I may make a guide that requires the back cut at the mid-ramus, but also one that makes it at the condyle sparing. So you can actually have two cutting guides taken to the operating room, and you can make use the appropriate guide once you have the exposure and you've judged accurately what resection to do. In 2 patients till now, we've had unplanned change of osteotomies, and that of course does take away a little bit from the planning. Unplanned means we didn't anticipate it, we didn't account for it, but intraoperatively we had to change our osteotomy, and they had less than perfect results because the element of human error crept in a little bit.
Sometimes when the resection changes, the whole plan goes haywire.
Yeah, so while planning, you have to be very careful that you've made a great assessment of the disease and you very carefully planned it. So the planning is done with me and the maxillofacial with a clinical exam of the patient and the scans. And you always can go 5 millimeters more than what you expect. So if you're going to do mid-ramus, you can go upper ramus. There's nothing lost by taking another half a centimeter in that area. So as long as you plan well, you'll almost never have to change your resection.
Thank you.
Thank you.
Thank you, sir.
Thank you, Dr. Deepak Sarin. Now I would like to invite Dr. Parveen Ahlawat, Consultant Radiation Oncology, Rajiv Gandhi Cancer Center, Delhi, to topic re-irradiation in relapsed head and neck cancers. Welcome. Over to you, sir.
Good evening, everyone. Thank you, AIG Hospitals and organizing team for inviting me to deliver this topic. The topic I'm going to speak is on re-irradiation for recurrent head and neck cancer. These are the questions I will be dealing with. So, why is this topic relevant? We have over last 2 decades, we have done significant advancement in all specialty surgery, radiation, systemic therapy. But no matter how best you do, almost 30 to 50% patient will land up having loco-regional recurrence. Those who survive recurrences, some of them will have risk of second primary all through their life. And the figure ranges from around 15%. Around 5 of them will develop isolated nodal recurrences. So it is important to deal with this topic. This is the treatment outline for recurrent head and neck cancer. All recurrent head and neck cancer needs to be assessed whether they are resectable upfront or unresectable. If they are resectable, we should do every possible attempt to do surgery. Now, surgery has been a traditional standard of care for resectable. However, not many could undergo salvage surgery, depending upon how experienced, how well the facilities are there in your center. Those who are unresectable, systemic therapy used to be mainstay of treatment, but not very impressive results. These days, re-irradiation has emerged as another modality of treatment for recurrence, unresectable tumor. Historically, it was avoided. At least I remember in my post-graduation time, we used to say once irradiated can never be irradiated. However, things have changed after the emergence of intensity modulated radiotherapy. Re-irradiation is a challenge. Challenge is because the patient has already received a very high dose of radiation to a large area, both in the primary site as well as in the neck side. And once irradiated, the normal tissues never forgets the doses delivered completely. So the surrounding organ structures have most likely been already exhausted because of previous radiation. So delivering almost same dose again is a challenge because each organ has certain limitations to how much dose they can receive. Why it is so challenging, though why it isn't so vogue these days? So these are the reason. Now with we have all of us are treating with intensity modulated radiotherapy. Now all radiation oncologists have this renewed confidence in delivering a second course of radiation with radical intent. And after seeing so many publications, retrospective although, we are in a state to identify how best to select patient with re-irradiation. When it comes to literature, re-irradiation, the randomized control trials are very few. All that we have is mostly retrospective, few prospective single institutional studies. So these are the questions one by one I will be dealing with regarding re-irradiation. The question was why should we re-irradiate? Why can't we just continue to give palliative systemic therapy or best supportive care or some other modality? It is because we need to control this tumor progression. Head and neck cancer are for a very long period of time, they remain confined above the clavicle. They keep on growing in their local site, causing bleeding, pain, disfigurement, infection, altered swallowing, and ultimately all these things lead to death. So achieving local control in patient with recurrent disease is paramount. You do whether with surgery or re-irradiation. And we hope that it not only provides symptomatic relief, but also improves survival. Why to read it again? So these are the few studies, all of them are retrospective. They shows that if you do re-irradiation, the 2-year overall survival is approximately 50%. Severe toxicity range from 10 to 15%. So it is acceptable to have these complications if the survival is around 50%. This is my own study I had done in 2014 in Rajiv Gandhi Cancer Hospitals. We saw that overall survival at 2 years was 48%. All these patients were treated with two-dimensional radiation therapy. Then an important thing we realize is those patients who will survive long, who have better local control. So if you are able to control locally recurrent disease, these are the patients who will go on to survive for a long period of time. We updated our results again in 2017 with when we have completely shifted to IMRT. The results were even far more better. This time median survival was 28 months and 2-year survival was 55%. We did found some toxicity, but not very large amount. Now, currently, we have treated 178 patients with re-irradiation, 64 with radical intent, and 36 with adjunct. So, median overall survival now is 26 months. 2-year overall survival is around 50%. So, second question is when to irradiate? What should be the gap time between first and second course of radiation? There are a lot of publications, mostly retrospective. So I'll quote one prospective trial, RTOG trial. It shows that if you deliver radiation after 1 year of time gap, the survival is better. But it is felt that the best candidates are those who have at least 2 years. Third question is what is the optimum dose of RE-RT? In upfront newly diagnosed patient, radical dose is 70 gray, adjunct is 60 gray. What should be the minimum dose for re-irradiation? On the left, you are seeing RE-RT series before RT era, and on the right, you are seeing IMRT era. So you see, most pre-RT era, we could not deliver higher dose. Most people have delivered 46, 50, or few have delivered 60 gray. But with the introduction of IMRT, we are able to deliver much higher dose to higher enough to cause a tumoricidal effect. What to irradiate? So this question was solved by this retrospective study, pattern of failure after re-irradiation. What they done is they have controlled the gross tumor disease, actually all around in 3 dimensions. They looked at the local regional failure. They found that great majority of second recurrence occurred within 0.5 to 1 centimeter, immediately around the vicinity of gross disease. So it makes sense that if you are going for re-irradiation, very tight, limited margins are sufficient. So in practice, it appears that 5 millimeter margin should be sufficient. Question 5. Should we do elective nodal irradiation? We always do for newly diagnosed patients, whether it is radical setting or post-op setting. But for re-irradiation, a lot of studies have proven that limited re-RT volumes should be used, and we should omit elective irradiation for the neck nodal area. I'll come back to another study later. Which technique should be used? Can we do 2-dimensional radiotherapy or IMRT? So on your left, you are seeing experience with 2-dimensional therapy. The overall survival that time used to be 2-year overall survival around 20%. After the introduction of IMRT, the survival has increased to almost 50%. And there are studies which has compared 2-dimensional and IMRT found a significant survival advantage with IMRT. Question 7. Can we deliver to post-op patient? That is, patient had a resectable recurrent disease. What is the benefit of delivering adjuvant re-irradiation? So one of the few randomized trials we have is the GOTEC study, which randomized after salvage surgery into wait and watch versus adjuvant re-RT plus concurrent chemo in high-risk patients. So results were giving re-radiation significantly improved locoregional control, disease-free survival. However, overall survival did not change. So all those who believe that they want to prevent locoregional recurrences or disease-free survival, there is a role for adjuvant re-radiation. Late toxicity after adjuvant re-radiation is high. It is primarily because the volume of irradiation was large, and in many of these studies, elective nodal irradiation was also done. So you get benefit of adjuvant re-RT, but at the cost of high toxicity. Now, how should we approach very nice study by Muri collaborative group. What they done 412 patients. They studied to 412 patients. All of them had undergone re-RT either as a definitive or adjuvant setting. On the red is the progression of death. The progression has happened at almost 1 to 1.5 years. After that, it plateaus down. Similarly, late toxicity, grade 3 or more, also peaked at around 1 year and then plateaus down. Two, when it comes to individual toxicities, we see that there is significantly higher troublesome grade 3 toxicity in the form of aspirin. High toxicity. How was the result? They found a and 2 year overall those who undergone surgery did better. So based on these, they had come up with a patient selection criteria approach. We will see later. When they compared post-op versus definitive, that is patient who had resectable versus unresectable disease, so there was significant difference in survival. Whether it is node negative or node positive, there is no benefit in doing elective nodal irradiation. It only adds to whether it is definitive RT, whether it is post-op RT. If it is definitive RT, go try retrieving 66 or more. There is no impact of fractionation whether you do once a day or twice a day, whether it is a definitive setting or radical setting. So with this, they have come up with an approach. The approach is all recurrent head and neck cancer should be looked at whether what was the time gap between first and second RT, whether they were resectable, and whether they had organ dysfunction. So those patients who had more than 2 years disease-free survival and had a resectable disease, they were classified into class 1. If you give re-irradiation, these are the patients who will go on surviving for a very long time. Those patients who are, but they are not resectable, they were categorized disease-free survival less than 2 years, but their organ function were preserved. They again were categorized into class 2. Time gap, and also had poor organ dysfunction. These were the patients who had very bad results. So giving re-RT is really needs to be, is going to be challenging and not likely benefiting. So these are the three Kaplan-Meier curves for the class 1, class 2 and class 3. So there is a lot of people have been doing SBRT. The SBRT is delivering very high dose in very few. You see, I'm not a big fan of SBRT. I gone through many of the literature. These are retrospective series. You notice that as you increase the dose of SBRT, which you eventually need to do because if you want to give a good radical dose, although your median survival increases, but also your late toxicity significantly increases. So when you compare SBRT results and IMRT, IMRT seems to be doing better, whether it is disease control or late toxicities. Brachytherapy, also forgotten art, it also is one of the most conformal treatment, but it is a difficult procedure to be done for re-irradiation setting because the tissue already is fibrous, difficult to insert needle, but those who can do it, you see that these are few case scenarios where interstitial brachytherapy was done. This is a base of tongue patient. I have also done one surface mold technique for buccal mucosa, very simple to do it. Some enthusiast people have done intra-op brachytherapy. For example, in this case, patient was treated for buccal mucosa long ago, now had recurrence in infratemporal fossa, resected, and then given intra-op radiotherapy. This is another example of intra-op brachytherapy. Some very enthusiastic people have done brachytherapy interstitial for undissectable nodal recurrences. My request will be not to do is, it is not going to make any difference. There are few studies which have found very poor results. These are the results of brachytherapy. You see overall 2 year local regional control is ranging from 30 to 68%, and 2 year survival ranges from 33 to 49%. Proton beam therapy is in vogue. In morning we have discussed at length what is the role of proton beam therapy in newly diagnosed and also in recurrent setting. So I won't go in much detail. So my concluding slide is re-RT today is a feasible, effective, and seems to be having acceptable toxicity provided you use IMRT, you do not use large volume around the primary, plus you do not use elective nodal irradiation. Consider IMRT wherever feasible. Need to go through all the previous radiation records, and RP class by Murray group should be guiding us well, and ultimately patient selection criteria is the key for re-irradiation. So with this, thank you so much. If there is any query, we can discuss. Yes, sir.
Surgeon, my query is very simple.
Yes, sir.
So when we are evaluating a patient for irradiation, one of the questions in our head is, what's the intent? Like, is this essentially a palliative intent, or is this going to be a curative attempt? You showed that Miri group paper which says you can analyze. Does not the size of the tumor and let's say the disease is only local or loco-regional have an impact on the cure rate? I mean, sense would tell me that should be a huge factor.
Yes.
But it doesn't seem to enter into the algorithm.
Correct, sir. It is the volume. When we do radiation therapy, we can measure the volume in 3-dimensional. Larger the volume, results. I mean, there's no, it is even proven for newly diagnosed cases also. Plus, if you have even one node, giving radiation is associated with very bad results. So, curing both primary as well as node by radiation is difficult. So now one question that for a large tumor, whether it is radical or palliative, it is palliative. If it is primary also intact and you have 1 or 2 nodes, then most likely to be palliative. The question is, if you do palliative systemic therapy, what is the advantage? your advantage if you get best of the chemotherapy and best of the immunotherapy, for example, Pembro plus Carbo 5FU, the median survival is around 13 months. So there is a case for REART in those, at least it will do better than 13 months. Not necessarily, but yes. Correct, sir.
So my question is about hypofractionation and re-radiation. Do we have evidence?
So, see, hypo is completely, I mean, big. Hypo, when you say it is in IMRT or SPRT?
No, IMRT.
Okay, in IMRT, we can do hypofractionation to like 2.2 gray, but not a very big, large dose per fraction. It has not been, hypofractionation as such, not been found to be of any use in head and neck cancer. It can be used as a palliative. Hypo has a role when you are delivering as a SBRT.
So the data you have presented when you compared IMRT, when the comparison was IMRT versus SBRT, the results are not very pro SBRT.
Yes,
so that should we, really not prefer hypofractionation?
Yes, we should not be preferring hypofractionation.
Thank you.
Thank you. There is one more question. Sorry?
How to decide on OR constraints in re-radiation?
Okay. Yes, I have done a lot of patients. The good thing today is most of the patients you will be giving radiation, in their previous course of radiation, they would have received IMRT. So the problem, the tackling problem of achieving OR was more relevant when the patient was irradiated with a two-dimensional array last time. Because that time if you give 70 gray and elective neck, most likely you will exhaust all the spine, brainstem, mandible dose. But if the patient has earlier received IMRT and now again you are giving IMRT, trust me, achieving spinal cord tolerance, brainstem tolerance, they are very, very easy. There is no clear consensus on what should be the spinal cord constraint, mandible constraint, brainstem complaint. But take my word, if you are combining both from the previous and the now, for example, previous radiation has given in radical case maybe 25 gray, 30 gray, and 35 fraction, that is like 1 gray per fraction. You can confidently limit your radiation to 10 to 15.
Thank you, sir.
Yes, sir.
While choosing the dose to the organ that you're, the GTB that you're going to treat in the radiation, is there an upper limit of a cumulative dose of the previous radiation and the present radiation? And does it vary with time? For example, you're doing a re-radiation at 2 years' time, doing a re-radiation at 1 year time, doing a radiation at 3 years' time. Obviously, it does go up. But do you have a reference that a student can use?
Some people in their retrospective have quoted that BED is important, cumulative. But in my mind, there is no reason why BED should be, cumulative BED should be important. It is the current dose which we are going to deliver now. If it is a radical case, try and achieve minimum 60 gray. And in 2 years, you can easily achieve 66 gray. At least 66 gray in the radical case. Thank you so much for patient hearing. Yes.
What is your experience with ORNs in radiation cases?
Out of 147 patients, I can give you a vague, roughly, although it is difficult to document ORN because many of the time patient will be handed over to medical oncologist and you will lose the track of true ORN. This is the problem with the late toxicity of re-irradiation. But I guess by literature wise, most studies if you have done with re-irradiation with IMRT, 3%. Thank you.
Thank you, Dr. Parveen Alhawat, for the wonderful speech. Now, I would like to invite Dr. Tanveer Shahid to moderate the panel discussion. He is a senior radiation oncologist, Apollo Hospitals, Kolkata. And the list of panelists, I would like to invite Dr. Ashwini Gopal, consultant radiation oncologist, Indo-American Cancer Hospitals, Hyderabad. Dr. Abhishek B, consultant head and neck surgeon, Apollo Cancer Hospitals, Hyderabad. Dr. Kinjal Shah, consultant medical oncologist, Indo-American Cancer Hospitals, Hyderabad. Dr. Sarat Chandra Reddy, consultant radiation oncologist, Care Hospitals, Hyderabad. Dr. Avinash Chaitanya, consultant head and neck surgeon, Care Hospitals, Hyderabad. Dr. Naga Avinash Bunda, consultant medical oncologist, AIG. I would like to invite all the panelists to come on the stage and to proceed for the panel discussion. Thank you. Over to you, sir.
So good evening. With this, we come to the last by Dr. Sridhar and Dr. Nandita. There are few overlapping things. So to begin with, I'd like to thank Dr. Kaushik, Dr. Sujana, Dr. Nandita, Dr. Vamsi for giving this wonderful opportunity. What I have tried to modify in this panel discussion is not like a typical panel discussion. Since it was a last talk, I tried to make it a bit more interesting. It's more like a mortality meet rather than a panel discussion. And the reason why I am this patient is a true patient, and she was very close relative of our chairman sir of Apollo. So when she was being treated, literally entire Apollo was working for her. So we tried every possible thing. So I just have taken that as a mortality meet. I'm presenting first time with permission from them that I'm presenting this, So to begin with, she was a 57-year-old lady presented with a non-healing ulcer in the left buccal mucosa with a swelling on the left side of the neck. On examination, it was a small tumor, rather 3 into 3 centimeter also proliferative lesion at the left buccal mucosa, with just it was extending into the RMT with a right-sided level 2 lymph node. CT scan, it showed ill-defined enhancing lesions of 3.5 into 3 centimeters on the right buccal mucosa, and with a cervical lymph node at level 1 and 2 on the left side. Sorry, it's not right to the left side itself. The thorax was normal. Biopsy was well differentiated, infiltrating keratinizing carcinoma. The image from Google, not the true representation, because I could not get that image because the patient had passed away and I had to very sensitively take all the images. So, and this was not on the pack, so I had taken it from the Google. So finally the treatment which was offered to this lady was wide local excision, which mandibulectomy, left MRND plus reconstruction with free fibular graft on 1st of September. We'll have to remember the chronological order of the dates because that will be helping us. 1st September 2020. Histopathology, the tumor size came to be 3 centimeters, depth of invasion 13 mm. Tumor was infiltrating lymph node 5/54 positive, minded without ENE. Eventually, it was a PT4A N2B. Current CTRT, standard doses 60 gray 30 fractions with platinum, 6 cycles of weekly cisplatin. So, Dr. Ashwini, you agree with the plan? Whatever we have done till now?
Absolutely. I think I would have omitted cisplatin.
Okay, why so?
There is no extracapsular extension and the margins are clear, so I would rest of the things are.
Okay, so that's a good point. So instead of Dr. Nikhil, Dr. Ashwini. In January 2021, 2 months later, she presented with a small swelling on the left lower neck region. Ultrasound of the neck was suggestive that this could be a doubtful node. FNAC proved to be metastatic squamous cell carcinoma. PET CT also showed that there was a left cervical lymph node at level 5 with a tiny non-FDG abit in the lung lesion, which was likely to be to be a benign tumor. So there was a lymph node and it was on FNAC, it was positive. This was the node which I'm talking about at level 5. To begin with, Dr. Abhishek now. So Abhishek, what next? You being the surgeon now.
Yeah, considering the PET, the lung nodules looks like benign, so I would go with the classical MRND of the opposite side.
No, this is on the left side itself. Left.
Okay.
Left. We have already done the
level
left.
5.
Yeah, left. The disease was also on the left and this appearance is also on the left only.
Okay. Then yes, I would have gone and done a full scale neck dissection again. Means whatever the level 5 which they didn't do, I would have gone and removed it.
So previously the left MRND has been done.
Yes.
MRND we already till 1 to 5, 2 to 5 we already dissected. 2 months later from the radiation again you will be doing the neck dissection on the same side.
Yes. Means it will be more like a supraselective neck dissection.
Okay.
So
Okay.
only that will be more on the soft tissues around the tumor and will be taken.
So exactly the same thing was done. She underwent nodal tissue on 14th of January. PDL1 was negative and it was metastatic squamous cell carcinoma with a CPS score of 0. Dr. Avinash, what is the now exactly this question even I asked Dr. Deepak Sareen also. Like patient had a recurrence on the left side. The left side was the recurrence. Left side again it has been neck dissection has been done. What is the evidence of doing neck dissection on the opposite side, that is on the right side? Is it advocated and is there any evidence to do so?
Sir, as of now, for the present disease that we have, I think it is sufficient that we did the left neck, the node that has been come and we have removed that perinodal tissue and everything. Doing the opposite side neck may or may not be done based on the patient stature at that time, but it is not advocated not in my practice at least.
Absolutely. So even so you are absolutely right, because it is not really, we don't have a level 1 evidence to do so. Same thing Dr. Deepak Sareen had also mentioned, but there are papers from TMH, especially from the Pankaj Chaturvedi's group, where they do it, and even a NHS paper also advocates of doing it. However, they have mentioned the role of SLNB. Specifically 2 years ago from Pankaj Chaturvedi group, they have mentioned that it is routinely practiced in their practice of doing it. However, this paper from Germany, which is a very high volume center, they have said that we don't have an advantage of doing a contralateral neck dissection. So I agree absolutely that in this particular case, of course, of doing so for the opposite necks. Okay.
Sir, SLNB here, how would you do? Like, because you don't have any recurrence in the primary.
Absolutely.
So where would you give the dye to see whether it is going to the contralateral neck or not? So doing an SLNB in a recurrent case is not.
So for the moment, if you forget this case, so can this be a way to avoid a contralateral neck dissection?
Instead, I would do a PET rather than to see if there is any uptake there already. Maybe if there is a recurrence in the primary, then giving an SLNB dye there and seeing if there is any uptake on the contralateral side can be used.
Okay.
If there is nothing in the primary side, then there is where will we give the SLNB?
Absolutely. And we had couple of talks regarding SLNB. There's a steep learning curve, time taking, cost, all those things are involved. So exactly 1 month later, in February 2021, she again noticed swelling on the left side of the neck. Everything is happening on the left side only. Ultrasound of the neck, it showed a neoplastic lesion which was hypoechoic subcutaneously at left level 5. Mind, it was not dermal, it was subcutaneous. FNAC was metastatic squamous cell carcinoma. PET CT, again, it showed a left posterior cervical nodular cutaneous thickening, Hopkins score 4. And there was a benign lesion in the lung, and the final impression was progressive metabolic disease. And this was the lesion which has appeared, and there was also a right lung middle lobe lesion which was a benign. Dr. Nikhil is not there. So instead of Dr. Nikhil, what will you do? Medical oncologist, I mean.
So this disease seems to be aggressive. So I would like to actually, though they are reporting recurrently that lung lesion is benign, but I would like to do at least an FNSC from and at this moment, as it is an aggressive disease, to the mainly in the form of chemotherapy.
Okay, so I'll stop you over there. So that's fine. So you want to investigate the lung lesion also, in spite that it's being called as benign.
Yes,
Absolutely,
yes.
agree to it. They took an opinion from the premier institutions like Tata Memorial and also a surgeon from Mumbai. Both the institutions have told that consider combination of surgery, that is, and with systemic therapy, that is immunotherapy. So exactly what you are saying. So now regarding the surgery part, so what do my surgeons say? Like, we have done a primary surgery, we have already done a neck dissection. Now we have a lesion on the left side.
Yeah, this will be actually, if the, like she said, if the lung lesion is negative, we can reoffer him, means it will be a double super selective neck dissection. We can go resection of that neck.
Kind of a wide excision followed by systemic therapy.
Yes.
Absolutely. So coming on to Dr. Sharath, so now let's assume that the surgeon has done a wide excision and medical oncologists are ready to go for systemic therapy. Since November, the treatment has been completed at CTRT. It is February now. I know that there is no role of re-radiation, but will you think about something? Because one of the surgeons, they did advocate that this patient can be taken up for electron therapy. Will you give anything, or why will you not give?
No, sir. No radiation here.
No
The reason
radiation.
being the time interval is quite short.
Okay.
Not even 2 months, 2.5 months. So in view of that, we won't recommend the radiation.
Absolutely. All the radiation that with such a short period of time, DFI of only 3 months, we will not go for re-radiation. Now, my medical oncologist friend, Dr. Kinjal, role of systemic therapy at this stage, and how will you decide your systemic therapy?
So for this patient, if she has undergone the surgery also third time
Yes,
for that neck
correct.
lesions, and any FNSC was done for the lung?
No, it was not done.
So if the tumor is already removed and that lung, if it is telling that it is benign, I think then I don't have any disease to treat in the body. So at this moment, if the surgery was done and I would like to check the lung, but it is not done, I might not think of starting systemic therapy because I don't have anything to target. And even if I'm doing what later I'm going to achieve, how am I going to compare with the previous things? Better than that, I would like to do some kind of maintenance, metronomic therapy kind of thing that we sometimes do in our patients just to check the progression of.
One thing, Dr. Kinjal, we do understand at this point your disease is extremely aggressive. The biology of the disease is extremely aggressive. We want to give some kind of systemic therapy. It can be empirical, but there is take another opinion from a medical oncologist, and his opinion was to give a combination of chemotherapy and a monoclonal antibody, that is cetuximab, plus taxanes or platinum. And the best thing was that he also mentioned that this is based on two important studies published recently, that is TP Extreme and Checkmate 041. What do you say after this?
So I still continue. Patient, I would have definitely offered the therapy.
See, what's
excision, that third surgery, what sir was telling that.
But that was a very local disease. I mean, still both the surgeons, they do agree that it is still better to take it out rather than to leave it.
But then, sir, I don't have anything to target. What am I targeting? Which disease I'm targeting? It's not yet proven. The recurrence has been already removed.
So
it's kind of palliative surgery that they have done.
Absolutely.
Anything monitor have any symptoms? So
No, I'm not for Kinjal. I'm trying to instigate you.
I'm just trying to,
Because we are in the last talk, so let's instigate each other so that people are awake, So fine.
So what are we trying to give palliative treatment for to palliate her? What are we palliating her?
It's good that you are holding the mic, so this. You proceed now. Role of Foundation 1.
The surgeon, if this patient doesn't have any symptoms to palliate, then I would just observe. Because the lung lesion is not troubling her, and those nodes which are popping up, we have removed them. I would just observe her. And regarding the second question,
yes, Dr. Vamsi, please.
Will you do Foundation 1 and will it help? I don't think so. What will be your approach keeping in view of an aggressive disease? So see, this patient has recurred locally and we have also given her cisplatin. So the very fact that she's platinum refractory within 6 months has come back, that is something which all of us have to live with.
So Dr. Avinash, it was a very good learning experience for me. Apart from being a radiation oncologist, when I was preparing the slides for this, so many things I had to read and learn and try to find it out what was being. Many things which I found that it could have been avoided, and that were rightly pointed about Kendall and you that yes, Dr.
So I actually will disagree. I would have said the third surgery should not have been done. You should have given systemic at that point of time.
Absolutely.
Because the third surgery was an overkill, and I would simply ignore that surgery. I would give a systemic therapy.
Absolutely.
Question is what systemic therapy? Both TP Extreme and the check keynote 048 both have excluded patients who have recurred within 6 months. So at that point, considering that issue, I would be actually okay to go ahead with an immunotherapy. Supposing this patient comes today, even the CPS is 0, even though it is 0, because it's a cisplatin ineligible or cisplatin refractory, I would actually go ahead and give immunotherapy single agent. That would have been my take.
So
that's a wonderful thing.
Yes. The reason for why I said the third surgery, because that lesion was very much close to the brachial plexus, and it's a palliative surgery so that it doesn't infiltrate it. And the patient doesn't have severe mode.
So both the points well taken. So another surgeon now.
You can resect if it is palliative also. No, when it comes back, anyways, you are going to give chemo, sir.
Okay.
This can be done in local.
I mean, what are we palliating is something to look at.
So I had to read up the TP Extreme and the 048, though I did not go into detail. I found it, what is it? So I'll not go into the details now. Anyhow, was done with this patient. She was started on cetuximab and nanoxyl. First dose was given in March 2021. Foundation 1 was also done. On the primary surgical pathology, patient went on opinion from Dr. Jatin Shah and Dr. Alan Ho from US. Also agreed that system will continue, and if she fails on the treatment program, that means they are refractory to cetuximab, she may be tried on immunotherapy with pembro even though the CPS score is 0. And this was the question exactly I asked in the tea break with Dr. Vamsi also. Can pembro be given with CPS score of 0? Medical oncologist over here.
So the trial was designed in a such a way that they included all comers. They later on decided like CPS more than 20 versus CPS more than 1 versus CPS nil.
But the benefit was more
is
in
very almost nil
Nil,
when there is a CPS 0. Correct. New. That is nivolumab is.
Okay, fine. So we'll rush from here now. Anyhow, cetuximab, carboplatin, nanoxyl continued from February till October 21. Interim PET CT was done in May. She was fine. Till October, she was absolutely in a complete remission, we can say. But in October 2021, again, maintenance chemotherapy stopped, but maintenance cetuximab continued. In January, from October, the maintenance cetuximab continued. In January, when the PET CT was done, there was uptake in the operative site, and this lung lesion, what my medical oncologist friend was doubtful that this is something fishy, that had again it has increased in size. Still the patient was kept under observation, which I'm sure Dr. Kinjal will not agree that why she was, and even Dr. Abhishek will not agree that why she was kept on observation, but she was kept on observation. So from October 2021 till May, so 10 cycles had been until May 2022, maintenance rituximab did continue. Vamsi is having a big smile ki what you all have done, but this so Kaushik did not give me that opportunity of that panel. So in May 2022, the lesions in the lung, it grew. There was a prevascular node also. Apart from that, there was a right gluteal region, small lesions had appeared at the right mid back, and it was a progressive metabolic disease. So prevascular node, gluteal node, and at the mid back there was an appearance. CT guided biopsy from the left lung upper lobe came to be as a poorly differentiated squamous cell carcinoma, and FNAC of the right mid back from it I am not aware of. The point was that PDL1, this time from the lung it came to be as a with a TPS score of 85 to 90%. Now how do you yeah, so medical oncologist, yes. So Dr.
yes,
Avinash, how will you proceed now, or Dr. Kinjal, whoever?
Just wanted to ask you, was the PET done, or the, I think if I'm not wrong, the HRCT at baseline did not reveal any lung lesions, right?
No.
Because it makes me, it makes me wonder if we have missed something in the lung in the beginning.
So that was exactly the point. Even we had a discussion.
So because
we
the
went
second
back
primary lung, and that because I could remember the CPS score in the beginning when the
Is
first
zero.
recurrence has occurred was 0.
Correct.
The disease can evolve. So here, I think we'll have to continue with because the TPS definitely is quite high. Because the disease volume is quite high, I would start with combination pembrolizumab and then probably continue pembrolizumab alone as maintenance.
to agree with this regimen, cisplatin plus 5-FU plus 0. In May it was started, and other foundation one was again done. I did not know why it was done. So from May 2022, sorry. Okay. So in May, cisplatin plus 5-FU plus pembro started, and it continued till October. In July, interim PET CT was done, and it showed a regression of the pleural base lesion and a prevascular node. There was a resolution of the surgical bed lesion. But in October, the regression in the lung lesion persisted, but there was a progression of the soft tissue lesion in the costal pleura, that is in the lung adjacent to the fifth, and an appearance of the left alveolus lesion had appeared just adjacent to the second premolar. Dr. Kinjal, would you continue pembro or change now? Because it's a progressive disease.
But this looks to be kind of
Mixed
can
response.
be mixed response.
Mixed
So I have to actually on to repeat a PET. Till that time, I'll just continue the pembrolizumab because we are not left with many options.
Okay.
Later.
Okay.
I'll continue
But-
and repeat a PET again after a month.
But Dr. Kinjal, one thing, that new appearance, that is a left upper
Yeah,
alveolus lesion, that is something, because this is something a new, field consideration you can say. So in view of the mixed response from the recent PET CT, now pembro was stopped. She was started on cetuximab plus nivolumab in November 2022. Sorry? Yes, I'm coming to that. So the thing is that I'll come to that also. So is there now, to the radiation oncologist, will you call it as an oligoprogressive disease, and the role of local therapy as lung lesion is concerned? Would you offer Dr. Sharath?
Sir, actually, initially, first thing I will do is get a biopsy of the alveolar lesion.
Okay.
So I would like to examine that lesion and get a
That
biopsy.
so biopsy was that came to be as a squamous cell carcinoma. The
So,
biopsy was done.
If that has come as positive, I think like I'll agree with Dr. Omti and get a surgery of the primary and the VATS done for the lung lesion.
But surgery for the primary, probably not agreed now because there is already proven lung lesion also. Apparently, she had a metastasis all over. Now, though it has regressed, but still, probably surgeons will not be wishing to do another for the right upper, left upper alveolar lesions. Probably they will not.
Sir, actually, this case will be discussed in MD. But if the surgeon and the surgical oncologist and the ENT surgeon are not.
So the case was discussed in the MDT. The biopsy of the oral lesion was positive, and the lung lesion cut off because every time they are missing the lung lesions, but this time it was something to be concerned of, and this time probably we did not want it to miss because the treatment was happening at Apollo Calcutta, Apollo Chennai, both the places. Lot of confusions were there in between. The confusions, it was like in concordance, but lot of opinions were coming. I should not say confusion. BD, in fact, it is just 87. It is less than what it ideally has to be given. At the same time, the nivolumab and cetuximab continued till January. In January, there was a response as far as the lung lesion is concerned. There was also that it looked like a query residual, and according to the immune resist criteria, it was a partial response. Sorry. Okay. So the patient, by this time till May 2023, the patient finally, when the PET CT was done, it was a complete metabolic response and there was no uptake anywhere else in the body. So this was in May 2023 we have come. Continued 16 cycles of maintenance cetuximab and nivolumab till July 2023. Now I'm asking to all. I mean, I don't ask now. So asking to all, this is an aggressive disease, but this time when the patient had a complete metabolic response, is there anything, a theoretical question, is there anything we could have offered? Pertinent because this patient even went on to take an opinion from Singapore that CAR T cell therapy, TIL therapy, CAR T cell therapy was even, the blood samples were already taken, was sent to Singapore, the things were getting ready, but somehow after that it could not materialize. Was it appropriate to go for all these things, or what is the prerequisite for going for, by specifically medical oncologist, for CAR T cell therapy? We don't have an evidence for CAR T cell in head and neck. We have only for hematolymphoid that we know. But in spite of that, the next slide we have the trials going on in head and neck for.
I think the basic right of the patient to get enrolled to a clinical trial is something which we have been missing from the beginning. So she has every right to actually undergo enrollment to a clinical trial for a promising therapy. If you look at the aggressive nature of the disease, then it looks all the more pertinent that she should exploit the option. Definitely, yes.
Okay. So that was exactly the point which I wanted to make. How many people? Dr. Indra, I don't have an answer to that, I mean, see, the thing was that what Vamsi told that or even probably not. Probably not. Absolutely, yeah. You
could have just added Cetux to Pembro and continued.
So Dr. Niril is making a very pertinent point. The wrong message should not go to the student specifically. That you should just you cannot change just for the sake that patient is a influential person or patient is a patient after all. Anyhow, so with that, I'll be trying to end because unnecessarily the patient even went on to take a proton therapy also, which I completely disagree with this because the proton therapy was given for the left alveolar lesion. The dose which was given was 36 gray in 20 fraction, which is a very underdose. And she also went on to take another, with cyber knife, she took another radiation to the lung mets because that was something which was, anyhow, so after that 2 more drugs were given. One was mab, one was enfortumab. So my medical oncologist friend, if you can just highlight ki what are these 2 drugs and is it. Enfortumab was very interesting because what I could find in Renal, this I found in the Red Journal published this year. Enfortumab published in Red Journal, it means a lot that enfortumab can be given in the recurrent settings. But Avinash is looking at the ceiling. I don't know.
Practically don't have an experience.
Don't have any experience. Yeah.
So these are the phase 2 study. As of now, enfortumab is only approved for the urothelial cancers. It is Nectin-4 ADC, targeting Nectin-4. So head and neck cancers, it's not approved. It's again a clinical trial basis. So maybe
No,
after whatever happened after pembrolizumab with her was, I
yeah,
feel,
yeah.
more of
Yeah,
clinical trial.
so samplimab, what I thought, FDA approved for cutaneous malignancies, melanoma.
Yes,
But
yes.
enfortumab is for classically for recurrent head and neck cancers only. So these are the things. One more, yeah.
Yes,
Yeah.
it's again,
Yes, one more also. Yes.
Pembro, Nivo,
Anyhow.
and then semiplimab.
Yes, sir. Please. Yes, sir. Yes, sir. Yes, sir. Yes, sir. No. Dr. Kaushik, that was, she used to get, I mean, everything was being offered in. Eventually we lost her in the month of May. With that, Indranil, myself, we belong from Calcutta. We also lost hours. More than a month have passed. Nothing has happened. We are fighting for justice. Let's pray for hope. We want justice. In fact, we lost both of them. Thank you so much.
Certain things may be not applicable across the board, but the fact that they have